Characteristic joint deformities like swan neck deformity, Botnius deformity, ulnar drift in rheumatoid hands. What are the investigations we normally ask for? Complete blood picture to see whether the patient has got any anemia, and inflammatory markers, rheumatoid factor, CCP, chest X-ray, X-ray of the hands and other affected joints. You can see in this picture severe erosions in poorly controlled rheumatoid arthritis. Rheumatoid vasculitis, rheumatoid nodules in the lung, and pleural effusion also. Whenever you see a case of SLE or rheumatoid with effusions, first think of the primary etiology as a connective tissue disease, rather than jumping into things like COX and put them on ATT. Rheumatoid nodules over the elbows. And this patient developed drug rash. The patient was prescribed leflunomide. She developed leflunomide-induced rash. Why I'm showing this picture is some doctors use leflunomide like a painkiller for joint pains. So in this patient, she took leflunomide, developed rash. Never ever give leflunomide for people who are in the reproductive age group, because it can be teratogenic. Even if you stop the leflunomide today, it's going to stay in our system for next 3 years. So don't use it in the reproductive age group unless they completed their family. This patient referred to me by Professor Mohandas because the patient has come with joint pains, and he asked me to rule out rheumatoid. So there is no proper inflammatory arthritis symptoms or signs in him. A little bit of tenderness with the hand squeeze. So video was not playing. Actually, when I asked him to walk, I noticed Parkinson's gait. So it's a Parkinsonism presenting, mimicking like rheumatoid hands. So it's a pseudo-rheumatoid. So there are a lot of mimickers in rheumatology. We have to be well aware of it, because some patients, infective arthritis also, like Cox or Hansen's, can mimic like inflammatory arthritis. Vasculitis in a rheumatoid patient. Vasculitic ulcer in a rheumatoid patient. Vasculitic ulcer before treatment, and couple of weeks after started therapy. Sjogren's very neglected disease. Here, if the patient has got Sjogren's, that is sicca symptoms, dry eyes, dry mouth, dry skin, after rheumatoid, we call it as secondary Sjogren's. But if the patient has got Sjogren's symptoms without background autoimmune disease, other autoimmune disease like lupus or RA, it is called primary Sjogren's. Usually, on average, patient comes to us after 2 decades of the onset of the symptoms because of lack of awareness among the medical fraternity. So the common symptoms like dry eyes, and typically the patient tells in Telugu, "Sir, na kallallo isika unnattu feeling undi" ani. డ్రై మౌత్ ఎట్లా ఉంటుందంటే, మన సున్నుండ తిన్నప్పుడు మంచినీళ్ళు తాగకపోతే ఫీలింగ్ ఎలా ఉంటుంది? చచ్చిపోతాం మంచినీళ్ళు తాగకపోతే సున్నుండ తిన్నప్పుడు. అంత డ్రైగా ఉంటుంది నోరు వాళ్ళకి. సో సివియర్ సిక్కా సిమ్టమ్స్. దిస్ ఇస్ ద షెర్మస్ టెస్ట్ వీ డూ టు కన్ఫర్మ్ ద డ్రై ఐస్. సివియర్ డ్రై టంగ్. English people call it a stony dry. Thank you. I think I completed in 14 minutes. Thank you. Now we have a series of some cases brought from our ward and also OP. I thank all the patients who have come here to share your experiences, also teaching the young doctors. Shilpa, you want to start?
Sadguna.
Sadguna.
Good morning, everyone. I will be presenting a few patients who are diagnosed as rheumatoid arthritis. First, we have Mrs. Sadguna. Please. She is a 49-year.
Can I have the IT person here, please? That's right.
She is 49-year-old lady. She came with 2 years history of pain and swelling in multiple joints, involving small joints of hands, wrists, shoulders, temporomandibular joints, knees and ankles. She had early morning stiffness in the joints lasting for about 1 to 2 hours. There was significant difficulty in her routine activities. 2 years back, she was tested positive for rheumatoid factor and her CRP was high, but she took alternative therapy for 2 years with no improvement. In May 2017, she presented to our OP. On examination, she had synovitis of bilateral metacarpophalangeal joints, proximal interphalangeal joints, wrists, left knee and bilateral ankles, and there were bilateral stiff shoulders and there were no deformities of joints. Tender joint count was 25 and swollen joint count was 23. ESR was 56. RF factor was significantly elevated. DAS 28 score was high. She was started on methotrexate and oral steroids. She was reviewed after a month. She had about 80% improvement in her symptoms, and she had only arthralgias of bilateral knee, no tenderness or swelling, and there was significant reduction in the DAS 28 score. ESR was 57. When she came for review, she was happy that her symptoms have improved and she could do her routine activities without any help from others. This is her picture of her hands showing no deformities. Presently, she is on methotrexate and oral steroids.
Continue once in a week.
Yes, sir.
Once in a week.
Yes.
Sorry for the interruption. We'll have a direct video telecasting of this picture clinical symptoms. There was some technical problem. In next 2 to 3 minutes, we'll focus a video of the particular patient. Meanwhile, if you have any doubts, you can proceed with the doubts.
Thank you. So what are the drugs she uses?
She's on methotrexate.
Methotrexate 7.5 once in a week.
Initially, it was started as 7.5 mg once a week, and now it is increased to 15 mg once a week.
Once in a week.
Yes, sir.
So no other NSAIDs now?
Presently, she is not taking any NSAIDs.
So that's one drug now it is.
And she is on deflazacort minimal dose.
So that's also she is continuing?
Yes, sir. We'll be stopping that in a few days if she becomes better.
Thank you.
This is the picture.
Next.
Just to tell you that very basic treatment. How to see they can get better. She came on the 31st of May. Now this is 9th July. So May, June, July, within 2 months. Just I will ask the patient how she is feeling. మాట్లాడండి లేకపోతే హస్బెండ్ మీరని మాట్లాడతారా? మాట్లాడండి.
ఫస్ట్ ఎలా ఉన్నారు ఇప్పుడు ఎలా?
అందరికీ నమస్కారం అండి. నేను 3 years బ్యాక్ చాలా బాధపడ్డాను ఈ నొప్పులతోని, జాయింట్ పెయిన్స్తోని. అసలు ఏ పని చేసుకోలేకపోయాను. ఇప్పుడు 1 month అయింది ఇక్కడికి వచ్చి. నేను ఆ 1 monthలో చాలా బెటర్గా ఫీల్ అవుతున్నాను. 15 daysలోనే చాలా చాలా బెటర్గా ఫీల్ అవుతున్నాను. ఇప్పుడు బాగా పని చేసుకోగలుగుతున్నాను. అసలు నాకు నొప్పులు ఉన్నాయా, అసలు నేను నొప్పులతో బాధపడ్డానా అని అనిపిస్తుంది. ఇప్పుడు అంత బాగా క్యూర్ అయింది.
So she's on methotrexate 20 milligrams, sir, folic acid 10 milligrams, and steroid 3 milligrams once daily, tapering doses. Probably from next month we're going to stop the steroid, and I don't think she's taking painkiller. Painkiller vaatledu kadamma?
Folic acid is 10.
Yeah, we use it.
Arthritis elsewhere, and she was started on hydroxychloroquine and leflunomide, but she used to have 3 per week and HCQ. In June 2000, initially when she came, she had pain and swelling in the metacarpophalangeal joints and proximal interphalangeal joints and wrists and knees, and she had bilateral stiff shoulders. Her rheumatoid factor was high and ESR was high. The dosage of methotrexate was increased to 15 mg per week, and she was given a stat dose of injection dipomedrol, following which she became better. Presently she doesn't have any tenderness. She has minimal deformities of the metacarpophalangeal joints of right first metacarpophalangeal joint, first second and third metacarpophalangeal joints. There is no tenderness, no erythema. There is minimal swan neck deformities of the fingers.
Thanks, sir.
After a week of dipomedrol and increasing the dose of methotrexate, she became better. Patient can
మీరు మాట్లాడతారమ్మా?
అది 50th ఇయర్లో మెనోపాస్తో వచ్చాయండి నొప్పులు స్టార్టింగ్. పొద్దున్న ఏమిటో అంటే నాకు తెలియలేదు, అవేర్నెస్ ఏం లేదు కదా. ఏదో ఫస్ట్ ఇనీషియల్గా మోకాళ్ళండి, చాలా చాలా బెడ్ రిడన్ అయిపోయాను మోకాళ్ళ నొప్పులతోటి. తర్వాత డాక్టర్ దగ్గరికి వెళ్తే ఆస్టియో ఆర్థరైటిస్ అమ్మా, ఇది నీకు మెనోపాస్తో వచ్చిందని అన్నారు. తర్వాత స్లోగా డిటెరియేట్ అయిపోయాను, డిటెరియేట్ అయిపోయి బెడ్ రిడన్ అయిపోయాను. తర్వాత నెమ్మదిగా షోల్డర్స్కి వచ్చింది, దీంతో పాటే వచ్చింది షోల్డర్స్కి. సో ఏమీ చేసుకోలేకపోయేదాన్ని, ఏమిటో అనుకున్నాను, అసలు తెలియలేదు నాకు ఇలా వస్తాయని. అండ్ వీఆర్ 4 sisters. మా ఎల్డర్ వన్ ఈజ్ రొమటైడ్ హార్ట్ పేషెంట్. షీ పాస్డ్ అవే, 2 valves రీప్లేస్ చేశారు. షీ పాస్డ్ అవే ఆఫ్టర్ 10 years. మై థర్డ్ సిస్టర్ ఆర్కే రావు గారి పేషెంట్ చాలా రోజులు, అది కూడా రొమటైడ్ ఆర్థరైటిస్తో 10 years బెడ్ రిడన్ అయిపోయి షీ పాస్డ్ అవే ఫైనల్లీ ఇన్ ఎ వెరీ ప్యాథటిక్ స్టేట్. పెద్దక్క రొమాటిక్ హార్ట్ కాదండి, హార్ట్ ఏదో 10 years అప్పుడు జ్వరం వచ్చి తర్వాత 2 valves రీప్లేస్ చేశారు. థర్డ్ సిస్టర్ యూఆర్కే గారి పేషెంట్ చూడిపోయింది. నేను ఐఎమ్ ద యంగెస్ట్ ఆఫ్ ఆల్. సో ఇది వచ్చేసరికి నాకు మా సిస్టర్ పోయేసరికి ఇంకా సైకలాజికల్గా కూడా డౌన్ అయిపోయాను నేను. సో ఆయన దగ్గరికి వెళ్తే ఇది ముందర ఆర్థో ప్రాబ్లం అన్నారు. ఆర్థో డాక్టర్ దగ్గరికి వెళ్తే ఆయన ఆ రోజున హీ వాజ్ నాట్ అవైలబుల్. సో వెళ్తే ఆ రోజున ఎవరో సరే తీసుకెళ్ళిన డాక్టర్ పోయిన ఉన్నారండి, ఆయన జనరల్ ఫిజిషియన్, ఆయన చూసి చెప్తారంటే ఆయన చూసి ఇది రుమటాయిడ్ ఆర్థరైటిస్ అమ్మ, దీనికి డిసీజ్ మోడిఫైయింగ్ డ్రగ్స్ అని ఉంటాయి, అది డాక్టర్ శశికిరణ్ అని యశోదాలోనండి, ఆయన ఈ హెచ్సిక్యూ అవి రాసిచ్చారు. హెచ్సిక్యూను ఫాలిట్రాక్స్ అవి వాడాక చాలా తగ్గిందండి. అది ఇంక దీనికి ఆల్టర్నేట్ లేదు, మోకాళ్ళ నొప్పులకి నువ్వు ఆపరేషన్ చేయించుకోవాలి, ఇంకొక ఆల్టర్నేట్ లేదు, తగ్గవు దీనికి అన్నారు. అంటే అని ఆయనే రిఫర్ చేశారు గురవారెడ్డి గారికి. 2009లో రీప్లేస్ చేశారండి 2 నీసు రీప్లేస్ అయ్యాయి. తర్వాత ఈ డ్రగ్స్ వేసుకున్నాను, నెమ్మదిగా తగ్గిపోయాయి, నాకు ఇంకేం ప్రాబ్లం లేదు, డే టు డే పని చేసుకునేదని. కానీ ఎప్పుడు కూడా ఎక్కువ స్ట్రెయిన్లు ఏం పడవండి, ఇమీడియట్గా జ్వరం వస్తుంది. ఎక్కువ స్ట్రెయిన్ ఏదైనా నా రొటీన్ తప్ప ఏదైనా ఎక్కువ పనులు చేసుకుంటే చేయలేను, జ్వరం వస్తుంది. సరే అయిపోయాక మళ్ళీ ఒక 20 డేస్గా నొప్పులు పెడుతున్నాయి. ఈ షోల్డర్స్ చాలా ఇదైపోయాయి. మొన్న సోమవారం వచ్చానండి డాక్టర్ గారి దగ్గరికి, లాస్ట్ సోమవారం ఇస్తే ఆయన మందులు ఇచ్చారు. మందులు ఇస్తే ఇవాళ సండే కదండి, రేపటికి 1 వీక్ అవుతుంది ఆయన దగ్గరికి వచ్చి. చాలా చేంజ్ ఉంది, చాలా హాయిగా ఉంది, ఇప్పుడు చాలా తగ్గాయి నొప్పులు. నీరసం వెళ్ళలేదు, నొప్పులు తగ్గాయి చాలా. షోల్డర్ అసలు కదపలేకపోయాను ఆయన దగ్గరికి వచ్చినప్పుడు. సార్ డాక్టర్ గారు మా సిస్టర్ గుర్తుండి ఉంటుంది, అన్నపూర్ణ అని ధూళిపాళ్ళ అన్నపూర్ణ అని, షీఈ్ మై ఓన్ సిస్టర్, రుమటాయిడ్ ఆర్థరైటిస్ పేషెంట్. మీ దగ్గరికి వచ్చేది ఎప్పుడు కూడా, మీ పేరు చెప్తూ ఉండేది నాకు. సో అట్లా అదండి పరిస్థితి. ఇప్పుడు 1 వీక్లో చాలా తేడా ఉందండి డాక్టర్ దగ్గరికి వచ్చాక. అండ్ కదండి, థ్యాంక్ యూ వెరీ మచ్.
Thanks, Amma. Mr. Venkat Durga Prasad garu is 56-year-old male. Yes. Sir? We combined, sir. At this age, actually, they will have both osteo and rheumatoid. But what I'll tell to everyone is, if we actually strictly treat rheumatoid, we don't need replacement unless she has got a severe osteoarthritis.
This is the case of rheumatoid arthritis.
She is a rheumatoid patient, sir.
Knee, but it's unlikely to start with
The later on, other joints were affected. Now you can see that she has got finger joint. Rheumatoid plus ONEs, sir.
Sir, how do you decide the dose of Polytrek? Because earlier case 20 mg, now 7.5 this day.
So usually we start with either 10 or 15 milligrams. Then every month we escalate the dose up to 25-30 milligrams. Then if necessary we may have to add other disease modifying drugs. The average dose we use 50 milligrams, sir, to begin with.
Not start from high dose and go down?
Oh, no, sir, no. Slowly escalate.
Low and
Actually, in England, they start with 7.5 milligrams. Like some people actually start with 2.5. Every week, they increase it, up to 15 milligrams, then wait and see, then add extra 5 milligrams every month. But I found 15 milligrams. Straight away I start 15 milligrams in my clinic, starting dose, because they're very slow acting. So meanwhile we take the help of steroids, either oral or intramuscular. If it is intramuscular, we give once in a month for first 2-3 months.
Sir, single dose 15 milligrams or a divided dose?
Usually I tell them to take at one time, sir. Some people take morning 1 tablet, evening 1 tablet, like that. So Mr. Durga Prasad garu, he is a new patient to us. He is not on any medication. Now we have to prescribe. Please focus on the hands. He's 56, joint pains and swellings for 3 months, early morning stiffness for more than 1 hour. He's got a very stiff shoulders. Chetal paikattanni, shoulders daggara. So he feels stiffness as especially more in the morning. And he has got synovial inflammation in the elbow joints. You can see both the wrist joints and MCP joints and few of PAP joints. And also he has inflammation in the knees and ankles. And his ESR was 86. He is rheumatoid factor negative. So this is early rheumatoid arthritis. Actually, if we see any case like this, early onset, with the latest modalities of therapy, they go into remission very quickly in 4 to 6 months' time. Then we can maintain like that, and we don't see any future deformities, and they don't develop any further complications. So we have to catch the disease very early like this. So just to show you that how early rheumatoid looks like, any symmetrical polyarthritis is rheumatoid arthritis. There are other differential, but the basic point is that symmetrical polyarthritis. He is rheumatoid factor negative. So at the time of diagnosis, 20-25% of the patients can be rheumatoid factor negative. Over a period of time, around 10 to 15% of the patients get seroconverted to rheumatoid factor positivity. So roughly around 10% would be seronegative throughout their life.
ఈ మోకాలరికి 1 year అవుతుంది సార్. మందులు వాడినప్పుడు ఈ కొంచెం తగ్గింది, పర్వాలేదు. తర్వాత 4 months నుంచి మొత్తం ఎన్ని నొప్పులు వచ్చిన స్టార్ట్ అయింది.
ఫస్ట్లో ఈ చిన్న జాయింట్ నొప్పులు లేవండి?
అప్పుడు ఫస్ట్లో లేవు సార్.
ఇప్పుడు ఫస్ట్ మోకాలు స్టార్ట్ అయింది,
మోకాలు స్టార్ట్ అయింది సార్.
తర్వాత చేతులకు వచ్చింది.
తర్వాత మోకాలు అరిగింది సార్. ఇది ఎక్స్రే అరిగింది అన్నారు, మందులు వాడాము.
దానికి దెబ్బ ఏమైనా తగిలిందండి గతంలో ఎప్పుడన్నా? మోకాలు మీకు తెలిసి మోకాలుకి దెబ్బ ఎప్పుడన్నా తగిలిందా? తగ్గలేదు. సో ఇది వచ్చింది అరిగింది అన్నారు. సో అట్లా మందులు వాడుకుంటాం.
మందులు వాడాము 3 months పైన వాడినాక తగ్గింది, కొంచెం ఫర్ రిలీఫ్ వాడుతుంది, తగ్గింది. రిలీఫ్ అయిపోయిన తర్వాత మళ్ళీ నొప్పులు స్టార్ట్ అయినాయి సార్. నొప్పులు స్టార్ట్ అయినప్పుడు న్యూరాలజిస్ట్ దగ్గరికి వెళ్ళాం సార్. ఒకవేళ న్యూరాలజిస్ట్ దగ్గరికి వెళ్తే ఆయన టెస్టులు చేసి న్యూరాలజీ నా ప్రాబ్లం ఏం లేదు, అంత ఓకే అన్నారు సార్.
అప్పుడు ఈ నొప్పులు లేవండి? ఈ చేతుల నొప్పులు ఏమి లేవు?
నొప్పులు ఉన్నాయని ఆయన దగ్గరికి వెళ్ళాం సార్.
ఇప్పుడు చెయ్యి వాసింది చూడండి, ఈ రిస్ట్ దగ్గర, అవి అంత ముందే న్యూరాలజిస్ట్ దగ్గరికి వెళ్ళేటప్పటికే ఉన్నాయండి?
ఈ నొప్పులు న్యూరాలజిస్ట్ దగ్గరికి వెళ్ళకుండా ఉన్నాయి సార్. ఉంటే ఆయన దగ్గరికి వెళ్ళి ఎక్స్రే తీశారు, బ్లడ్ టెస్టులు చేశారు, అన్ని చేసి అంత నార్మల్ గా వచ్చినాయి సార్. అన్ని
ఎముకలు అరిగిపోయిన నొప్పులే అంటా ఉన్నారా? ఎముకలు అరుగుదల మీద నొప్పులే అంటా ఉన్నారా?
ఆయన ఏం చెప్పలేదు సార్, అంత నార్మల్, నరాలది ఏం సంబంధం కాదు అని చెప్పారు సార్. మళ్ళీ మళ్ళీ దీని దగ్గరికి వెళ్ళాను, మన ఆర్థో దగ్గరికి వెళ్తే ఆయన చూసి ఈ ఆర్థో ప్రాబ్లం కాదు, జాయింట్ పెయిన్స్ ఉంటాయి మీరు అని చెప్పి మన రొమటాలజిస్ట్ దగ్గరికి వెళ్ళమని చెప్పారు.
ఆయన స్ట్రైట్ అవే చూడగానే రొమటాలజిస్ట్ గారి దగ్గరికి వెళ్ళండి అని చెప్పారా?
అవును సార్.
సో తర్వాత సార్ దగ్గరకు వచ్చి కలిసి మీ ఎక్స్పీరియన్స్ మాట్లాడు.
Any value of ACCP in this case, sir? Because
yes. Yeah, it's a good point, sir. So at this point of time, we may ask for CCP if the patient can afford. It's not mandatory. For him, I don't ask because I know his condition.
Suppose if he can afford.
Yeah, yes. When rheumatoid factor negative, obviously we ask for CCP.
So in this case, you expect the antibiotics will.
And yeah, CCP would be most probably positive in this case.
Suppose even with the positive antibodies, we can go straight away to the treatment.
Yes, sir. Again, so I'm stressing, rheumatological diagnosis or clinical, the laboratories will guide us, help us extra, like if he has a rheumatoid factor CCP is positive, then extra evidence to say that he has got rheumatoid. Thanks, Andy. Which one? It varies with the lab. A minimum around 1200 to 1700, I think.
Is available in the disposable kits or any special machineries necessary for taking this?
No, sir. Nowadays is available in all laboratories. In all random.
She is a 78-year-old lady. She had a 10-year history of joint pains, mainly affecting small joints of hands, wrists, and elbows. She had prolonged EMS and dryness of mouth. She was not diagnosed for last 10 years, and she was being treated symptomatically elsewhere. She has developed severe deformities of hands. Now she presented to the rheumatology OP.
Actually, she is a untreated chronic rheumatoid arthritis. It is a burnt out disease. Almost 20 years she was symptomatic, but due to fear of drug side effects, she didn't continue her treatment. She was started on methotrexate and she took only for 1 month, but somebody has said that it is associated with lot of side effects. That is the reason she didn't continue the treatment. Later she shifted to alternative medicine, but since almost 10 years she is not under any treatment, and finally this week she came with this type of deformities. The purpose of keeping this patient is of late we are not seeing a rheumatoid with such deformities. The purpose or the aim of treatment of rheumatoid is to prevent such deformities. So because she was not treated for this many years, she has landed upon by these complications. And one more important thing in her is she is at risk of some extra-articular manifestations. Though it is a burnt out rheumatoid, but still we are planning to treat her to prevent the extra-articular manifestations of rheumatoid arthritis, be it a cardiovascular or be it a vasculitic manifestation or be it any other extra-articular manifestations in her. If you can see, she had a classical deformities of all the deformities of rheumatoid. This is called as a Z deformity. Kadapadu. This is a classical Z deformity of the thumb. These are the metacarpal subluxations which we really don't see in properly diagnosed and properly treated cases. This is if you see this is a radial deviation of a hands with ulnar drift. This is called as a Z deformity of the hand too. And as she had metacarpal dislocations, we are not able to observe other type of deformities, but this is a bottlenose deformity in her, and she doesn't have any swan neck deformities. And if you observe closely, there is a slight flexion of the DAP joint of her, but this is not a classical swan neck deformity in her. You can also see an ulnar styloid prominence in these patients. These generally we see in even normal patients, but this is also a described feature of a deformed rheumatoid arthritis. And in such patients, we also have to see for any evidence of nodules. Generally, we see nodules on the extensor aspects of these elbows or over the occiput region or over the shins or tendoachilles, but fortunately she doesn't have any nodules. So by seeing her, what we insist you is please diagnose rheumatoid. Start the treatment as early as possible, only to prevent such situation. Apart from starting the treatment, you also should counsel the patient not to have a fear of the side effects, because all these DMARDs are reasonably safe. After all, what happens if a patient develops side effects? It may affect liver, it may affect kidney, or it may affect heart or any other part of the body. But ultimately, untreated rheumatoid do affect all these organs. So once these organs are affected, we cannot give any drug which a patient desires at that point of time. So this is a lesson for all of us to treat the rheumatoid as early as possible. Thank you, ma'am.
So does she have any deformities in the knees, Prasanna?
Yes, sir, she had OA, but I cannot disclose. That is the reason I am not showing OA of the knees.
The other thing is, what is the cause for prominence of the head of the ulna? Is it something to do with the inferior ulnar joint?
No, sir. As per, there will be a synovial destruction of the bones, and as she will have the drift, so that the ulnar styloid will become prominent. That is the reason we will appreciate this ulnar prominence more so in rheumatoid patients than in a normal patients.
Madam Prasanna, what medications is on now?
As of now, no, she visited me only. She is the first visit, sir. She have to review with all the baseline investigations. I am planning her to start on methotrexate and no role of steroids in her. because the disease is not active, I'm not planning to give her steroids, only methotrexate. నేను మీకు రాసిస్తాను.
Sir, you asked some question about neurologist. Neurology, he went to the neurologist. So actually, before the rheumatology patients visit us, usually they either go to a neurologist or an orthopedician or an alternative therapist. Rarely they come to us directly. But in neurology, if somebody presents with bilateral carpal tunnel syndrome, think of something like rheumatoid. And about alternative therapies, actually I saw some doctors telling the patients that there is no treatment for your arthritis in allopathy, please go to homeopathy. So at least one point I would stress is, now with the latest modalities of therapy, patient can lead normal life. Please come, sir. This is Dr. URK's patient, Mr. Champalal. Thank you, sir, for coming here.
He is a 70-year-old man. He is known case of rheumatoid arthritis for last 30 years, and he has been on treatment for last 30 years, but he had severe deformities of hands with secondary osteoarthritis of knees and hips. He underwent knee replacement few years ago. Now he presented with non-healing ulcers over right leg and right second toe for last 8 months.
अंगुली का जो है ना,
That's fine, sir.
He's not a diabetic, sir.
కొంచెం ముందు జరపండి, కాలు ముందు పట్టినారు.
ఎన్ని రోజుల నుంచి ఉన్నాయి సార్?
8 months.
this is from last 8 months. But before 3 years also he had, but after 2 or 3 months it healed automatically.
He's ambulatory. He's walking.
Yeah, with walker. With help only he can do it. He had a knee replacement about 7 years back in 2010.
That has helped him?
That has helped him. Knee replacement has helped him, but now he is hip. So presently we are not thinking of the replacement since his age is of 71 years. And he is also of the opinion that if I am completely bedridden only, then I will go in. He was completely bedridden because of knee about 7 years back. For that time he has gone with a knee replacement of both the knees. He was able to walk it and he was able to find it. His generally arthritis is nearly about 30 years back. And started with the treatment of the eyes. Generally, his arthritis. I don't know what is the. He had a reaction in his eyes. So he went to Delhi to Dr. Agarwal's clinic. He told to take Mosami juice or something like that 3 or 4 times a day. So he had taken about that one for 2 months continuously, 4 times a day. That has affected his. According to us, I don't know about the doctor's opinion or not, but according to us, it affected all these joints and all. So we were residing in Assam, Tezpur. So the climate was also very wet there, and nearly 5-6 years we had some Ayurvedic medicines, ashwagandha and all the things. In that way we had it, and it was he was unable to walk also. He was in his wheelchair only when we brought him to Hyderabad. That time in the year 94, we met Dr. URK Rao when he has recently started his Deepthi Rheumatology Center at Lakrikapul. So that time he have given him some gold injections. That time it was, and with that he was completely able to walk. His wheelchair was removed, his walker was removed. He was completely able to climb the chairs also. But after that again he was in the service, so he went to Assam after 1 year. In Assam again, that time the gold injections had some reactions in his skin. So after that we stopped it. But he was able to do his completely works and all, because when he came from Assam he was completely in the wheelchair. But after that he was able to do it. In the 2000 year it was prescribed to do both the knee replacement and hip replacement also. but we thought only to do it when it is completely bedridden or any then only. And this ulcer, it was nearly about 3 years back it has come. Yeah, but after 2 or 3 months of treatment, it has been removed. But this time, even after 8 months, till now it was not there. So we met again Dr. U.R.K. Rao. Only the problem what is with my father was that he has stopped visiting Dr. U.R.K. Rao from last 5 years. 5 to 6 years. He told that this is going on. We are taking methotrexate. He was taking about 10 mg per week from last nearly about 18 years. From last 18 years.
Raise the shoulders. Raise your both shoulders.
No, it is not that much.
Flex your elbows. Bend your elbows.
Yeah.
So the main idea is to present this case, sir. It's got rheumatoid vasculitic ulcer. If you look at the joint, actually, those are deformities, but there is no active inflammation in the joints. So point out disease. So actually, disease in silent phase, but still they can develop vasculitic ulcer. Typically, actually, vasculitic ulcer develop when they have got arthritis disease under control. So suddenly it flares up in the vessels. They get vasculitic ulcer, and it's actually a bit of resistant to therapy, but with the proper therapy, these vasculitic ulcers will resolve.
What is the therapy you give for that?
We have kept him on pulsolimadol and cyclophosphamide monthly injections for 6 months.
अंगुली का जो है
यहाँ भी आ गया
ये क्या है इसका हड्डी का ये अलग है वो अलग है
So this is one of the longest. He's a very sweet patient. Follows the advice regularly, but somehow because of his schedule in the office and others, he couldn't come last 5 years. So this shows us two things. With an appropriate therapy, he could survive for last 30 years. When we were students in Delhi and then in NIMS, when we were in the faculty, the lifespan is given only 20 years. But with an appropriate therapy, they can have a normal lifespan. But of course, the joints which we need to have repair as age advances, age plus rheumatoid arthritis. So both will go in situ, then they will have problems this way. But now, he developed the ulcers. Since we don't have facilities to treat effectively, we took the help of Sarath Chandra Mouli and his team, and it's improving. When I saw that, actually it was very angry looking. Now it is a bit better, but it takes time. Here your age is also against him. The vasculature, the blood circulation, everything would be more compromised. So, yeah, Farisa to theek hai, but it takes time.
After taking methotrexate for last nearly about 18 to 19 years, then also he does not have any side effects. His BP is normal, his sugar, only BP problem has started about 1.5 years back, but his sugar is normal. All other testings, we are doing it regularly 6 months, all it is normal.
So this tells us one more thing. So we need not worry about the side effects. Though regular monitoring is essential, like what he was doing. Many of us actually worried about the side effects of the drugs rather than the side effects of the disease when it is prolonged. See, methotrexate is one of the ones which he didn't get any complication, in fact. This is a complication of the arthritis.
He's on steroid now, sir?
He's on pulsolimadol, sir. He's receiving third dose today. Excellent, sir. What he's told is very important. Dr. U.R.K. said about methotrexate, not to worry. Because even whatever the drug comes to the market, the new biologics, whatever, they'll be tested with methotrexate. One arm methotrexate, the other arm would be like the new drug. So still, it is the gold standard drug. Whenever we say case like this, belongs to a doctor's family, I get a call. I think probably same experience, sir. Doctor, please don't prescribe methotrexate to my parents. So it's a myth actually. And because everybody thinks it's an oncology drug, it's not. I tell my patients, to build a small house, you need a brick. To build this big building, 17th floor building, it also need a brick. So methotrexate, we use it in nanodose. In oncology, they use megadoses. So not to worry about methotrexate toxicity.
So
very useful drug.
What are the likely complications you expect, and you advise us to follow these patients with methotrexate, sir?
No, usually as long as they are under strict monitoring, sir, we hardly...
And what monitoring, sir?
We monitor complete blood picture, and I don't do complete LFT, usually SGPT is enough. And
how often, sir? How often? This?
Initially monthly for 6 months, sir, followed by once in 2 months, after a year, once in 3 months, and we prolong like that.
The main problem is bone marrow suppression and hepatic dysfunction.
No, bone marrow suppression is unlikely. If you take the hemogram every month, initially, first 3 to 6 months, then once in 3 months. Then the liver functions, SGPT essentially we do, because it's one of the important parameters, once in 3 months. And then serum proteins sometimes. Creatinine if the patients are NSH.
We cannot depend on bilirubin or...
No, the SGOT, SGPT. Enough, sir.
If you have any...
No, if the thing is, jaundice is the thing we can see even without... testing the serology.
No, actually it's too late, sir.
Yeah. So that is what...
Yeah, bilirubin, the elevation of bilirubin is too late.
Yeah. So that's...
Like in lupus nephritis, we look at the urine to see whether there has got a proteinuria and CAS. We don't look at creatinine. We see creatinine, but the important one is urine. Like that here, we don't do a complete LFT, just SGPT is enough.
The earliest marker. SGPT is the earliest marker.
Thank you, sir.
And the other thing about the said about bone marrow, we hardly see anything nowadays like that. We see in patients by mistake, for example, in this age group, we newly prescribe, is the weekly they take daily. Then they develop bone marrow suppression. If they take as per the prescription, very rare to see that.
So for what are we looking for CBP?
Cytopenias.
Cytopenias because of? Methotrexate causing hemolysis or bone marrow?
No, bone marrow suppression, but in our clinical practice, we don't see that. As per the protocol, we have to do all these things to avoid
because they may also have other drugs, like NSAIDs, low-dose steroids, chloroquine. So it's essential to see all of them.
In this case, because it's a weeping long ulcer, any vascular studies have been done, sir?
Yes, sir. CT peripheral angiogram has been done. It doesn't show any significant arterial disease, and venous Doppler was also done. It was normal.
So it has been done, sir, seen by our vascular surgeon. There's nothing significant. So clinically, it is rheumatoid vascular ulcer. Sir, sorry, sir, we have to move on. We have one more case. Thank you, sir.
Thank you.
So no role of antibiotics?
Actually, we do
parental.
We are giving, I think he's an augmentin, just to, not to have any infection there.
Sir, the reason for this ulcer is?
Rheumatoid vascular ulcer, sir. Vasculitic ulcer.
Vasculitis.
Yeah.
It's endothelial dysfunction. Vascular.
Yeah.
Dysfunction. So any other part has been affected or only?
In this case, only cutaneous involvement, sir. It may affect other organs also. Like I told example, scleritis. Rarely, the first presentation would be scleritis in rheumatoid. Only few patients, I can count them on fingers, maybe have 3-4 patients. First presentation is scleritis, which is equivalent to vasculitis. And she is also another patient with vasculitic neuropathy.
She is a 28-year-old teacher. She had 3 months history of polyarthritis involving small and large joints. She presented to the rheumatology OP in May 2017, that is 1 month back. Then she had severe swelling, tenderness in all joints. Rheumatoid factor was positive, and she was diagnosed as rheumatoid arthritis and was initiated on methotrexate treatment. After a month, she became better. Her symptoms improved, but for
కొంచెం పైకి తీసుకున్నాను అలా వెళ్ళి లాగుతున్నాను ఆయన పైకి పట్టుకోమా మా ఉడిగాను years later, she developed neuropathy symptoms in both the legs.
Dr. Sarath, why she should develop foot drop?
It's vasculitis, sir. Okay, yeah. Rheumatoid arthritis patient developing vasculitic neuropathy.
So resulting in foot drop.
Foot drop.
Common peril nerve getting involved.
This is a different phenomenon. This is a different phenomenon.
No, sir. Involving the skin and the nerves. Vasculitis involving the skin. Cutaneous vasculitis and neuropathic vasculitis.
Is it vasculitis usually late complication? No?
Yes, sir. You are right. Yeah. For example, Champalel is there. Yeah. It's very rarely we see like this. You are right.
Young and very early complication.
Yeah.
What should be the cause for such an early complication?
No, we didn't actually expect that to happen in her. Rarely we see vasculitis in early stages like this.
Possibility of drug reaction there?
No, sir. No. No, we seen by already our dermatologist. We did biopsy. We haven't got the reported, but this is a case of rheumatoid vasculitis affecting the skin and the nerves.
So the mononeuritis multiplex, you might have heard it. So it's one of the features of rheumatoid vasculitis.
How many years?
ఏంటిదండి నాకు నొప్పులు మేలో వచ్చాను సార్. వచ్చినాక ఇక్కడ జాయింట్ పెయిన్స్ చాలా, అసలు హ్యాండ్స్ ఇట్లా పైకి లేపలేకపోయేదాన్ని. ఎప్పుడు లేదు సార్ నాకు. రీసెంట్గా ఏప్రిల్ నుండి కొంచెం లాస్ట్లో స్టార్ట్ కాగానే అసలు ఏం చేత కావట్లేదు, కాళ్ళు చేతులు అసలు లేపనీకి వస్తలేదని ఇక్కడికి వచ్చేసాను సార్ దగ్గరికి. మేలో వచ్చేసాను. మేలో వచ్చేసి ఒక 2 months వాడగానే నాకు మొత్తం హ్యాండ్స్ గిట్లా కొంచెం ఫ్రీ అయింది సార్. పడిపోవడం ఏం లేదు సార్. ఒక 15 days 10 days అట్లా ఉంది సార్. ఈ ర్యాష్ వచ్చి కూడా 10-15 days అవుతుంది సార్.
Sir, as an answer to your question, this young female with arthritis and neuropathy, which is odd looking for rheumatoid, so definitely we have to exclude other causes like lupus. We have excluded lupus in her, but as all patients do not manifest with the similar complaints or a similar clinical manifestation, there are some exceptions to every case presentation, and she fits into that group. She's not a lupus. She is properly diagnosed rheumatoid with a rare presentation. I mean, as per the onset of the rheumatoid and as per the presentation, she is a rare case of rheumatoid with a vasculitic patient has a very high titer positive rheumatoid factor, or if she tests positive for anti-CCP, though many books are not quoting this anti-CCP positivity, and very severe arthritis at the onset of disease with a high inflammatory markers, these patients are at risk of development of vasculitis during the follow-up period. We cannot say that she or he will completely develop vasculitis, but the risk is there. So it should alert, these factors should alert us to keep a watch on every patient, whether this patient is going to develop vasculitis or not. So we have to keep all these factors in the back of mind for examination in each visit. So not only assessing the disease activity in terms of tender joints or swollen joints, we also have to look for any other indications leading to extra-articular manifestations. The common indication being asymptomatic petechial or a purpuric type of thrush. It is like a danger signal for these patients, warning that these patients are at risk of developing some complications, like a danger sign. So by seeing this type of cutaneous manifestations, we should alert the patient, and at the same time we should also alert ourselves.
Sir.
No, sir. We didn't think of Hansen's because the presentation is rheumatoid and she's rheumatoid factor positive.
Duration
and we have
is so short, only what she's saying is less than 6 months.
No. Because we are seen by our dermatologist and our neurologist also. We do have Hansen's in our clinic, but her clinical scenario is not fitting into Hansen's. And after therapy, sir, it's I think the day 3, she already noticing some symptomatic improvement. And కనిపిస్తుందమ్మా?
కనిపిస్తుంది సార్. నడవగలుగుతున్నాను సార్.
ఈ కాలు కొంచెం డిస్టర్బింగ్ ఉందా, అది మీకు మార్పు గమనించారా మందులు మొదలు పెట్టలేక?
మెడిసిన్ వాడినాక లేపడం చాలా తక్కువైంది సార్. వాకింగ్ కూడా కొంచెం మంచిగా
సో ఇట్ ఇస్ నాట్ duration related to cause this foot drop. So she may present yes.
As I told, sclerosis as early malnutrition rheumatoid sometimes like that. Probably in my practice, the first case rheumatoid, presenting with neuropathy so early.
Will this foot drop completely completely recover?
Hopefully, sir.
Usually what is your experience? Does foot drop completely recover, or what is the literature says? Does foot drop?
Since it is an acute onset, the recovery is chances are bright. But if it's a chronic, probably maybe 70% recovery will be there.
If somebody comes after 6 months, then chances are less likely.
So we have the best.
Yeah, because she came within couple of times, couple of weeks, she came back to us. So hopefully she will recover completely.
Is it the Takay's disease earlier manifestation with the rheumatoid?
Sir, say again.
That you excluded Takay's disease?
Takay's? No, in her case it's not Takay's.
It's very common.
Takay's, we don't have Takay's. It's not Takay's. She has no features to say it's Takay's. Takay's sometimes can present with neuropathy. Like, I had some patients who present with a stroke. So this is not Takay's. No, sir. Yeah.
Sir, I am an orthopedician.
Sir.
Just I wanted to add two things I wanted to know actually. See, we have seen the earlier patient who has been on methotrexate from last 18 to 19 years. But still it has not prevented the deformities in the fingers or not the extra articular. I am telling about this then. And many times I am hearing this, it is a burnt out disease. In burnt out disease, how they are progressing into the deformities. That is number one. Number two, is there a role of methotrexate in a burnt out disease, or methotrexate is still keeping it in a burnt out stage only? Even if it is a burnt out stage, how we are going for the deformities in the joints? That's my... And I want to add one more thing. I am also a patient of Dr. U.R.K. Rao, not now, and also for you also. I met you also twice. For the information of the youngsters, I am telling, most of the patients, I'm having psoriatic arthritis, not rheumatoid, but regarding methotrexate, I have been taking for the last, say for example, 10 to 12 years methotrexate. So far I didn't get any complication regarding that methotrexate. And I had to temporarily stop methotrexate because I had some viral fever. For that, about 6 months I have stopped methotrexate at that particular time. But otherwise I am not doing. And with my own personal experience, and before that also, I am also very adamant proposer for methotrexate. I have been using methotrexate for my patient from the last 30 years. The first patient for whom I wrote methotrexate, he came and fought with me. He went to a library and studied that it is a drug for cancer. Why you are giving for me?
Even doctors
and the same patient after 10 years came and he explained me, sir, you did a very good thing by starting me on methotrexate. And how could you think of methotrexate at that time? Say, I'm not telling this for my sake. This is the response and the reaction from the patients. So as long as we are scientific and academic in our approach, don't bother. You can convince the patient to take it and we will definitely get better results. But only thing is, my question is this one. Whether it is playing any role in preventing the deformities, because as an orthopedician, I am more interested in the deformities. I want to prevent it. Do you suggest anything more? That's my question regarding
convincing the patient. Actually, patients are convinced, but not doctors, I would say. So about methotrexate.
The first paper published of methotrexate in Journal of Association of Physicians of India, JAP is one of the journals by us, from NIMS when I was working in 1990. That time the methotrexate is supposed to be, as Professor was mentioning, the anti-cancer drug, how it is given. But as Sarath was mentioning, that is in higher dosages in methotrexate. Now it is a psoriasis, psoriatic arthritis, rheumatoid and other diseases. Methotrexate is the drug and we can go up to 30 milligrams, but though 15 to 20 milligrams is the average we do. The relevant question is, how come in that gentleman, though he is taking for long-term methotrexate, see, this is not curable. Methotrexate is it's only controlling the disease, and then he was a bit, switching off. After 5 years, he came to me. So the vasculitis developed at that point of time. There is a word called tolerance. That means the pharmacologically, the same drug, the same dosage may not be affecting well. So we had to add a combination. So this gentleman actually was needing like leflunomide, sulfasalazine, chloroquine to support the methotrexate. Since he was taking the same, probably he didn't derive the benefit of a single drug. That's why we call now combination therapy. Now we have come the biologic agents also. Then that time probably the deformities would have been less. But by the time he has seen me, actually there were deformities way back 2 decades ago.
Thanks, Amma.
So to add for...
Thanks.
Dr. Rao, suppose you have a patient with very severe rheumatoid, can you start up with biologics and without DMRs?
No, since biologics are costlier, and then the conventional disease-modifying drugs like methotrexate, leflunomide, sulfasalazine, chloroquine, we have to try them first, at least 3 to 6 months. Then the disease, if continues to be active and aggressive, then we think of biologics. That is a standard one which we take, especially in our country because biologics are costlier.
So to add further regarding the burnt out disease, the burnt out in the sense clinically no tender or no swollen joint. The swelling which you are seeing in that particular patient is a bony swelling and not a synovial swelling. And before we say that it is a burnt out disease, we have to have a radiological evidence also. If the MRI doesn't show any activity, we can surely say that it is a burnt out disease, but still we have to treat her because she is at risk of developing extra-articular manifestations. And the second thing regarding the methotrexate in prevention of deformities, if we start methotrexate early in the disease, it definitely will prevent deformities. But there are patients, though they are good at treatment, nearly 10 to 15% of the patients do not respond to this baseline conventional DMARDs. So for that patient, the next line of option is biologic DMARDs.
Sir, we see... Sir, about again, burnt out is in methotrexate. Still the patient needs methotrexate, though it's burnt out. Because again, to prevent other complications. So he needs a combination therapies plus or minus biologic therapies.
Why leflunomide
No, so we are using...
Methotrexate is used widely, but leflunomide
we are using...
find that much.
No, yeah, actually methotrexate is more friendly. It's a weekly drug. Actually, side effect profile wise, methotrexate I would say better than leflunomide.
My point, we are intervening as early as possible.
Yes, sir.
That is number one. Number two, at least in my case, my patients, I have been starting them on methotrexate before we see any deformities. But still, after 7 years or 8 years, they are slowly growing. I am thinking that I am happy, his ESR less, CRP less, everything is less, he is on methotrexate. And also, mostly nowadays we are using leflunomide also. But still, after 7-8 years, I observe there are some deformities developing, particularly in the fingers and wrists.
Yeah, it happens actually. That's why physiotherapy is important.
In what way we can prevent it? That's my...
That is the reason we ask the patient to come on a regular basis. And nowadays, the new equipment we are using is high resolution ultrasound. Clinically, we may feel the patient is in remission. But these patients, when we do high resolution ultrasound, we see disease activity. So, like tight control of the diabetes, so we aim at tight control of the rheumatoid by using different combinations and plus or minus
I
steroids
wanted
and
to ask the same
biologics.
question. Both of you, leaders of rheumatology here, I want to know about the role of this. Earlier you were doing a pyramid type treatment or something like that, but nowadays multi-drug therapy is there.
That's true.
What is the role of multi-drug therapy in preventing these deformities and in the control, and what is its role? Because from last 10 years, we have been hearing about the multi-drug therapy. Please,
Multi in the sense, combination therapy, you mean. See, like Hansen's multi-drug, tuberculosis, we give combination therapy. Cancer, we give combination therapy. So it's the same, hypertension, all of them. So that's the same principle comes here. So but multi-drug, one thing I wanted to let you know that we should not give two NSAIDs together. So that's, well, I just wanted to bring out that one. But the disease-modifying drugs, we can give 2-3 combination therapy, so that the action is different, and then they target to the inflammation and also preventing the deformities. Well, they did not give the 100% guarantee that the deformities do not occur. That's why we are getting the newer drugs.
Sir, you see, commonly now the chikungunya is rampant. Fever reduced and patient is all right. Giant pains, RA positive. What's the issues around it?
So then we have to revise, go back to the patient, take a proper history and proper examination. If the patient has got signs and symptoms like duration is already chronic, and joint pains and swelling, tenderness, erythema, symmetrical, early morning stiffness of more than 1 hour, then it is rheumatoid. No longer it is chikungunya. Probably chikungunya has triggered. Rarely these things we see. But in my practice, all my chikungunyas except one, all chikungunyas completely recovered. One patient from NFC, she turned into rheumatoid. She has been on DMARDs.
1 year or 2 years, pains are continuing. Rheumatoid positive.
But if the patient has no signs of rheumatoid, only joint pains, still rheumatoid factor positive. When you examine, joints are quiet and the patient says a lot of pain but no signs of inflammation. Look for other causes. For example, doctors. All the doctors are vitamin deficient. So if you have a lot of joint pains, aching every day and feeling lethargic, check your vitamin D levels, because we work longer hours. So in my family, all 4 of us, we use vitamin D regularly. So we are all vitamin D deficient. So look for other causes like vitamin D deficiency, hypothyroidism, like that. Rarely viral, B hep C, patients can have diffuse body pains. And the last thing comes is, after ruling out connective tissue diseases, fibromyalgia. Fibromyalgia, some people don't believe in that because we don't have any good evidence, but it's a clear-cut entity itself. We don't know the pathology, we don't understand.
Sir, if but still we can give hydroxychloroquine. Probably some of them will benefit.
Dr. About the lefnomide, is it going up or is going down in rheumatoid arthritis? Lefnomide we have been trying, but at least I have stopped.
The going up means in the prescription rate?
Prescription wise. Or is it on the decline?
No, it is there.
It is.
Yeah. It's a good combination actually. See, the methotrexate is a purine antagonist. Leflunomide is a pyrimidine antagonist. So if you combine these two, we will achieve a better result.
Thank you, sir.
Sir,
the last question, because we have to move on to the next topic.
Sir, if the patient is in remission, then you want to stop methotrexate suddenly, or you want to taper it, or should the patient be using methotrexate lifelong?
There is no particular pattern, but what I would do in my clinic, for example, we are talking about combination therapies. The favorite treatment is for rheumatosis, triple therapy, methotrexate, sulfasalazine, hydroxychloroquine, plus or minus steroid. If the patient is getting better, then taper and stop the steroid. Then NSAID, already and SOS, always it's SOS. Then if the patient says, sir, I'm getting pigmented, then stop hydroxychloroquine or reduce the dose. Then maybe sulfasalazine. The last one comes is methotrexate. Methotrexate still, I believe, wonderful drug. So slowly taper it, not suddenly.
So if there are no signs in the future, there's no need to start again methotrexate?
No, at least one drug should be there.
For lifetime?
Yes, sir. we don't stop completely medication. If somebody has been in remission for a very long time, maybe 7 point. Usually I tell them at least 15 milligram, but some people insist, sir, I'll go back down further. Probably 7.5 or 10 milligrams is the least dose I use in patients who are in remission. Never ever stop completely, because it may come back with tsunami with complications.
Thank you, sir. I'm a student of cardiology. So I wanted you to give me about 2-3 minutes on the cardiovascular profile of rheumatoid arthritis and maybe the adverse effects with reference to cardiology. In other words, when can I get a reference from you? Thank you.
No, I think we need a separate session on that. Here we are focusing mainly the basic rheumatology. It's like showing a donkey, it is donkey, showing a horse, that is a horse. So we are not going to the high funda, but in a simple answer I want to give, for all our rheumatoid patients or lupus, other connective tissue disorders, when the disease getting better, when they're in remission, the chances of cardiovascular complications are less. According to the literature, suppose the 250 years old guys, one with the rheumatoid patient, the other is a healthy guy, 50. And the rheumatoid patient getting complications, cardiovascular, they get 10 years earlier than their age-matched groups. So, atherosclerosis or, ischemic heart disease, coronary artery disease, whatever, because of the endothelial dysfunction. So, by treating rheumatoid aggressively, not only rheumatoid, you are preventing cardiovascular and cerebrovascular morbidity. Okay.
And the drugs or anything which can have a significant cardiovascular effect?
Morbidity, no, not to my knowledge. No.
Thank you.
Thank you. Except the steroids. But nowadays we always try to use the minimum possible dose for the minimum duration. Now I request Dr. Vijay Prasanna to deliver a lecture on seronegative spondyloarthritis. Thank you.
There is a slight change in the schedule. Instead of lupus, we are going to discuss seronegative spondyloarthritis now. So since last 1 hour, you have been hearing regarding the seropositive arthritis, that is rheumatoid arthritis. In the next couple of minutes, I'm going to take you into a different scenario, that is a seronegative arthritis. Slides, please. Lights off. Lights. Thank you. So we call it as seronegative and arthritis, and we also have added an adjunctive, that is spondylo, because these are all considered as a group of diseases. And why these are grouped in under one umbrella is there is a specific reason for this grouping, which I'm going to deal in the next couple of minutes. So what are these seronegative spondyloarthritis? These are a group of diseases which I have mentioned. These are heterogeneous, but they share a similar clinical profile, or they share a similar radiological evidence. Apart from this, they also have some genetic shareage, that is genetic similarity. The similar clinical picture is they may present with some sort of clinical manifestations which may overlap with all these type of diseases. They may have some similar radiological manifestations, and they all test positive, not all, sorry, they test positive for HLA-B27 usually. So these are called seronegative in the sense because they test negative for rheumatoid factor and also anti-CCP. So day in and day out, you see many patients who are negative for this rheumatoid and negative for anti-CCP, but still there is an evidence of inflammatory arthritis. So to which group you have to dump these patients is a clinical dilemma. So in such cases, you have to think whether the patient fits into this seronegative spondyloarthropathy group or not. So how to identify these patients, whether these patients fit into this group or not, is the next question. So there are 5 types of seronegative spondyloarthritis, among which we commonly see ankylosing spondylitis, followed by psoriatic arthritis, reactive arthritis, and arthritis associated with an inflammatory bowel disease, and there is also an entity called as undifferentiated spondyloarthritis. We call this as an undifferentiated spondyloarthritis because these patients do have some similarities of all the rest of the 4 arthritis, but they exactly don't satisfy the criteria to call them either as an ankylosing spondylitis or as a psoriatic arthritis or an IBD associated arthritis or a reactive arthritis. So such patients were grouped as undifferentiated arthritis if he or she fulfills the criteria of spondyloarthritis. So what are the similarities which are shared by this group of patients are, they share in common articular manifestations and extra-articular manifestations. I mean that they share are not exactly every patient should have all these features. They may have one or more features, and each patient do not have a similar symptom. So the spinal manifestations, they may have a spondylitis, sacroiliitis or a syndesmophyte formation, and the articular manifestations, it could be an arthritis, be it is an axial skeletal involvement or an appendicular skeletal involvement, enthesitis and dactylitis. Among these articular manifestations, enthesitis and dactylitis, these were considered as clinically diagnostic features of spondyloarthritis, though dactylitis is seen in many other conditions like gout. The other extra-articular manifestations include uveitis, psoriasis, urethritis or conjunctivitis or an inflammatory bowel disease. Some patients do have balanitic manifestations. So these patients, most of these patients have a common clinical symptom, that is back pain. As we all know, day in and day out, we see many patients suffering with back pain coming to our OPD. The cause for this back pain is multifactorial in such patients. So most of the times this back pain is in mechanical type of back pain, though there are other causes of back pain like neurogenic back pain or other characteristics, that is psychological back pain or something and so on and so forth. This inflammatory type of back pain is also one cause of the back pain, which accounts for nearly 10 to 15% patients. And this inflammatory back pain is the diagnostic characteristic for this spondyloarthritis. So nearly 85 to 90% of patients presenting with inflammatory back pain, they can be classified into one of the groups of the spondyloarthritis. How does this inflammatory back pain differ from other types of back pain? These inflammatory back pain, they have a special characteristics by which we can judge clinically to help it differentiate it from the mechanical or other causes of back pain. Don't get scared of this slide. There are various criteria to define inflammatory back pain. If you closely observe, all these criteria have taken age as a major consideration. To summarize this 4 criteria, these are the characteristics of inflammatory back pain. So if the age of onset of back pain is less than 40, or some books say 45 years, means if he or she presents with that back pain, particularly when he or she is less than 40 to 45 years, you can think whether the back pain reason could be an inflammatory back pain in such patients. And the symptoms persisting for more than 3 months of duration, and the patient pointing back pain more so in the lower back. It is not exactly same in every patient. Some patients do point pain in the neck region. Some patients do give a history of alternating buttock pains, and there is a night awakening, that is sleep awakening due to this buttock pain, particularly around 3 to 5 a.m. And predominantly an important symptom is a morning stiffness lasting for 30 minutes or more, and all these symptoms should have an insidious onset. And typically this inflammatory back pain improves with activity and worsens with rest. And again, one more differentiating feature is a good response with NSAIDs. By knowing these features, you can clinically itself can differentiate whether the patient is suffering with an inflammatory back pain or other causes of back pain. The sensitivity of this criteria is 77% with a specificity of 91%. So going with an ankylosing spondylitis, I'll be touching only the clinical manifestations so that you can identify these patients at an early stage. I am not going deep into the pathogenesis, and I am not touching treatment aspects of this disease. So this is a normal posture of every person. a patient who is suffering with an ankylosing spondylitis can have this type of stooped up postures. So every stooped up posture, is it equal to ankylosing spondylitis? No, definitely not. There are also other causes, but for an undergraduate or a basic medical student, you should know that this spondyloarthritis, particularly ankylosing spondylitis, is one of the common causes of this stooped up posture. So if, for example, if a female aging more than 50 comes with this stooped posture, we don't consider ankylosing spondylitis in her. The first differential should be an osteoporosis in her. So what exactly happens in this spondyloarthritis? So in patients who are suffering with this group of diseases, particularly in ankylosing spondylitis, the inflammation starts in the SA joint, and this inflammation, when uncontrolled, it spreads. Actually, this is not the medical language which I should use, but for the ease of understanding, I am saying that the inflammation spreads from the SA joint. Actually, it is not the thing which happens. So once the inflammation sets in the initial stages, if we don't address at that stage, this inflammation gradually progresses to involve the vertebra also. So this inflammation, when untreated for a prolonged period, it results in formation of a new bone, which is called as a syndesmophyte. That is similar to osteophyte. I think most of you know what is an osteophyte. It is similar both clinically and also radiologically. Syndesmophyte mimics its similarity. The only thing by which you have to differentiate syndesmophyte and osteophyte is again considering the criteria of inflammatory back pain. This syndesmophyte formation is an irreversible manifestation of ankylosing spondylitis. So once the syndesmophyte forms, it doesn't keep quiet. It gradually progresses and it bridges the adjacent vertebra. That is called as a bridging syndesmophyte. So once this bridging syndesmophyte forms, this is an irreversible state which leads to formation of which leads clinically into a stooped up posture with decreased motility of the spine. This spinal motility is decreased either at the level of lumbar spine or at the level of thoracic spine or at the level of cervical spine. This bridging syndesmophyte can form at any part of the spinal region. So clinical features, most of these patients, as I have said, they have an inflammatory back pain. This back pain gradually sets in. If you take a careful history, most of these patients give a history of alternating buttock pain rather than a classical lower back pain. This back pain can involve any part of the spine, be it a cervical, thoracic or a lumbar spine. And these patients do have other peripheral joints of peripheral joint involvement, be it an upper limb joint or a lower limb joint. So apart from this back pain and buttock pains, these patients also present with a characteristic feature called as enthesitis. That is, enthesis is nothing but a site of attachment of a muscle or a tendon or a cartilage to the bone. So there will be inflammation of this site. This is considered as one of the clinical characteristics of this group of diseases. So most commonly we see Achilles enthesitis and Achilles tendon enthesitis or a patellar enthesitis. The next feature is dactylitis. Dactylitis is nothing but a swelling of the soft tissue of the digit, be it a finger or a toe. It is a diffuse swelling of the digit or a toe, and these patients do also have involvement of phi, particularly the uvea, whole of the uvea, be it an anterior or a posterior. So this patient, this is an image, I don't know how many are able to appreciate. You can see the irregularity of the pupil. This is the same, eye of the same patient. You can appreciate the irregular pupil with some debris. This is because of the untreated recurrent uveitis in this patient. This patient has first manifestation of uveitis, and later during the follow-up he was diagnosed as ankylosing spondylitis. So this recurrent untreated uveitis is one of the cause of blindness in these patients. So what happens if we don't treat these patients? If these patients were left untreated for a prolonged period, as I have mentioned, from the inflammatory back pain stage, they'll have an increased stiffness. This stiffness is due to formation of syndesmophyte. Gradually, this syndesmophytes, they bridge the adjacent vertebra. This is called as a bamboo spine, which we can appreciate radiologically. So bridging syndesmophyte resulting in this stooped up posture. Apart from this, as in rheumatoid arthritis, these people are also at risk of extra spinal and extra articular manifestations like involvement of the heart, involvement of the lung, and involvement of the kidney, and more so involvement of the eyes. So the next question is, every sacroiliitis is ankylosing spondylitis. How many of you will support that every sacroiliitis is the diagnosis of, is equivalent to ankylosing spondylitis? Can you please raise your hands? No one. Very good. I'll deal with an example. He's a 28-year-old man who has presented with 6 months history of lower back pain with a peripheral arthritis predominantly involving knees and ankles. So if you see, he is fitting the criteria of spondyloarthritis in the form, the age, he is 28, the duration is 6 months, presentation is a lower back pain with predominantly the onset of peripheral arthritis in the lower limbs. So initially I have considered my first differential as a spondyloarthritis, probably ankylosing spondylitis or a reactive arthritis, and I have asked him for admission for further follow-up because he had other clinical manifestations which need for evaluation. So on clinical examination, this patient has a left submandibular lymph node which is very tender, though it is not clinically significant. It is less than 1 centimeter, but it is significantly tender. So apart from this, there is no other clinical clue. So patient who is having symptoms of low back pain, were reasonably young patient with clinical examination of left submandibular lymph node. So I thought something odd should be considered apart from the spondyloarthritis. So after admission, when our resident has taken a thorough history, and there was a history of tuberculosis in his mother during his childhood. So we have taken an MRI which is showing bilateral sacroiliitis with a stir hyperintensities. Again, this going in favor of spondyloarthritis. And he had a reasonably good response, 60% response to 2 different NSAIDs. And we have done an FNAC of this lymph node. And thus this FNAC had shown features of tuberculosis. So what we have planned is whether it is a coexistence of tuberculosis with ankylosing spondylitis or it is only a tuberculosis which is causing sacroiliitis is a clinical dilemma. So what we have thought is we stopped NSAIDs after counseling him regarding the severity of pain if we stop the NSAIDs, and we have initiated him on only ATT. He didn't even receive paracetamol for his pain or a tramadol for his pain. He was there for an ATT for whole 1 month, and significantly nearly 100% improvement in his lower back pain is there. To further add, he tested negative for HLA-B27. Normally, these patients test positive for HLA-B27 in nearly 85 to 95% of patients. But still, in the back of mind, are we missing ankylosing spondylitis in him is a clinical dilemma. So we have taken the help of Professor Kakarla Subbarao Garu, and he also insisted that it is sacroiliitis secondary to the Cox etiology, because in the imaging he also had an extended inflammation in the muscles. Now the inflammation is not restricted to only bilateral SI joint. It also has come out through the muscle. He had a muscle involvement. So this muscle edema shows it is an infectious type of sacroiliitis rather than as inflammatory type of sacroiliitis. So he is doing well with ATT, and as of now he is under a physician follow-up, 6 months ATT. He is perfectly all right. I thought he'll come today, but he didn't come, unfortunately. So the next group is psoriasis with psoriatic arthritis. Psoriasis, any skin rash, is it equal to psoriasis? No, definitely not. Psoriasis do share some clinical features in similarity with other types of skin rash, and there are also various types types of psoriasis, maybe a pustular psoriasis or a plaque psoriasis. And this patient, particularly this patient, has a plaque type of psoriasis. Most of the times what we do in our busy OPD is we don't insist in clinical examination by exposing him. So these are the cases where we miss the hidden sites of psoriasis, be it a retroauricular area or axillary, inguinal or a gluteal area. So when we have a suspicion of seronegative spondyloarthritis, we have to disclose them and we have to examine. And it can be a gutted psoriasis or it can be an inverse psoriasis, which involves cruisis, and it can be a seborrheic variant of psoriasis. This is a rare presentation of psoriatic erythroderma. He is a 70-year-old patient who has been diagnosed as psoriasis on alternative medicine. Suddenly he had presented to emergency with a severe dehydration and decreased urinary output. So what we have to expect in him is the dehydration secondary to psoriatic erythroderma, because once the lesions peel off, these patients lose fluids through this exposed area. As the skin is a vast area covering the body, the rate of loss of fluid from the skin is very high. So these patients are at risk of development of dehydration and secondary renal failure. With only simple hydration, his renal failure has been corrected, and now he was on methotrexate. So there are also nail changes apart from the skin changes. You have to see for pitting, you have to see for ridges, and you have to see for onycholysis. This pitting is rarely appreciated in Indian scenario. More than 5 pits is considered significant. So apart from pitting and ridging, we also see sometimes splinter hemorrhages, and this is a real patient's hand where you cannot appreciate pitting in this. If you clearly see, I don't know how whether you are able to appreciate it pitting or not, but you can definitely see there is a problem with the nail. So this is called as onycholysis at the initial stage. And apart from this psoriasis, do patients with psoriasis, some may develop into psoriatic arthritis. But all patients with psoriatic, is there any rule that they should have psoriatic arthritis? No. These patients can develop rheumatoid too. So there are various types of psoriatic arthritis, the commonest being an asymmetric type of psoriatic arthritis. Asymmetric in the sense, as Dr. Sarath has pointed, that bilateral symmetrical joint involvement is rheumatoid. So any asymmetrical arthritis, you first think of psoriatic. I'm not saying that it is psoriatic. You think of psoriatic arthritis, and it can be a polyarticular and symmetric, mimicking rheumatoid. See, if you see his hands, this is a bilateral symmetric involving bilateral wrist, bilateral first PIP and right second PIP, and with the swan neck deformities. If you see this without knowing the history, you can label him as rheumatoid arthritis. Though fortunately methotrexate is a drug used for both of diseases, but there occurs a difference whether to start him on HCQs or steroids. So if you can observe this picture, can you find any other clinical clue? Deepthi? How can you say this is a psoriatic rather than rheumatoid? Anyone? No? I cannot. Very good. This is the dactylitis. See, this second finger, he had a diffuse swelling when compared to the right one. So seeing this, you can say that the patient fits into seronegative, be it ankylosing reactive or psoriatic something, but it is not definitely rheumatoid. Though rheumatoid patients do develop a dactylitic picture, but most often this inflammation is restricted to the joint line, unlike in rheumatoid psoriatic arthritis. So by seeing this dactylitis, you have to go more in favor of psoriatic arthritis. But to label him as a psoriatic arthritis, you have to have a radiological evidence also. Next, predominantly DIP involvement. Again, DIP involvement in these patients, it could be an osteoarthritis or a DIP variant of psoriatic arthritis. Again, we take a radiological evidence and a complete clinical history and complete clinical examination to differentiate both. And spinal involvement as sacroiliitis, and a rare variant called as arthritis mutilans, which we are not seeing of late. This is a representative picture, and this is a real picture of the patient presenting with an arthritis mutilans, where you can see a lot of deformities, active arthritis, apart from psoriatic lesions and nail changes. So, is it necessary by any means that patient with psoriatic arthritis should have psoriasis initially? Or every patient of psoriasis develops psoriatic arthritis? How many of you say yes, that psoriasis should be there to diagnose a psoriatic arthritis? No one. You are saying? You're saying that psoriasis is necessary. No. Psoriasis need not be a clinical presentation when the patient have only arthritis. Okay. Why? Because I will be telling. So most of the times, nearly 60 to 70% of these patients, they'll have skin lesions and they'll have arthritis. In this group of patients, we don't have any clinical diagnostic dilemma to call them as psoriasis and psoriasis associated arthritis. But there is a set of people where 20 to 30% of the patients, they have a psoriatic arthritis as an initial manifestation of psoriasis, followed by skin psoriasis. In the next 10 to 20% of the patients, they'll have occurrence of psoriasis and psoriatic arthritis simultaneously. These psoriatic patients, they also can manifest as dactylitis, as in ankylosing spondylitis, enthesitis, and peripheral edema, which is like mimicking a protein-losing enteropathy. They can have Sappho syndrome, and they can have pachydermoperiosteitis. These are the extra-articular manifestations, and the last two we rarely see. And coming to the next one is reactive arthritis. Reactive arthritis is arthritis resulting secondary to infection of other sites of the body. So it is, as I have mentioned, it is secondary to infection of other sites of the body. It doesn't mean that the arthritis is due to infection or it is a septic arthritis. It is clearly a non-septic arthritis resulting due to infection of other sites. The other sites, the commonest being either a urinary tract or a gastrointestinal system. And this reactive arthritis, regarding the incidence of reactive arthritis, it shares a clinical exceptions, because this psoriasis or psoriatic arthritis or ankylosing spondylitis, these are the male predominant diseases. Most of the rheumatic diseases are female predominant. Among them, psoriatic arthritis and seronegative spondyloarthritis are the male predominant diseases, but among this group, reactive arthritis have an equal incidence in both males and females. So how do this reactive arthritis present? So any patient who gives a history of some diarrhea or urinary tract infection like symptoms at least 3 days to 2 months prior to the onset of arthritis. Where does this arthritis start? So it is predominantly a lower limb arthritis and asymmetrical arthritis, and it should be an oligoarticular. It means that the arthritis should start in the lower limb joints. It should not be symmetrical, and it should be less than 4 joints. So asymmetrical lower limb arthritis is the characteristic feature of reactive arthritis, and these patients, they test positive for HLA-B27. So there is one large study when we follow these patients of reactive arthritis during the due course of the time. Nearly 10 to 15% of these patients, they turn out to be ankylosing spondylitis. These patients do have involvement of other joints, and these patients do have dactylitis, and these patients do satisfy the criteria of inflammatory back pain. Next comes the IBD-related spondyloarthritis. As you know, Crohn's and ulcerative colitis are the IBD-associated spondyloarthritis, and these patients have 2 types of presentations. One, it can be an oligoarticular or a monoarticular and a polyarticular manifestation. This polyarticular manifestation, again, it could be a bilateral symmetrical polyarthritis associated with this IBD. These patients do have enthesitis, dactylitis, and other sacroiliac joint involvement apart from bowel diseases. So as we couldn't demonstrate this patient, so I'm keeping only endoscopy and colonoscopy reports, and he is a very elderly male who presented with some vague joint pains and anemia. So the point here is he has presented with an anemia and joint pains, and age-wise he is 52. So in this age group, we have to rule out certain conditions for anemia. So during workup, he was found to have some antral and fundal gastritis and duodenal diverticuli with some H. pylori RUT positivity. And for colonoscopy, we have done it because as a part of workup for his severe anemia, he had a superficial ulcerations with skip areas, particularly involving the terminal ileum. So the involvement of terminal ileum again gives a diagnostic dilemma, whether it is due to tuberculosis or whether it is due to some other cause. So we have taken a biopsy which is suggestive of Crohn's disease. He is also similar patient, but this patient has a frank lower back pain starting from age of 20, and he was not investigated. He sits at home, he takes diclofenac, and he was relieved by his symptoms. So in 2016, he underwent an MRI, which was showing bilateral sacroiliitis along with a facet joint hypertrophy. But this was missed, and later, since 20 years, she also had a history of occasional bleeding PR. That is a clue which we have to take in this case. And what is the cause for this bleeding PR? We have started taking the history and workup. There we have found she had a proctocolitis with a biopsy proven ulcerative colitis. So apart from this intestinal manifestations, these patients do have some extra intestinal manifestations, among which involvement of eye and erythema nodosum requires an attention. You should consider IBD as one of the cause for erythema nodosum, which we see clearly, and involvement of eye is also one of the presenting feature or one of the feature of this IBD associated arthritis. So to conclude, this group is a seronegative group. They share common clinical and radiological manifestations, among which inflammatory back pain should be addressed at the correct point so that we can prevent the morbidity and the radiological damage if we start the treatment early. And in these patients, physiotherapy plays a very important role, not only in seronegative arthritis group, any arthritis, physiotherapy plays a very major role in preventing deformities, which is as a part of your answer to the last question in the last session. Thank you so much. Now I'll hand over to Dr. Deepthi. She'll be dealing few cases of spondyloarthritis, and we have kept good number of psoriasis. We couldn't demonstrate IBD arthritis or a reactive arthritis as of now. Focus to the patient. Patient.
Good morning. This is a 66-year-old male patient. He is a known case of psoriasis for the past 10 years. He had a history of joint pains for the past 1 year with early morning stiffness lasting about 15 minutes. Previously he was treated with methotrexate Folwite, and his symptoms were not subsiding. So he was started with injection infliximab 400 mg. 3 IV infusions were given, and currently he's feeling symptomatically better.
Skin చూడొచ్చు.
కాళ్ళది చూడొచ్చు. రెండు సైడ్ కాళ్ళది చూడొచ్చు.
Focus on the feet. మీ డాక్టర్తో మాట్లాడచ్చు మీ ఎక్స్పీరియన్స్.
ఇది సమర్శనం అవుతుంది సార్.
చర్మవ్యాధి సమస్య ఎన్నాళ్ళ నుంచి ఉందండి?
సంవత్సరం నుంచి ఉంది. ఒకసారి యాక్సిడెంట్ అయితే ఇది కాలుది ఇక్కడ ఆపరేషన్ చేశారు, అది ఓకే. ఇది సంవత్సరం నుంచి వచ్చింది సార్. ఇట్లా
ఈ కీళ్ళ నొప్పులు కూడా అప్పటి నుంచే ఉన్నాయండి?
కీళ్ళ నొప్పులు అప్పుడే వచ్చినాయి. మొత్తం 11 నెలలు మంచం మీదకి వెళ్ళి లేవలేదు సార్. పెయిన్ కిల్లర్ టాబ్లెట్స్ వేసుకుంటేనే ఒక 2-3 గంటలు లేచేది, బాత్రూమ్ అది పోయేది, వచ్చి పండితే ఇక అసలు నిద్ర కూడా ఉండకపోతుండే. ఇక నల్గొండ, హైదరాబాద్ హాస్పిటల్స్ మొత్తం తిరిగినా కానీ కాలేదు సంవత్సరంలో. ఇక లాస్ట్కి ఒక మిత్రుడు చెప్పిండ్రు ఇక్కడ హాస్పిటల్, చెప్తే వచ్చాను. వచ్చినాక వారం రోజులు ఉన్నాక చూసి ఇంజక్షన్ ఇచ్చారు. ఒక 4:15 స్టార్ట్ చేసి రాత్రి 12 అయింది సార్.
మీకు వేళ్ళు ఇక్కడ నొప్పులు ఉన్నాయా, ఇక్కడ ఉన్నాయంటారు? లాస్ట్లో ఉన్నాయా, ఇక్కడ ఉన్నాయా, ఇక్కడ ఉన్నాయా?
ఇక్కడ ఇట్లా
కాదు, మీకు వేళ్ళు నొప్పులు అన్నారు కదా, ఇక్కడ నొప్పులు ఉన్నాయా లేకపోతే లాస్ట్ ఇక్కడ
ఇలా ఉన్నాయి?
ఇక్కడ ఉంది, ఇక్కడ ఈ వేళ్ళు ఇక్కడ చివర,
ఈ చివరకు కూడా కొంచెం.
So DAP joints are in.
Yes, sir. Prior to the initiation of the infliximab therapy, ankles, knees, MCP, DIP, PIP joints were involved. He also had extensive psoriasis involving all the 4 limbs back in the scalp. But after 3 doses of infliximab, he's symptomatically better, sir. As of now, he doesn't have much of joint pains and synovitis cannot be demonstrated. And also his lesions have come down considerably.
Please show his feet. Look at the nails. Severe nail dystrophy in the 2 nails. So whenever you say case of inflammatory arthritis, look for the skin changes and the nail changes. So any inflammatory arthritis with psoriasis, skin lesions and this kind of nail involvement, either nail petting or nail dystrophy, they look like fungal nails, then the diagnosis would be psoriatic arthritis. సో ట్రీట్మెంట్కి ముందు ఎట్లా ఉన్నారు, తర్వాత ఎలా ఉన్నారు, డిస్క్రైబ్ చేయండి.
ముందు 11 నెలలు మొత్తం కంప్లీట్ మంచం మీదనే ఉన్నాను సార్. దిగరాకపోయేది, ఉండకపోయేది. ఒక పెయిన్ కిల్లర్ టాబ్లెట్ వేసుకో 2-3 గంటలు జర ఇట్లా లోపల కొంచెం లేచి తిరిగేది. ఈవెన్ బాత్రూమ్ పోయి వచ్చేది. మూత్రానికి పోవాలంటే మంచం మీద వండుకొని పోయేవాడిని సార్. ఇక్కడ నల్గొండ తిరిగినా, అన్నీ తిరిగినా. చెప్పాలన్నా బాగా
ఇప్పుడు బాగున్నారు కదా. మీరు ఆ రోజు ఇంజెక్షన్ తీసుకున్న తర్వాత ఓ మాట చెప్పారు, నెక్స్ట్ టైం మార్నింగ్ చెప్పండి డాక్టర్స్కి.
11 నెలలు నాకు నిద్రలేదు సార్. 11 నెలల తర్వాత ఇంజెక్షన్ ఇచ్చిన రోజు తెల్లారి నైటు సాయంత్రం 6 గంటలకు వండుకుంటే ఉదయం 6 గంటలకు లేచిన. 1 ఇయర్ నిద్ర ఒక్కరోజు పోయినా సార్. నేను సంవత్సరం నిద్ర లేదు నాకు. ఒక్కొక్కసారి ఎంత బాధ అయ్యేదంటే అసలు ఇరగొట్టేసేయాలనిపించేది ఏదన్నా దొరికితే కాళ్ళని. అలాంటి ఇబ్బంది ఉండే. ఆ ఇంజక్షన్ ఇచ్చినాక మంచిగా నడుస్తున్నాయి. ఇప్పుడు పెడుతున్నది 3వ ఇంజక్షన్ అయింది. హ్యాపీగా ఉంది సార్ ఇప్పుడు.
No, he's on very low dose of steroid and methotrexate because his pains were so severe. In the beginning itself, we tried infliximab, and he has got excellent improvement. So in his own words, he explained he had 11 months or 1 year sleep in one night. So from that day onwards, he's trying to dance now. He wants to share his joy with us. Thank you very much.
మంచిది సార్.
సో ఏం చెప్తారు మీరు డాక్టర్స్కి, ఏం చెప్తారు?
నాకైతే ఇప్పుడు హ్యాపీగా ఉంది సార్. ఇంట్లోకి వచ్చినాకనే మంచిగా ఉంది. ఫస్ట్ మందు తిరిగినా ఎక్కడ కాలేదు. 11 నెలలు 12 నెలలు అవస్థ పడి ఇందులోకి వచ్చినాక ఇప్పుడు బాగా అయింది. హ్యాపీగా ఉంది సార్ ఇప్పుడు. ఇంతకుముందు మాత్రం మస్తు అవస్థ పడ్డాను, తగ్గల.
Thank you. Sorry. Actually, in the West, in Europe and US, once they start biologics, they continue because most of the time they're covered under the insurance. So here, we use up to 6 months or maybe 1 year. After that, patient's pocket will trouble. And also, even if the patient is a great patient, we try not to overuse. As they get better, we try to stop the biologic and continue background disease modifying drugs.
The next case, a 64-year-old male patient. He was having white scaly plaques over his all over the body, psoriatic lesions for the past 20 years, history of joint pains, polyarticular for the past 20 years, recent onset of lower backache for the past 6 months with early morning stiffness lasting up to 15 minutes and difficulty in turning sideways while lying down. He is a known diabetic and hypertensive, and there is no significant family history.
Take the mic. Which joints are involved?
Joint pains involving the ankles, bilateral knees, MTP joints. ఇక్కడ కూడా ఉన్నాయి కదా మీకు. Bilateral wrists. ఇక్కడ ఎక్కడెక్కడ ఉన్నాయి? చేతుల్లో పెట్టుకోండి. చేతుల్లో పెట్టుకోండి. ఇలా పెట్టండి. ఫోకస్ చేయండి. రైట్ లెఫ్ట్ గ్రేవ్తో ఫోకస్ చేయండి.
There is no uniform swelling, but the skin wrinkles are very prominent. So this is loss of skin wrinkles is abnormal and presence of skin wrinkles is normal. So this left toe, great focus out the. So you can see
the ALT is 25 and he's HLA-B27 negative. A 53-year-old male patient. He was
I'm suffering from almost 20 years psoriasis. So along with psoriasis, I suffered with joint pains. There's a psoriatic arthritis with after diagnosis. And so I went for initially this Ayurvedic, then homeopathic, then again this traditional medicines and Tibetans. So then I went through this medical journals and
surgery, particular steroid. If there is an indication, you give steroid into that joint only and not in like a systemic administration. Particularly in psoriasis, the systemic steroid aggravates the psoriatic lesions. Okay, there is no role of systemic steroids in these patients. There are few conditions where steroids are totally contraindicated in rheumatic patients. Among them, the one is psoriatic arthritis or any seronegative, but IBD related arthritis, steroids play a major role.
In early age, he has undergone replacement. Was a rheumatologist was concerned before he was taken up for that?
He was initially seen by a rheumatologist.
Before the surgery.
Before the surgery, off late, they are not taking our clearance.
We are going to have a fight between rheumatologists and orthopedic surgeons, sir.
Yeah, not the fight, because he is a known case, early case. Then
correct.
orthopedic surgeons should take an opinion of a rheumatologist before.
Definitely, sir.
Yes, you are right, sir. Actually, before entering into surgery part, they discussed a lot at NIMS only. Orthopedic surgeon, what they told is, it never requires any kind of replacement. Why? Because in this kind of early stage, we don't need any kind of replacement. But the thing is that rheumatologist, what they suggested is, he needs immediately replacement. So we feared a lot. Why? Because at the time of 20 years, below 20 years, how can we face the problem of replacement? As a father, I feared a lot. Why? Because what is the necessity? We can see at the very outset only left hip joint is damaged.
That's right.
So my thinking is, after using 1 year or 6 months medicine, if needed, we can enter into surgery. Otherwise, why not? Why unnecessarily enter into surgery? That is my opinion.
He is able to walk
So
now?
he is able in the sense only with the stand he is able to walk. And one more thing, after having 4 joint replacements, only 30% what we can say movement, 70% movements are there. Physiotherapist, he is asking again there is 30%. After getting 30% curity from that physiotherapy, other things, he will walk naturally.
When was the replacement was done?
Sir, my advice is, respected doctors, especially due to lack of awareness, most of the cases, patients are suffering with this type of joint replacements. And one more thing, due to the lack of coordination between rheumatologists and orthopedic surgeons, these type of situations are happening, sir. As far as my knowledge. I'm not opposing the policy, sir.
Yeah.
Sorry, very sorry.
Well,
sorry to see that.
Well, I'm not involved in his management anyway. But as a senior rheumatologist, we can mention if the joint is damaged, if I see X-ray, probably I could have told you, if the joint is damaged totally and if it doesn't improve with any medication, it needs replacement.
Okay, sir.
The surgical principle is if medication is not effective, then mobility is more important. So we do the surgery.
So a small request, while discussion is going on, quickly you can have a tea break, 15 minutes. Please be back next session.
At least to get the mobility.
Yeah, that's right. It requires physiotherapy and other things. Yeah.
Only for that purpose.
That's right, yeah. So probably we can help that way. Thank you, sir.
Yeah, good physiotherapy, post-op physiotherapy is very, very important. So for take-home message from this session, if anybody has got arthritis and back pain, think of seronegative spondyloarthritis, and if they have psoriasis, think of psoriatic arthritis. About sacroiliitis, actually the case should be for the rheumatologist, not for the non-rheumatologist, because it can give a wrong message. Because bilateral sacroiliitis, Dr. Prasanna asked, bilateral sacroiliitis, do you say it is Angstbond? I would say it is Angstbond, not TB. Because at your level, at your PG level, bilateral sacroiliitis, unless proved otherwise, it is ankylosing spondylitis. Why I am saying this is, in the periphery, a lot of patients with sacroiliitis taking ATT unnecessarily. And in this case, clearly it's shown on the MRI, soft tissue involvement. Because other than the joint involvement, MRI would show signs of inflammation, maybe collection of pus in the muscles or the spaces around. So if the soft tissue involvement is there, then it is COX. So to say COX, we have to have a proof. And if you find any collection, then aspirate and try to confirm it. So bilateral sacroiliitis is either AS or some sort of seronegative spondyloarthritis. Yeah, rarely we do see COX, but we have to have a proper proof. This is one of the unusual cases. I'm glad we didn't miss COX in this case, because otherwise, if we don't treat it, it spread to other organs. Thank you. Am I right, Dr. Prasanna? Yeah. What I'm saying is, at the PG level, bilateral sacroiliitis is ankylosing spondylitis or some sort of seronegative spondyloarthritis, unless proved otherwise. This is a rare manifestation.
Because this is a tertiary center, of late we are seeing this, but at a level they have to think of this seronegative spondyloarthritis only, sir.
That is the main point. Think of inflammatory back pain with arthritis is one of the types of seronegative spondyloarthritis. The other thing about seronegative, it's a very confusing term, because seronegative rheumatoid and seronegative spondyloarthritis. We don't use that term anymore because we have to proper psoriatic arthritis, proper ankylosing spondylitis, reactive arthritis, intraopathic arthritis. Thank you, sir. Please join us for tea. In 15 minutes, we'll gather back and start next session on lupus.
To the Clinical Rheumatology Workshop being organized by the Department of Rheumatology and Clinical Immunology, KIMS Hospitals. We will now proceed to the inauguration. I would like to call upon the dignitaries to come onto the dais. I invite Dr. Sarath Mouli, Clinical Director, Department of Rheumatology, KIMS Hospitals, and the Organizing Secretary of this workshop to kindly come onto the dais. Okay. I'd like to call upon our guest of honor, Dr. U.R.K. Rao, Director, Sri Deepthi Rheumatology Center, to come onto the dais. He is the first rheumatologist in Hyderabad and the twin states of AP and Telangana. I now call upon Dr. Bolineni Bhaskar Rao Garu, MD and CEO, KIMS Group of Hospitals, and Chief Cardiothoracic Surgeon and Patron of this workshop, to kindly come onto the dais. It is my privilege and honor to invite our chief guest of the day, Dr. Kakarla Subbarao Garu, former director, NIMS, and world-renowned radiologist and academician, to come onto the dais. I now request the dignitaries on the dais to light the lamp and inaugurate the program.
ఈరోజు ఒక ముఖ్యమైన రోజు. ఇవాళ గురు పౌర్ణమి. సో గురువులందరికీ పాదాభినందనలు. అందరికంటే మొదటి గురువు ఆది గురువు ఇక్కడ డాక్టర్ కాకల సుబ్బారావు గారు. రుమటాలజీలో నా గురుగారు డాక్టర్ U.R.K. రావు గారు, డాక్టర్ భాస్కర్ రావు గారు, అండ్ టు ఆల్ ద సీనియర్ ఫ్యాకల్టీ sitting here. So thank you very much for coming for this CME. The main idea to conduct this CME is we pass out medicine without seeing a single case of rheumatological disorder. So that is causing a lot of problem for the patient, because if you don't see a patient in your lifetime, for example, rheumatoid or lupus, if you didn't recognize that, then how would you give a proper referral and treatment to the patient? So ఇది థర్డ్ కన్సిక్యూటివ్ అని చేయడం. లాస్ట్ ఇయర్ 2016లో we did in I think April 9th and 10th we did the same conference. This is for the non-rheumatologists. So all of the specialties actually can come, mainly useful for the postgraduates. Here what we are doing is we discuss each topic, each disease, followed by live case demonstration. Who have some good patients are waiting for us to share their feelings, and also they're going to teach all the postgraduates here today. And theory followed by 50 minutes of live case demonstration and 50 minutes interaction. So we're going to cover roughly 7 to 8 different diseases. Shanti, over to you.
Thank you, sir. Now I request Dr. Bhaskar garu to speak a few words.
అందరికీ నమస్కారం. ఇది కృష్ణా ఇన్స్టిట్యూట్ ఆఫ్ మెడికల్ సైన్సెస్లో ఈ వర్క్షాప్ అనేది క్రియేట్ చేయడం అనేది చాలా ఆనందంగా ఉంది. ఎస్పెషలీ పేషెంట్లు అందరూ ఉన్నారు కాబట్టి పేషెంటు రుమటాలజీ అనేది చాలా తక్కువ మందికి అవగాహన ఉంది. ఈ నొప్పులు రాగానే ఎవరైనా కూడా మందుల షాప్కి వెళ్ళి ఒక అనాల్సిక్ తీసుకుంటారు. తీసుకున్న దానివల్ల ఆ నొప్పులు అంతవరకు తగ్గిపోతాయి. తర్వాత అలా తీసుకున్న తర్వాత మళ్ళీ ఇంకో ఎంబీబీఎస్ డాక్టర్ ఎవరో ఒక ఫిజిషియన్ దగ్గరికి వెళ్తారు. వాళ్ళకి అవగాహన కాకుండా ఇంకొంచెం ఎక్కువైన అనాలిసిక్స్ ఇస్తూ ఉంటారు. సో బేసిక్గా మనం ఈరోజు చాలా వరకు జబ్బుల్ని పేషెంట్లు అటు మెడికల్ పర్సనల్ కూడా ముదిరిపోయిన దాకా
Live streaming update start cheyaddu baba. Don't start live streaming now. For information, actually this is coming online. So if you can forward the link if you have and share it in your WhatsApp group or Facebook, so anybody can watch from their home in their mobile phones and laptops.
There's a request for the delegates, if you all can move towards the center, it'll be easier. This way, please. And all the delegates, please make a note. There is a feedback form that is given along with your kits. You can exchange your feedback form for your certificate at the end of the program at the registration desk. Thank you very much.
Please move towards this center of the auditorium, please. You'll have a better visibility. Please move to this side, all of you, please. Sir, please come to this side, if you don't mind. Meeru itla vacheyandi. Come to this side. Doctors, please come to this side. Lot of vacant seats here. Because we are also going to have a photograph after this. You have to stand in front of your seat so that everyone can come into the picture. Please come to this side, please. Please. Please, this side. Please. Here seats are there. No? Here seats are there. No, nobody. No, there are vacant seats here. No, still vacant seats are there. Please, doctors, come to this side. Because we are going to have a photo session before the lunch, so you have to stand where you are sitting. So we will have a group photo. So we are going to start the next session on lupus. So I'm going to discuss around 15 minutes on lupus. SLE is an inflammatory autoimmune multisystem disease of unknown etiology with protean, clinical and laboratory manifestations and variable course and prognosis. The clinical manifestations may be constitutional or specific depending on the organ system involved. Skin and mucous membranes, joints, kidneys, brain, serous membranes, lungs, heart, and occasionally GI tract may be affected. The typical age group is in the reproductive age group, 15 to 45. Childbearing age group, females 8 to 9 times are more affected than men. These are the different symptoms and signs of lupus: fatigue, fever, weight loss, arthritis, skin rashes, renal involvement, GI involvement, lung, cardiac, lymphadenopathy, hepatosplenomegaly, and CNS involvement. This is the ASIA criteria for diagnosing lupus. There are 11 criteria: malar rash, discoid rash, photosensitivity, oral ulcers, inflammatory arthritis, non-erosive, serositis, kidney involvement, neurological in the form of seizure, psychosis, hematological involvement in the form of hemolytic anemia, thrombocytopenia, leukopenia, lymphopenia, and ANA, immunofluorescence positive, other immunological parameters like positive dsDNA, anti-Smith antibody positivity, and anti-phospholipid antibody positivity. So these are 11 criteria. If our patient is fulfilling at least 4 out of 11, then we are dealing with lupus. What is the risk in identical twins? Around 0.5%. Risk in non-identical twins around 2.5%. In the general population, 1 in 1,000. The hallmark of SLE when it comes to the laboratory test is ANA immunofluorescence, but it's not specific. So this patient has come up with this rash and ANA positive. Probably some of you have seen this in my previous lupus presentation in the month of May. Can anybody guess what it is? He is ANA positive with this rash. What is it? Please. So this is not a case of lupus. This is seborrheic dermatitis. Sorry, this is acne rosacea. Sometimes seborrheic dermatitis can mimic like this. This patient had acne rosacea. And this patient, again, with pigmentation, ANA positive. This is, he was on anticonvulsants. So this was phenytoin-induced skin pigmentation. ANA phosphoresity is high in lower dilution. As the dilutions get better, we get better results. At higher dilution, the diagnostic value improves. And we have different patterns of immunofluorescence, ANIF. Rim pattern is the most specific one. Speckle pattern is the most common one and least specific. A lot of patients complain of fatigue. It can be very disabling. Even the patients who have been in remission, still they can have fatigue. Fever. About 42% of patients of lupus can present as fever. If you look at PEO, according to one study, 4% of the lupus patients can present like PEO. So all PEO cases, please do connective tissue profile. Skin or arthritis are common lupus manifestations. Diverse clinical presentations as rash, arthritis, pleurisy, proteinuria, Raynaud's, and Seizures, PEO can occur. Butterfly rash, erythematous elevated lesions, that is pruritic, painful, and in malar distribution. Typically, it spares nasolabial folds, and the rash fluctuates with the disease activity. Oral ulcers in lupus patient. Butterfly rash. Before treatment, she came with the flare, and after treatment, you can see the improvement in the skin lesions. Discoid lesions are chronic cutaneous lesions. The lesions often begin in erythematous papules or plaques with scaling that may become thick and adherent with hypopigmented central areas. As the lesion progresses, follicular plugging occurs with development of scarring with central atrophy. Discoid lesions may occur in the malar region or in other sun-exposed areas. The lesions in the scalp lead to extensive, often permanent alopecia. Discoid lesions may be localized or generalized, the latter being more likely to be associated with systemic features and serological abnormalities. Discoid lesions on the ear, on the cheeks, in and around the nose, ear, scalp and face. Is one form of cutaneous lupus, subacute cutaneous lupus. It's a distinct cutaneous lesions that is widespread, non-scarring, non-indurated, and photosensitive. This lesion is thus intermediate between the evanescent malar rash and active lupus and the chronic scarring lesions of the disease. The subacute cutaneous lesions commonly occur in sun-exposed areas and may be generalized. This is a subacute cutaneous lupus rash. Usually they are SSA antibody positive. Overall prognosis is better in subacute cutaneous lupus. One such patient with she developed a rash later turned into bullous lesions. So a rare presentation, presenting like toxic epidermonecrolysis secondary to lupus. This patient had, like the other rheumatoid patient, syndrome due to lupus. Lupus profundus, form deep subcutaneous nodules may develop due, so it can be due to the lupus itself or sometimes vasculitis or vasculitis affecting the nerves, central nervous system, lungs, kidneys, GIT, and pancreas. Vasculitic lesions may manifest as palpable purpura, nail fold or digital ulcerations, subcutaneous nodules, livedo reticularis, splinter hemorrhages, pulp space and palmar plantar lesions, simulating ossular nodes and GNV lesions. One of the common presentations is after the skin joint involvement. 90% of the patients present with either joint pains or joint pains plus swellings. The typical type of arthritis, what we call in lupus, Jacob's arthropathy. It is a non-erosive arthritis, reversible deformities. Whereas in rheumatoid, they get permanent deformities. So rarely they may get osteonecrosis, mostly in the hips. Lupus nephritis may be up to sometimes up to 50%. We detect by examining the urine, look for proteinuria and cellular CAS, hematuria. We actually pick up so early, none of our patients have high creatinine values because we don't wait till that time. And we have around 1,300 lupus patients in our database, and around 130 patients have lupus, proper lupus nephritis, biopsy proven. And in the last 13-14 years, none of our patients had went into end-stage renal disease. Nobody is on maintenance hemodialysis, and nobody required a renal transplant. And in KIMS, we have good team of doctors. So rheumatology is nothing but a teamwork. So yeah, without other department support, we cannot survive. So actually, we are not collecting the data in a scientific way. Actually, a 1300 database is a big database in any hospital. And 130 lupus nephritis is a big number. And either most of them are in remission or partial remission. Delirium, psychosis, seizures, peripheral neuropathies, movement disorders, cranial neuropathies, myelitis, and meningitis. In this scan, you can see the first one showing demyelinating lesion before treatment, demyelinating lesion in the midbrain, and after treatment, disappearance of that lesion. What the case was. And when we looked at the patient, actually everything was given to the patient appropriately. Still the patient got CNS lupus symptoms. So we took the help of psychiatrist here. So with the symptomatic psychiatric therapy, the patient has improved. Then we had cut down her lupus therapy. So it's very important how much is the disease related and how much is not. So it's very important. So lupus can involve the GI in the form of dysphagia, mesenteric vasculitis, inflammatory bowel disease, pancreatitis, hepatitis, and protein-losing enteropathy and sinusitis. Anemia, it can be hematological, it can be autoimmune hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia. Here I would like to mention one thing. Dengue is so prevalent nowadays. So when anybody comes with a fever with a low platelet count, we think of dengue. But if somebody is not behaving like dengue and the platelet count is still very low, please do ANA. It's very important. If ANA is positive, then take the help of a rheumatologist. Because it is increasingly common nowadays. A lot of thrombocytopenia we are missing. Sometimes, luckily, patients they do very well even with low counts. But sometimes it's like a tsunami. It can flare up in other organs. So be careful. Whenever you have thrombocytopenia for a longer duration, please do ANA levels. Naupla syndrome, up to 40% can have positive APL antibodies, but they may not manifest clinically. Infections is a major problem in India. Infections can affect the skin, lungs, urinary tract. Incidence rate of serious infections requiring hospitalization up to 10 to 30%. And lupus patients, I see on an average 25 lupus patients every day. Yeah, I see around 50 patients, around 60. My clinic every day, roughly 60 up to go to 70. So around 40 to 50% of my patients are lupus. And all of them do very well, extremely well. But when they suddenly stop the medication, you know why they suddenly stop? Somebody next door neighbor or good friend of them, ఇంకెన్ని రోజులు తీసుకుంటావా, ట్రై చేద్దాం మందులు ఆపి, నేను హోమియోపతి వాడాను తగ్గింది నాకు, నువ్వు కూడా ట్రై చేయి. సో మన ఇండియాలో ఉచిత సలహాలు, సో ఉచిత సలహా తీసుకుంటే దెబ్బతినేవాడు ఎవడంటే పేషెంట్, ఇచ్చినవాడు బాగానే ఉంటాడు. So it's a big problem in lupus. For a rheumatoid patient, if the patient delays the treatment for 6 months, 1 year, nothing will happen. He will have more pains, but lupus is dangerous. So what we are having nowadays, the biggest problem is they stop the medication suddenly, they come with the flare and also infection. It's very difficult because active lupus need high dose of steroids. But if you give high dose of steroid, the infection gets worse. It's very, very difficult. So whenever you see lupus patient, please advise them. As long as they come for regular follow-up and take medication as per the prescription, I can give more than 99% guarantee that they would do very well. Risk factors of the infection: lupus, active lupus itself, neutropenia, lymphopenia, hypocomplementemia, involvement of kidneys, excess use of glucocorticoids, and rarely they may present with angioedema. How do you diagnose angioedema clinically? Not just urticaria, they will have swelling of the lips and also tongue. If it is severe, it can involve the throat. So it's very dangerous. So immediately they should come to A&E. And severe C4 deficiency itself can present like lupus. Lung involvement in the form of pleuritis, lupus pneumonitis, ILD, ulnar hemorrhage, pulmonary embolism, pulmonary hypertension, and shrinking lung syndrome. Cardiac involvement, pericardial effusion, and it can involve any layer of the heart. Eyes, dry eyes, scleritis, episcleritis, antiuveitis, retinopathy, optic neuropathy, and choroidopathy. Lupus patient with a malar rash. With arthritis, severe alopecia, gangrene of the fingers and toes. Lupus in a child with skin lesions in the palms especially. He's one of my favorite patients. He had been my patient for more than 14 years. So probably this was taken around 2003 or so. He had a severe lupus at that point of time. Subsequent photographs. Now he's so well. He is only on hydroxychloroquine 200 milligrams daily. All my lupus patients who, whether they had CNS lupus or lupus nephritis, when they go into remission after 2-3 years, if I'm very confident, I stop all the DMARDs, steroids, put them only on hydroxychloroquine. I call hydroxychloroquine as a Sanjeevani for lupus patients. So never ever stop hydroxychloroquine in lupus patients. It has got so many other advantages also. Alopecia in a lupus patient before and after therapy. Investigations, some routine investigations we do. If we have doubt like proteinuria, we have to ask for 25 urinary protein and ANA, DNA complements. And if we doubt infection, we do Procol, CRP levels. The goals of therapy: to ensure long-term survival, achieve the lowest possible disease activity, prevent organ damage, minimize drug toxicity, improve quality of life, and also we educate the patient about the disease, because most of my patients are very young, and some of them are at the marriage age group around 20 plus. So very important. I counsel them very properly, and also counseling before pregnancy also very important. So not only giving medication, we have to counsel the patient properly regarding the monitoring and about the drugs, how to take, because non-compliance is very high among the younger patients because they're careless about therapy. Thank you very much. And few patients who had normal deliveries with healthy babies. That's it. Thanks. Now Dr. Shilpa is going to present a few of our cases.
We have a 27-year-old girl. In May 2017, she presented with pain and swelling in multiple joints with early morning stiffness lasting for more than 1 hour. The duration of symptoms was 5 months. There was on and off fever with no explained cause, and there was fatigue and photosensitive malar butterfly rash and mouth ulcers. On examination, there was pallor, tenderness of proximal interphalangeal joints of hands and toes, and there was a typical malar rash. Blood investigations revealed normal CBP, elevated ESR, RA factor was normal, ANA was 4+, and it was nucleus granular type. Anti-DNA was negative. Her urine routine was normal. Based on the clinical features and the laboratory parameters, she was diagnosed as SLE, and she was started on hydroxychloroquine, Vislon, and azathioprine. She had a good response to the treatment. After a month, she had decreased joint pains and fever subsided, and ESR reduced. She was continued on azathioprine. On 4th July, she presented with fever for 15 days, cough with mucoid sputum, vomiting and loose stools. There were no joint pains or rash in the present admission. On presentation, patient was in hypotension and tachycardia. She was febrile. Temperature was 103 degree Fahrenheit. Chest is clear bilaterally. There was no rash, active synovitis, no ulcers. So possibilities we considered were sepsis or a disease flare. The blood investigations showed leukopenia. Initially on admission, the total count was 3,600. HP was 9.6. ESR was 67. And this time anti-dsDNA was positive. Initially it was negative when the diagnosis of SLE was made. Procalcitonin was negative. There was hypocomplementemia. Blood cultures and urine cultures are negative. CT chest is normal. But there was she was started on antibiotics along with low dose of steroid, but there was persistent leukopenia, so we did a bone marrow biopsy. Report is awaited, and we have started her on filgrastim and broad spectrum antibiotics. She improved clinically for the last 2 days. Today's total count is 9,000. her hemodynamic parameters was stabilized after admission. So it's a diagnostic confusion whether it is a sepsis related to leukopenia or a disease flare causing fever and other manifestations. Till now we have not got the evidence of any infection or infectious foci. Blood culture is negative, sir. Urine culture is also negative, sir. Since the complements are low and dsDNA is high, the possible diagnosis is in favor of lupus flare rather than infection. But due to leukopenia, underlying superadded infections cannot be ruled out, so we are giving broad spectrum antibiotics as well.
Sorry. As precalcitonin is raised, as procalcitonin normal, we have gone to the higher antibiotics, madam, because it's almost rules out the infection process.
Yes, but her sputum culture was negative, but her sputum Gram-Stein was showing pneumococci. So empirically we are treating her with antibiotics. Presently there is no active synovitis.
She doesn't have temperature.
Now she is afebrile, sir. After admission, she's been afebrile.
But this is actually, she came with the infection, sir. At that time, presentation, she had fever, chills, and on the day of admission, she'd have loose motions for a couple of days. So while treating infection, her counts also dropped down further, and C3 is very low. Yes. So presented as infection, simultaneously she said a lupus flare also. So it's very difficult these cases how to manage. Luckily her count today is 9,000 white cell count. Yesterday it was 1,200. She's puffed up actually because at the time of admission her BP was 60. So a lot of fluids were given. That's the reason she puffed up. So she needed. Yeah.
Maybe she's chilly, but that's in her back.
Clinically, according to laboratory department, she's getting better. We worried about the counts. Yesterday, 1,200 before. Steroids, we gave steroids along with. She was on antibiotics. At the time of admission, I think she was only 5 milligrams. So now she's on IV steroids. She was on inotropic support. Now she was off inotropic support. Now she's maintaining her BP. So that was.
She's Mrs. Kamala, a 70-year-old lady. She's had history of polyarthritis for many years. She also had history of bronchiectasis. Initially, she was tested positive for RA factor. Few years ago, she was diagnosed as rheumatoid arthritis and was started on oral DMARDs, but she was on irregular treatment. For last 2 years, she's been on sulfasalazine and oral steroids. There was no polyarthritis for the last 2 years. This admission, she presented with decreased food intake, vomiting for 15 days, weight loss about 8 kg over last 6 months, excessive dryness of mouth, difficulty in swallowing food. On examination, there was pallor. They were palpable left lower cervical lymph nodes. Bilateral co-scapitations were present on chest auscultation. Investigations showed severe pancytopenia. HB is 5.5. Total count was 1,700. Platelets were 7,000. ESR was high. RA factor was positive. Along with that, ANA immunofluorescence was positive and it was showing nucleus granular pattern. Anti-DS-DNA was positive. ANA profile showed positive SSA, row 52, strong positivity. Complements were low. Urine showed 16 RBCs per high power field. Direct Coombs test was positive. CT chest showed bilateral bronchiectasis. Along with that, right mild pleural effusion. USG abdomen showed minimal ascites. Creatinine was normal. So, with the clinical features and laboratory parameters, the possible diagnosis considered was SLE, but considering the weight loss and cervical lymphadenopathy, COX was to be ruled out because she was on steroids for last 2 years. Lymph node FNAC and Mantoux test was done, reports awaited. She is now being treated with hydroxychloroquine and IV antibiotics. Initially, on the day of admission, the counts were platelet counts were very low, so she had to be transfused with platelet transfusion. She was subsequently her counts improved.
How much was the platelet count?
Sir, on admission it was 7,000. Today it is 30,000.
So the reason why we are presenting this case is rheumatology subject is very dynamic. Whatever you see tomorrow, maybe 5 10 years down the line, the diagnosis may change. This is one of the best examples. 8 years back, she did have polyarthritis. Rheumatoid factor positive. She was treated at AIM CMC Vellore as rheumatoid arthritis patient. And she got better. She stopped medication. She was off the therapy, no symptoms. And now symptoms since when?
Since 15 days. 15 days history.
So unwell for the past few weeks with severe cytopenias. And we thought it was any drug-induced, bone marrow suppression. But when we saw her medication, hardly she was on any medication because she stopped it long time ago. She restarted, but it's not looking like drug-induced. So we did connective tissue profile. She's strongly positive for ANA, DNA, and several ANA profile were also positive. So initially it was like rheumatoid, but so it was not rheumatoid to begin with, probably lupus. 8 years ago she had lupus presenting as a polyarthritis, went into remission on its own or with the help of drugs, maintained so well 8 years, now coming with a flare. So that's what rheumatology is. So we have to monitor the patients very carefully. So we have to, sometimes, I test myself whether I'm going in the right way or not. Every time when the patient come in, are we doing the therapy appropriately? Are we missing any other things? I had few patients presenting as psoriatic arthritis. Because inflammatory arthritis, psoriatic lesions, psoriatic arthritis. 2-3 of my patients, they developed lupus later on. The reason was psoriasis can be part of lupus because they come with psoriatic type of rash. So then it looks like psoriasis. So over a period of time, they develop full-blown lupus. No,
previously it was done, sir. It was negative.
And at that point of time was negative.
Yes.
So initially sometimes these all things may be negative with symptoms.
Yes. Anything else? That's it.
She's a 11-year-old girl. She presented with fever for almost 5-month duration, on and off, and then myalgias involving lower limb, ulcers in the nose, nasal cavity, and diffuse alopecia. On presentation, there was no synovitis, no rash. Systemic examination did not reveal any abnormality. On diffuse alopecia was there, non-scarring alopecia. Laboratory parameters showed normal CBP. ANA was positive, nucleus homogeneous type. Anti-dsDNA and anti-Smith antibodies were strongly positive. RF factor is negative. Urine examination revealed 1+ proteinuria. 24-hour urine protein was 400 milligram per deciliters. And she had transaminitis. SGOT was 175. SGPT was 182. ESR was 75. Mild hepatosplenomegaly was there. Recently, she presented to the rheumatology OP. She has been admitted with in various hospitals with a diagnosis of pyrexia of unknown origin. Recently diagnosed as SLE. Started on disease-modifying drugs.
Hepatic enzymes are elevated.
Yes. So she's been on multiple drugs previously for fever and myalgias. Repeat testing we have advised.
She's a very recent patient, sir, actually. She was having polyarthralgia for a long period of time, associated fevers. So she was seen by many outside patient, but nobody diagnosed it. So she was using a lot of NSAIDs, off-label NSAIDs, like... Yeah, juvenile SLE, sir. DGNA is very much elevated, 6 times elevated, normal, and mild amount of proteinuria is there. But 24 hours we have done 800 ml volume was there, 432 was there. So we didn't do any biopsy because we referred to nephrologist. They said we'll observe the patient over a period of time. There was some urine infection at that point of time. So it's been just 1 week we have diagnosed this patient. Sir. Which one, sir? Yeah. No. Because she is having polyarthralgia, joint pains, they come to rheumatology department, and then when we see the other features associated, like fever is there and oral ulcers are there, alopecia is there, and we generally what do we do in this hospital is we do a profile, like for every patient when we suspect, as a routine we do ANA, RA factor and all these things. Majority of the time we pick up the clinical features were also fitting into that. We have just started hydroxychloroquine, steroids and other supporting medications. Yeah, so far she has improved. Last 5 days back she came. Now arthralgias have gone down, fevers are not there. So we just have to follow it up her more.
One of our young lupus patients, she is a very brave girl. She is studying engineering, 2nd year or 3rd year? Yeah. She would like to share her feelings as a patient. Though, does she look like a patient? No. Isn't it? Very smiley face. She is very active and energetic girl. She would like to share her feelings to all the doctors sitting here, especially for young doctors.
Good afternoon, one and all. I'm a 19-year-old student. I've been diagnosed with... I've been diagnosed with SLE 2 years ago. My LA screening ratio was about 0.95 and my ANA and anti-DS DNA were highly positive. I've been started on medication right early in the initial stage of the disease. So right now you can see me, I'm very happy right now. But when my disease was manifested in the initial stages, I could hardly walk. I was bedridden for about 20 days and I couldn't go to college at all. There was this subject called as engineering drawing, which involved us to stand for long hours and make drawings. I was really very apprehensive whether I would pass the subject or not, owing to all my pains. But I was on the right medication and I'm very happy right now. I scored about 96 in that subject. And I've been Dr. Sarath's patient for about 1 year. Before 1 year, I was admitted in hospital once for gastroenteritis and pyrexia. And after recovering from that, I've been consulting Dr. Mouli, and I'm very happy with his medication. Right now, I take about 20 mg methotrexate, 200 mg of HCQ, and 2.5 mg of corticosteroid, along with the other supplements. And you can see me, I'm good, active, and I also play badminton at times. Thank you.
Give my hand. God bless you. Wonderful.
Thank you, doctor.
Can you give initial details, ma'am?
Initial details, okay. Okay, my initial problems were severe joint pains. Severe joint pains in the morning, in the evening. I could hardly walk, all joints, small as well as big. So initial times they wrote it as inflammatory polyarthritis, and I was started with 40 mg of omnacotil, like that is Vislone, for in the morning as well as in the evening, and also had fever, which was constant.
Test was not done?
No, they were done about 15 days later after this, after I was bedridden. And they were highly positive, and then I went.
This 40 milligrams of prednisone helped you?
It helped me before I was bedridden, before taking prednisolone. After taking prednisolone for about 1 week or so, I could walk, I could even climb stairs as well. But I used to have pains and a lot of fatigue, along with alopecia. And so slowly, I've just visited a rheumatologist who just confirmed based on ANA and anti-DS DNA. And then he referred me for going for DRBVT test, and my LA screening ratio was about 0.95. My C-reactive protein test was negative, and then the omnacotil was being reduced. It cut down to 50 mg, then 20 mg, 10 mg, and right now I'm taking 2.5 mg a day. And along with omnacotil, they added the other tablets, like which disease-modifying drugs, and also NSAIDs. And right now I'm very happy and good to be here. Thank you.
Thank you. There's another little small story. A patient of mine, doctor's daughter, lupus patient. She was around 34, 35. She went into remission after started seeing her. Before that, she was a lupus patient for a very long time. And she, a beautiful looking girl. I asked her, why didn't you get married? Because she said, I'm a lupus patient. So I counseled her and her mother also. Last year she got married, now she's in US. So we do a lot of counseling to our patients. So our especially lupus patients, they can lead normal life completely. I have another patient of similar age. What's her name? A hockey player? Priyanka? Yeah, Priyanka. She was completely bedridden at the time of admission, maybe 7-8 months back. Now she is representing national level in the hockey. So a lot of patients, they completely lead normal life. So in counseling, we tell the patient, take medication properly, come for regular follow-up, everything will be fine. Because actually, slides are missing here. Another patient, only in the last 3-4 weeks back, APL. Yeah, one patient, she's around, I think, 22. APL. Unfortunately, at the age of 22, she had seen a lot of pathology. Antiphospholipid antibody syndrome, no lupus in her. She had DVT, pulmonary thromboembolism, hepatic vein thrombosis. Anything else? Peripheral? Yeah, peripheral thromboembolism. Pulmonary? But caring. And suddenly, what happened? 2 weeks before admission, she had a fever. Herself checked her CBP because she thought it was dengue. And platelet were 5,000. She walked into the clinic, she had no other symptoms other than low platelet count. So we were worried. We admitted her. We gave Solimedrol like any other patient, 5 days. There was no improvement. So we had no idea what to do. I consulted several of my colleagues across India, other rheumatologists, and also some hematologists. Nobody had any personal experience. And here I consulted our oncologist. He said she might require a bone marrow transplant. We gave her rituximab, anti-B-cell therapy. It might work, but it won't work immediately. It takes 4 to 6 weeks to show its effect. And counts are not improving. And 5,000, anything can happen. She might bleed internally. So we gave IVIG. With each dose, her count doubled. And the other important thing I forgot to tell you, we did bone marrow. The bone marrow showed severe necrosis of the bone marrow. So that is the reason, she's unable to produce her platelets. With IVIG, her bone marrow necrosis improved. We haven't actually done the bone marrow again. We are repeating her bone marrow again in a couple of weeks' time. Last week, her counts were more than 2 lakhs. So we thought actually we might lose the patient. Luckily, she improved. She's back to normal now. She's back to her job. She's working as a software engineer. Now we are moving to the third session on juvenile rheumatoid arthritis. This will be followed by lunch. Sorry, we are getting delayed. Shall we break for lunch or shall we have this talk? Quick?
We have got 3 cases in this center.
Yeah, okay.
So without wasting time, we'll very quickly go through these theory parts so that we can discuss the 3 cases. And when we discuss those cases, we will go into the details. Like I said, juvenile idiopathic arthritis is a term that is used to describe basically 3 things you need to have. An arthritis presenting in any patient below 16 years of age. And the most important point is exclusion of other conditions. That is a key point that has to be take-home message, because all arthritis that presents in any child below 16 years, longer than 6 years, need not be juvenile idiopathic arthritis. Unless and until we exclude a lot of other conditions very thoroughly, we may miss because unlike in adult, there are many other differential diagnoses crop up for which the treatment is completely different. Like for example, acute leukemias, generally they present with a history similar to more than 6 weeks, below 16 years, arthralgias, rarely arthritis, and they end up, once we start treatment, we just mask the disease for a certain period of time. Like we have got 3 different classification criteria. One is the American College of Rheumatology, the other one is the EULAR criteria, the European Union, and the other one is the International League Against Rheumatism. All of them have got the similar criteria of below 16 years, but the duration of arthritis, like in ACR and ILAR, we follow 6 weeks as a duration, whereas in case of EULAR, they go for around 3 months of duration, that is 12 weeks. Just to exclude other conditions which are like viral arthralgias and all those conditions, to rule out those things, we have got this criteria of 6 weeks, below 6 weeks or 3 months. And then other exclusion criteria will be there. Categories of JAA, broadly speaking, in our daily practice, we use this systemic arthritis, oligoarthritis. Within oligoarthritis, we subclassify into persistent oligoarthritis or extended version of oligoarthritis. What do you mean? We'll go through it at a later date. Polyarthritis, rheumatoid factor positive, negative, psoriatic arthritis, enthesitis-related arthritis, and finally, if the patient does not fit into any of these things, some 10 to 15% of the patients end up in not having any of the diagnosis at the time of presentation. So what we call them is undifferentiated arthritis. Later on, they may evolve into some of the categories too. So, like I said, this differential diagnosis is very important. Why I'm saying is because the incidence of JAA, if you take the international incidence, it is around 3 to 23 per 100,000 population. Whereas same thing, like some disorders like cancers, malignancies, which also have got almost overlapping like 18.6 to 159 kind of things. When we have to exclude these things, there are certain red flag things that we have to notice in any patient presenting to us with arthritis. When you see these patients, do not diagnose them as JAA. We have to take as much time as possible to rule out other conditions like pancytopenia, acute leukemia. Sometimes they present with leukopenias, lymphopenias, thrombocytopenias, and especially leukopenia, we have to see the age-related WBC count. That is because the WBC count in children is a bit different from the adults. In our hospital, for example, as a reference value, we take in adults 4,000 WBC count as a lower normal limit for the adults, whereas in children we take it for age group 5,000. So we have to be specific for the age group of the child, and based on that we need to go ahead. And presence of proteinuria, like it may indicate some other CTDs like systemic lupus erythematosus. Bony tenderness, one of the classic features of acute leukemia, presenting in a very polyarthralgia kind of things. A simple bony tenderness. Rather than the joint, it is the bone that is more associated. We have to be extra careful. Again, skin rash, some other dermatomyositis conditions may also present with arthralgias. Coagulopathies, coarse facial features. This is another important thing. We got pseudorheumatoid kind of conditions presenting to us, which are like, these are genetic disorders, which present to us with coarse facial features and all those things. In those features, unnecessarily starting treatment with steroids and anti-inflammatory drugs will be disastrous. And another bleeding diathesis, like hemophilia conditions, may present with oligoarthritis kind of picture. So unless we are very thorough with these history, it is very difficult to diagnose as JAA. To start off, the first one is the systemic arthritis. Systemic arthritis is basically two variants can be seen. One is the predominant fever and systemic manifestations associated with arthritis. The other one is you can still have systemic arthritis where the predominant feature will be arthritis. So based upon that, the treatment variations will be there. So classic teaching says that quotidian high spiking fever, that fever occurring at the same frequency, same day, the same height of fever occurring, the recurrent kind of fever that occurs. Evanescent non-fixed erythematous rash, that is, but in Indian population we have to be extra cautious because we are generally dark skinned, and that the classic presentation in the textbook may not be seen in our Indian population. And presence of hepatosplenomegaly should lead us to some other diagnosis, but it is still present in systemic arthritis. Generalized lymphadenopathy, serositis, polyserositis will be there, myalgias and abdominal pain. So arthritis is typically, sometimes arthritis may precede or it may be completely absent at the onset of the disease. So these patients end up in like pyrexia for unknown origin kind of treatment. Sometimes it will take 6 months to 1 year before finally the arthritis comes out. In those patients it will be very, very vexing because we do not know the diagnosis. We do not have any laboratory diagnosis to say that this is JAA or anything. I have got a patient, like a 12-year-old, a 10-year-old patient, I think, who presented to us OP, to the pediatric OP with complaints of only fever. at Vizag, basically, Vizag Medical College, basically. So there they have diagnosed almost from bone marrows, multiple bone marrow examinations. They have done tuberculosis evaluation. Complete evaluation was done for nearly 6 months. That patient was almost in the hospital for nearly 6 months. And like I said, in dark skin population, that classic features of skin rash may be completely absent. There was absolutely no amount of arthritis in this patient. They could not diagnose him. They were only giving antibiotics. Multiple episodes of AT were given. He never responded. And then he came to Hyderabad. And again, it took us 2 to 3 months. And suddenly one fine day, that patient had arthritis. And completely the treatment has changed. Once we started on methotrexate, he did respond initially. We don't have evidence for methotrexate in systemic arthritis, but in India, because biologics are not so affordable, we generally tend to treat initially. And later on, we did go for anti-IL-6, and he did respond a lot better. So this accounts for 10 to 15% of the all population of JAA. And other differential diagnosis, like I said, malignancies, infections, bacterial, viral, has to be done. This is a classic manifestation of the quotidian fever that happens every 24 hours. The same height of the fever, 40 in this patient. The left side one, we see the evanescent non-fixed erythematous rash, whereas the right side one is the rash of the rheumatic fever. So but in Indian population, we had to be extra cautious to diagnose that. And we can see the polyserositis kind of picture in this patient. And the second category, that is the oligoarthritis. Like I said, it affects around 4 joints. Maximum amount of joints that is affected at the time of presentation is 4 joints. But if this 4 joints is going to be there for a prolonged period of time, more than 6 months, it's called persistent. Whereas if it extends to other joints beyond 6 months, then we call it as oligoarthritis extended variant. Generally, it occurs before the age of 6 years. Female predilection will be there, along with positive ANA. And those patients, these positive patients, positive ANA with female predilection, onset before 6 years, they got high risk of developing chronic iridocyclitis. This point is very important because when I say chronic iridocyclitis, acute iridocyclitis, we need to differentiate. Because acute iridocyclitis present with acute redness of the eye, and the patient himself says painful eye, photophobia, all those features will be there. Whereas by the time these patients present to us, they are like, this is a white eye completely. So unless we see the details, we may miss, because ultimately they end up in blindness. And one of the most important causes of blindness in JAA ends up with this oligoarthritis, unless we follow them specifically over a period of time with an ophthalmologist. And like I said, persistent oligoarthritis, an extended version of oligoarthritis. Here we can see the example of a single joint, knee joint getting involved, oligoarthritis. Here in the MCP joint involvement, we can say PIP joint involvement, I'm sorry. And like I said, 1/3 of the patients develop chronic non-melanomatous anterior uveitis, and one or both eyes can be involved, and asymptomatic, that is the point what you have to remember. Here we can see the chronic anterior uveitis with band keratopathy and some keratic precipitates. And there is a classification, we got some guidelines when we should send a patient with oligoarthritis, juvenile rheumatoid arthritis, juvenile idiopathic arthritis to, depending upon the ANA positivity, depending upon the age of onset of disease, depending upon the disease duration, we categorize them into high risk, moderate risk, and low risk. What do you mean by high risk, moderate risk is the frequency of examination with an ophthalmologist. Like when we say high risk, we examine them every 3 months, whereas moderate risk is every 6 months. If it is low risk, every 12 months ophthalmological examination is mandatory. Polyarthritis, again, 2 types, rheumatoid factor positive, rheumatoid factor negative, affecting 5 or more joints at the onset of the disease. Again, a patient presents to us first, oligoarthritis extended version has to be deleted. It accounts for around 15 to 20% of the population. Again, we got 2 types here, overt symmetrical synovitis, like these are negative ANAs, onset at school age, small joint involvement, typical to adult onset kind of thing, raised ESR. The other one is the polyarthritis, but associated with symmetric arthritis, ANA positivity, and female preponderance. These patients typically behave similar to what the oligoarthritis patients present. Here we can see the involvement of multiple small joint involvement is there. And the other version is the polyarthritis rheumatoid factor positive. Here again, we got 5% of the populations are less present in a similar way. They almost onset during late childhood or adolescence. Rapidly progressive and destructive disease, but fortunately it accounts for less than 5% of the population. And psoriatic arthritis version, diagnosis of psoriatic arthritis requires arthritis plus typical psoriatic rash. But how many patients we see in a children population with a typical psoriasis is very less. Generally, we tend to have arthritis plus family history of psoriasis in first degree relative and or dactylitis presenting along with nail pitting. Some of these features may be there. And it represents around 5 to 10% of the population. Unless we go in detail with the history, we look at the family history, general examination, sometimes we tend to miss this psoriatic arthritis variant. The next category is the enthesitis-related arthritis. It accounts for another 5 to 10% of all JAA. This is one of the most difficult diagnoses to make because enthesitis, generally it tends to have like a patient present with more of plantar fasciitis or chest pain kind of things knee joint involvement associated with, there is no arthritis, synovitis, effusion is not there. Unless we look in detail about these patients into the detail, it may sometimes be missed. And here the differentiating point is these patients present with a symptomatic uveitis, unlike in oligoarthritis where there is an asymptomatic presentation, white eye, and this is more of painful eye, photophobia, pain presentation will be there. Finally, again, like I said at the outset, 10 to 15% of the patient at the onset will be very difficult to classify them into any of those one categories. So these patients will be called undifferentiated category. How do we treat them is depends upon tailor-made, like we need to follow them up over a period of time, how they evolve, what they end up into. And just a brief mention of the treatment of JAA, it depends, it is ultimately the only common take-home message is we need to diagnose unless until we come to a proper absolute diagnosis. Do not attempt to treat these patients. Maybe we can give some NSAIDs or those things, but other medications like steroids especially, without coming to a conclusion, because if it tends to be like acute leukemia, once we give steroids, they end up into, we'll be in a big mess basically. So we need to have a combination of rheumatologists, social workers, physical therapists, occupational therapists. We got few cases where we can discuss the need for all these combination therapy, because unlike adult, these patients will go up into the one patient that we have seen in Dr. Prasanna has presented that recently, that boy with Harsha. Just we saw that patient, juvenile angst patient who presented initially. That just tells us how a combination of therapy, because and this is just an algorithm for medical treatment of oligoarthritis. What we do is basically when we see oligoarthritis, when we rule out all other conditions, we start off with either NSAIDs, along a good dose of NSAIDs, which does not cause any side effects, and then we try to see whether a patient improves. If there is improvement, we tend to continue with that. Or intra-articular injections. Intra-articular injections is one of the, triamcinolone is what being used, but generally we tend to use methylprednisolone in our population. If there is an improvement, or we continue with that. If there is no improvement within 1 year, we can do like 6 monthly injections of 1 or 2 joints that are involved. If it is not involving, if it is inadequate response, if the patient extends into polyarthritis kind of thing, then addition of methotrexate, sulfasalazine, leflunomide. Again, we have to be extra cautious with using leflunomide because these are children, and anti-TNF therapy is at a later date. Polyarticular JA, we tend to treat in a similar way initially, but along with that, these patients tend to have more of corticosteroids. If they don't respond, methotrexate is the next line of therapy, along with alternatives like sulfasalazine, leflunomide. Ultimately, some set of population will not respond to any of these things. They end up with anti-TNF medications like etanercept, adalimumab, abatacept, tocilizumab. Again, systemic onset JEA, like I said at the outset, some patient, we have to decide whether the predominant feature is the arthritis or the systemic manifestations. Based on that, if the predominant feature is arthritis kind of thing, we tend to treat them like oligoarthritis or polyarthritis kind of. Similar picture like NSAIDs, maybe steroids, maybe methotrexate. But if the predominant feature is fever, other systemic manifestations, then I think the best step would be systemic corticosteroids. And if there is no steroid-sparing agents like anti-IL-1 treatment, anti-IL-6. Methotrexate is off-label. We do use in certain patients. Some of them respond, some of them don't, because anti-IL-1 and IL-6 is what is available in our country. It is very costly, so some patients do not take it over. And finally, there is some role for stem cell transplant in these patients, but rarely is being done. And that's all. So we'll just discuss some cases briefly. So based on that, we can have some doubts. Thank you very much.
A 15-year-old boy, he's been suffering from joint pains for the past 10 years. Usually affected joints are bilateral knees, wrists, elbows, shoulders, MCPs and PIPs. There is no involvement of the ankle. Prior to the onset of joint pains, he had a history of fever 1 year prior to this. History of occasional oral ulcers on and off pattern is present. Early morning stiffness for about 1 hour is present. He has stunted growth. His height is 130 centimeters and his expected height is 172 centimeters. Previously, he was being treated with Folitrax, SARS, HCQS and lodosteroids.
Stunted growth. So initially had polyarticular kind of picture. Methotrexate was started because patient's parents was, they didn't afford initially, so they could not go for IL-6 at that point of time. His ESRs, even before starting IL-6, we did start to give him some relief. He was using NSAIDs very recurrently, like every day he had to use. Steroid dosage was very high. So that was resulting in stunted growth. We didn't do DEXA scan for this patient, but definitely he might have developed some osteoporotic feature. The last patient that you saw, the child with disability, eyes are okay, sir. It's not an oligoarthritis kind of picture, polyarthritis. That patient, the reason why he was developing so many deformities, contractures, the wheelchair boy, was basically because that child had a DEXA scan of -5. Basically, I have seen for at the age of 18 years. The problem we faced with the DEXA scan is when we send for a DEXA scan, they enter the age. Based upon the age only, you get a T-score. We don't have DEXA measurements for a 15-year-old child. The computer does not accept it. We have to increase it up to 18 or 20. For that child, we have to make it up to 21. So that kind of, because what happened was that during surgery, what happened, that patient, initially he went to NIMS. They said they used sulfasalazine and methotrexate. The patient went for other alternative medicines. During that time, he deteriorated completely. When he came back, it will be a lot more in pediatric population rather than that. So this patient, only to prove that, later on, even now he is symptomatic, but his height can't be regained. So these anti-TNF therapies have to be started very early in these patients. So that's it. We have sent to the ophthalmologist. So far, he didn't develop so far. It may be because of both the steroids and because of the disease activity itself, because so much pro-inflammatory, ESR is around 170, 80, pro-inflammatory things will itself cause stunted growth. And steroids, especially in pediatric population, if we use steroids, they definitely cause osteoporosis. In any other adult also, they may cause osteoporosis and these things, but disease itself will cause osteoporosis. So if we control the disease itself, so there are studies showing that if you use steroids in some patients and immunosuppressants, they will end up with having lesser osteoporosis than those patients who do not use them. So that way maybe.
The next case, a 14-year-old boy has been having complaints of lower backache for the past 3 months, joint pains in the form of left knee, left ankle. Occasionally, he has bilateral involvement of hips, knees, and the left ankle. There is tenderness and swelling of the left ankle for the past 3 months. He has history of fever whenever there is a flare of joint pains, no history of rash. Early morning stiffness for about 15 to 20 minutes is present. He has increased fatigue. Gait abnormalities have been present, and amongst the investigations, his ESR is consistently elevated. Once it was 110 and then 60 mm per hour. His RA factor is negative, CRP is positive, is HLA-B27 positive, and the MRI showed right hip effusions with bilaterally normal sacroiliac joints.
This is basically juvenile Angstpond kind of variant that I have seen. Initially, he was admitted with an orthopedician, basically. They referred to us. So when he came to us, they thought it was septic arthritis because at that time only hip was involved, basically. They have done hip, biopsy was done just to rule out any septic arthritis or any tuberculosis, but that was not there. So once he came to us, we diagnosed other things and started on basically sulfasalazine. He's doing well so far.
How common is Angstpond at this age?
It is like we do see patients often.
You see them around 18 or 19 years.
We do see a lot of them.
Prasanna, do you see a lot of cases Angstpond at this age? What I teach my students is maybe 18, 19. But
juvenile Angstpond is a completely different variant of this.
Actually, for each group of juvenile idiopathic arthritis, each subset, there is a different age of onset. So if you take oligoarticular type of JA, the commonest presentation is between 7 to 12 years. If you take polyarticular, again 8 to 12 years. For this spondyloarthritis, we say juvenile if it is less than 19 years, but the common age is again between 12 to 18 years. And systemic onset of JA, at any age they can present.
It itself is an entity, sir.
Different entity.
It's a pediatric, pediatric age group juvenile spondyloarthritis. So now they call it enthesitis-related arthritis.
Depending upon the steroid is also there, sir, right now. NSAIDs and steroids. Methotrexate we thought of using, but again his SGPT-SGVT was very high initially, so it's just a new patient, so 1 month back he came to us, so we'll follow up the patient.
11-year-old girl came to OPD with complaints of joint pains for the past 6 months. Joints involved are bilateral knees, elbows, ankles, and wrist joints. History of joint swellings in the left knee and the left wrists are present. Early morning stiffness for 15 minutes is present. I have a picture, ma'am, of the knee.
First we'll show the patient.
Should I ask her to raise There is inflammation of the right wrist and the left knee. There is
There's more of tenderness than the effusion or synovitis here. What we see is, this patient is a very new, she just came yesterday.
Classical
she is having complaints on and off. 6 months back, 6 months, since 6 months she is having more of polyarthralgia. The reason why I wanted to show this case is, when we have seen this patient, she is having, okay, NA is positive. So that is something which is in favor. But one thing was missing was she is having some kind of leukopenia. Like this reminds me of another case. We had a similar polyarthralgia kind of thing where there was, for the age-related leukopenia, that was what I was talking about. That patient, we did similar thing and we started on steroids immediately, steroids and NSAIDs. She did respond initially, but later on there was a recurrence. Then yes, when we did a bone marrow again, it turned out to be a CALA-positive ALL. So in this patient, there is no need to do a bone marrow biopsy as it is because other things are okay, but sometimes in clinically we may miss some things. So just
this picture was taken yesterday evening at 6 p.m. There is marked inflammation of the wrist, which is subsided right now. She's on naproxen therapy.
Only naproxen we started because we wanted to rule bone marrow and then proceed with any other things. I think that's
Before we break for lunch, I request all the doctors to come to the center so we will have a photograph. Please remove those cameras. Can you? Please inside వచ్చేసండి కొంతమంది ఎట్లా నిల్చోవచ్చు. Please come to those who want to be in the photograph. Please come. Otherwise, please come. Just stand up in your chair, in front of your chair. That's it. Please come to this side for the photograph. You can come. No problem. You are welcome. Naveen, Dr. Mohan. ఒకసారి చూసుకో, యాంగిల్ చూసుకో. పర్వాలేదు రమ్మా. వస్తాను సార్, అందరూ ఒకసారి లైన్లో పెట్టి కాసేపు కూర్చోవచ్చు. సిట్టింగ్ వైడ్ అయిపోతుంది, బాగున్నాయి. అందుకని ఎవరి ప్లేస్లో నుంచి ఉంటారు. బాబు సిట్టింగ్ కవర్ అవుతుందా?
సిట్టింగ్ తీసుకొస్తారు,
ఎక్కడ
ఫుల్ఫిల్ చేస్తే సరిపోతుంది.
ఎట్లా
గ్యాప్ మొత్తం కూర్చోబెట్టే సార్ సిట్టింగ్ సరిపోతుంది. స్టాండ్లో హైట్ ఉన్న వాళ్ళు ముందున్నారు, హైట్ తక్కువ వాళ్ళు ఎన్నుకున్నారు.
సార్ యాజ్ పర్ హిజ్ నువ్వే చెప్పాను
సార్, అందరూ కూర్చుంటే సరిపోతుంది సార్. కాకపోతే అక్కడ ఉన్న వాళ్ళని చైర్లు మొత్తం ఫుల్ఫిల్ చేయాలి. ఇటు సెంటర్లోకి వస్తే సరిపోతుంది. కదండి, గ్యాప్ ఎక్కడ ఉంది అక్కడ కూర్చోండి మేడం. స్టిల్ కోసం జస్ట్ కూర్చోండి, ఎక్కడెక్కడ గ్యాప్ ఉంది అక్కడ. కూర్చోండి మేము అక్కడ గ్యాప్లో అక్కడ కూర్చోండి ఆ రోల్లో. ఇది ఫుల్ అయిపోతుంది మేడం, ఇంకో సగం వస్తుంది ఇది. నిచ్చో సార్ వస్తుంది. మేడం కొద్ది ముందు రాండి, ముందుకు 2 లైన్ 2 ఓన్లీ, ఇద్దరు రండి, ముందు రండి మేడం. ఇద్దరు 3 ఉన్నారు అక్కడ మీ పక్కన. ముందుకు రండి 2 వెనక్కి ముందుకు రండి. ఓకే.
I think some of you can shift that side also, because that side is like, yeah, it looks equal. So you can use that side. They're all together.
ఆ డోర్ ఇస్తారా డోర్
theory followed by 50 minutes of live. Theory followed by 50 minutes of live case demonstration and 50 minutes interaction. So we're going to cover roughly 7 to 8 different diseases. Shanti, over to you.
Thank you, sir. Now I request Dr. Bhaskar garu to speak a few words.
అందరికీ నమస్కారం. ఇది కృష్ణా ఇన్స్టిట్యూట్ ఆఫ్ మెడికల్ సైన్సెస్లో ఈ వర్క్షాప్ అనేది క్రియేట్ చేయడం అనేది చాలా ఆనందంగా ఉంది. ఎస్పెషలీ పేషెంట్లందరూ ఉన్నారు కాబట్టి పేషెంటు రుమటాలజీ అనేది చాలా తక్కువ మందికి అవగాహన ఉంది. ఈ నొప్పులు రాగానే ఎవరైనా కూడా మందుల షాప్కి వెళ్ళి ఒక అనాల్సిక్ తీసుకుంటారు. తీసుకున్న దానివల్ల ఆ నొప్పులు అంతవరకు తగ్గిపోతాయి. తర్వాత అలా తీసుకున్న తర్వాత మళ్ళీ ఇంకో ఎంబీబీఎస్ డాక్టర్ ఎవరో ఒక ఫిజిషియన్ దగ్గరికి వెళ్తారు. వాళ్ళకి అవగాహన కాకుండా ఇంకొంచెం ఎక్కువైన అనాలిసిక్స్ ఇస్తూ ఉంటారు. సో బేసిక్గా మనం ఈరోజు చాలా వరకు జబ్బుల్ని పేషెంట్లు అటు మెడికల్ పర్సనల్ కూడా ముదిరిపోయిన దాకా ఉంచి తర్వాత టెర్షరీ కేర్కి పంపుతున్నారు. దానివల్ల ఆల్రెడీ చాలా వరకు పేషెంట్స్కి డ్యామేజ్ అవుతుంది. అప్పుడు ట్రీట్మెంట్ చేయాలన్నా కూడా కొంతమంది ఇర్రిపేరబుల్ డ్యామేజ్ అయిపోయి ఉంటుంది. కొంతమందికి మనం ఎంత చేసినా కూడా ఉపయోగం లేకుండా పోతుంది. ఇలాంటి అవగాహనలో అసలు ఏ స్పెషలిస్ట్ దగ్గరికి ఎలాంటి జబ్బుల్ని ఇనిషియల్ స్టేజెస్లో మనం కనుక పంపితే కనీసం మనకు ఆ రొమటాలజీ అనే సిమ్టమ్స్ ఏంటి, అనాలిసిక్స్కిను పెయిన్స్కి డిఫరెంట్గా ఉండేవన్నీ కూడా మనం కనుక తెలుసుకోగలిగితే ఈ అవగాహన ద్వారా చాలామంది పేషెంట్లను మనం సేవ్ చేయగలం. అదే కాకుండా ఈ ప్రతి మందు కూడా ఏదో కొంత సైడ్ ఎఫెక్ట్స్ అనేవి ఉంటాయి. ఈ అనవసరమైన మందులు తీసుకొని ఈ సైడ్ ఎఫెక్ట్స్లో బాడీలన్నీ కూడా డ్యామేజ్ కాకుండా ఉంటుంది. కాబట్టి అందుకనే ముఖ్య ఉద్దేశంతో ఈ కృష్ణా ఇన్స్టిట్యూట్ ఆఫ్ మెడికల్ సైన్సెస్లో ఈ ఆడిటోరియం కట్టిన గత 2 సంవత్సరాల్లో దగ్గర ఒక 60 వర్క్షాప్స్ నేషనల్ లెవెల్ నుంచి ఇంటర్నేషనల్ లెవెల్ నుంచి మనం పెట్టి ప్రతి స్టూడెంటు ఎవరైతే మెడికల్ ఫీల్డ్లో ఎంటర్ అవుతున్నారో వాళ్ళందరికీ హౌస్ సర్జన్స్కి, పోస్ట్ గ్రాడ్యుయేట్స్కి, అదేవిధంగా పేషెంట్ పాపులేషన్కి కూడా అవేర్నెస్ క్రియేట్ చేయాలని కిమ్స్ టీవీలో మనం కిమ్స్లో ఉన్న ప్రతి ఓపీడీలో ఈ అవగాహన అనేది పెడుతున్నాం. ముందు చాలా వరకు అవగాహన అనేది వస్తే చాలా వరకు మనం డ్యామేజ్ని స్టాప్ చేయొచ్చు. సో వన్స్ అగైన్ థ్యాంక్స్ ఫర్ దిస్ రొమటాలజీ డిపార్ట్మెంట్ కిమ్స్లో ఇలా వర్క్షాప్స్ 2-3 వీక్స్ బ్యాకే ఒకటి చేశారు, మళ్ళీ ఇప్పుడు చేస్తున్నారు. కంటిన్యూస్గా అలా చేస్తూ ఉంటే మనకి బాగా ఉంటుంది. ఈరోజు దగ్గర మనకి కొన్ని వేల మంది రొమటాలజిస్టులు ఈ కంట్రీకి అవసరం, కానీ 500-600 ఉన్నట్టున్నారు మొత్తం కంట్రీ మీద. సో అలాంటప్పుడు అందరూ అవగాహన తెచ్చుకుంటే తప్ప ఈ డ్యామేజ్ని మనం అరికట్టలేకుండా పోతాం. వన్స్ అగైన్ థ్యాంక్ యూ వెరీ మచ్.
Thank you, sir. Now I request Dr. Kakala Subbarao garu to address the gathering.
Good morning. Dr. Bhaskar, CEO, Dr. Yarkarao, my good friend of mine, and today's convener, Dr. Sarath, senior faculty, members of the AMA Association. I'm very happy to be here. They announced already today is a Guru Purnima. You know who are my gurus? Students. Although I'm a non-clinical subject, still patients are my gurus. Without these two, medical services cannot go further, they cannot progress. Be as it may, I came to know that registration is free. It is unheard of in corporate hospitals. Unfortunately, not many people have taken advantage of it. Second thing, as a radiologist should be a clinical radiologist too. I always tell my residents, in fact, while I was working at Osman General Hospital, a resident should be at the reception desk of requests. He has to read the requests. You know, most of you, the requests are incomplete. So he has to take clinical history, see, then interpret the films. That's how we can give maximum service to the patients. And Dr. U.R.K. Rao, he was my colleague at Nizam's hospital, and that was the first institute that started rheumatology, actually. Okay. In my days, there was no rheumatology, actually, but everything is under general physicians. They used to do rheumatology, nephrology, gastroenterology, everything. But today, I'm glad that rheumatology has stood on its own as a particular specialty. I have a DM student from Nizam's who is practicing in Cochin. Every month, at least 12 cases he sends. 12 cases in the internet. And you know what type of cases? Have you heard of post-variolar effects on the joints? Post-variolar. We had a smallpox epidemic in early 1960s. We used to have many cases, particularly in children. Have you heard of it? Post-smallpox affection. One case he has sent to me without a diagnosis, 60-year-old, with long-standing disability of the elbows. And I said, it's post-variolar. Then he wrote to me, yes, sir, I took the history, he had smallpox in his childhood. Like that, it's not just rheumatology comprises everything, musculoskeletal system. And today I'm glad he has added immunology after my advice from the last CME. And this is dealt by not only rheumatologists, most of the surgical part by the orthopedic surgeons, and rehabilitation part by the physiotherapists, and the sports part of it, the sports medicine people. That's how it is divided and practiced today. The importance of radiology. I don't know whether the workshop is only for clinical patient. Without the radiology, you cannot practice rheumatology. I mean, you can initially diagnose. I mean, there are so many RA negative patients, so many HLA-27, B27 negative patients. All these, when a real clinical radiologist sees, he diagnoses this. And you know, joint, I just tell the principles of how to read a joint film. First of all, establish whether it's a bone abnormality or a joint abnormality. Because some bone abnormalities like osteonecrosis and infection can extend to the joint. But having established a joint abnormality, see whether it is monoarticular or polyarticular. And then if you look at the joint radiograph, how do you interpret ABCDs? A, alignment. Is it subluxed? Is it dislocated, telescoped, or is it ankylosed? B, bone density. There are certain arthritis where there is no para-articular osteoporosis. This is very, very important. For example, take osteoarthritis. There is no para-articular osteoporosis. Rheumatology, yes. All acute inflammatory joint disorders have para-articular osteoporosis. And then see, cartilage. Actually, you can't see the cartilage on the film. You only the space. But sometimes the space is widened because of the hypertrophy. For example, take acromegaly. The space is widened. Sometimes it's atrophied. Many of the conditions, including osteoarthritis, so thin space. And rarely it may calcify. Take actinosis, hemochromatosis, and CPPD. What is CPPD? Calcium pyrophosphate dihydrate disorder. There also you can get calcification. And then D, distribution. This is very important. When you look at the patient, is it involved in the terminal interferon joints, metacarpophalangeal joints? Is it like that? You have to know the distribution. For example, take psoriasis. It doesn't uniformly involve all the joints, unlike the rheumatoid arthritis. And then erosions. Most of them have no erosions, identify, and enthesopathy. For example, ankylosing spondylitis, Rider syndrome, psoriasis, they have enthesopathies. And then hibernation. Hibernation is just opposite of erosion, sclerosis. Yes, synovial thickening, soft tissue swelling, and study the synovium. Sometimes the synovium may calcify. I'm almost, instead of inaugurating the conference, I'm almost giving a lecture to all of you. But this is fundamental. If you carry this is the home taking message. If you carry this, I'm sure you'll be a wonderful rheumatologist. Well, with these few words about CME and KIMS, unlike other hospitals, private hospitals, KIMS is also a teaching center. Although there is no college, it's a lot of attention, thanks to Dr. Bhaskar, has paid a lot of teaching programs going on. Third, after all, medicine is service, training, education, and a little research. That research also has started a department, and I thank him for that. And today, ladies and gentlemen, have a nice time. If you have time after 4, look at particularly the rheumatology department and have a look and give some suggestions. Thank you very much.
Thank you very much, sir. You're a true inspiration for all of us. Now I request Dr. U.R.K. Rao Garu to share a few words of wisdom to the young doctors gathered here.
Good morning. గురువులకి అభివాదం మీ అందరికీ అభినందనలు. When I started rheumatology services from All India Medical Sciences, I did the post-graduation. The thesis was on rheumatoid arthritis. Professor A. N. Malaviya was my first guru. Later on, when we came, rheumatology, it's just joint pains. Everybody has knee pains. So but we didn't understand that it encompasses autoimmune diseases like SLE, scleroderma, polymyositis, many other things. So in this session, Professor Sarath Chandra Mouli would be dealing with the clinical rheumatology, how to first exposure. In rheumatology, history is more important. That's about 80%. Examination is about 15%. And investigations 5%. And among them, radiology, as Professor Kakala Subbarao was mentioning, has a paramount importance. So we shall have the clinical examination, clinical rheumatology, which I would be actually looking for, how much I can learn, because the learning is a process which is a continuum in our life. I wish you all the best, and be patient, and then enjoy these sessions. Thank you very much.
Thank you very much, sir. Now we'll proceed to the scientific session. I'd like to thank all the dignitaries on the dais for having taken time to be a part of the inaugural.
Here one good news. Now our department is recognized for DNB program. Till today we have been, thank you sir, thank you very much. Till today we've been running the fellowship program. We have our third and probably the last fellow, Dr. Sridipti. Where is she? Who is Dr. Yorkeres of his only daughter. And our first DNB candidate, Dr. Shilpa. Now it's difficult to get into actual rheumatology. So I was told to get into DM, rheumatology national level, they have to score below 50. In DNB program, because we have, I think, only 5 seats, so they should be around, 10 or below the rank, national level.
Alert from calendar. Vara Prasad TL's 51st birthday. Alert from calendar.
What's that? ఎవరికి వచ్చేసేది. So we are 14 minutes late already. So quickly I start the program. Sir, regarding Dr. Kakal Subbarak's suggestion, sir, we are starting musculoskeletal also in our department, that is high resolution ultrasound. So I'm requesting Dr. Bhaskar to get one for us, because that is the latest thing in rheumatology. So because we can diagnose early rheumatoids, and also it's useful for joint injections, sir. So that's going to be like a stethoscope for the rheumatologists. Rheumatoid arthritis is a chronic and systemic autoimmune disease. It is characterized by symmetric arthritis involving the hand joints, feet joints, elbows, shoulders, and rarely hips. Permanent joint damage may lead to disability within 2-3 years if untreated. TNF is the main cytokine involved in the pathogens of rheumatoid arthritis. What are the risk factors? Female gender. Females are 3 times more commonly affected than males in rheumatoid. And environmental factors like low level of education and low socioeconomic status. Smoking is strongly associated with RA pathogenesis. Genetic, HLA-DR-B1 and PTP-N22 gene polymorphism associated with RA. In the first picture, you can see early rheumatoid and moderately active RA and severely advanced rheumatoid. ACR criteria, this is 87 criteria, 1987 ACR criteria. There are 7 criteria. These are early morning stiffness of more than 1 hour, arthritis of 3 or more joint areas, arthritis affecting the wrists and finger joints, and symmetric joint involvement, rheumatoid nodules, positive rheumatoid factor, and radiographic changes. If one has at least 4 out of 7, we are dealing with rheumatoid arthritis. The duration should be more than 6 weeks. The latest criteria, 2010 ACR EULAR criteria. Why we have come up with this new criteria is, in the old criteria, we are missing out the early rheumatoids. So in 2010 criteria, joints given weightage up to 5. But here, if you see the large joint, if one large joint is affected, only 0. Even up to 10 large joints, only score 1. If more than 10 joints, including the small joints, score 5. And rheumatoid factor positivity, 2. If the titer is high, score 3. Symptom duration more than 6 weeks, 1 score. Acute phase reactant CRP, ESR elevation, score 1. So total score is 10. If the patient has got 6 or more, then we are dealing with rheumatoid arthritis. What are the differential diagnoses for RA? Everybody knows chikungunya. So somebody comes with chikungunya arthritis. Difficult to say whether chikungunya or not in the early stage, because it can exactly mimic like rheumatoid arthritis. That is the reason we have to wait for 6 weeks. Other differences like polyarticular gout and seronegative spondyloarthritis, other connective tissue diseases like lupus and rarely sarcoid. The common tests, autoantibody tests we do in rheumatoid factor and anti-CCP. Rheumatoid factor test should be carried out in people with suspected RA. If somebody is coming with just joint pains without signs of inflammation, don't ask for rheumatoid factor. First you have to suspect clinically RA, then only you ask for rheumatoid factor. Anti-CCP is highly specific, superior to rheumatoid factor. We consider measuring anti-CCP in people with suspected RA, but they are rheumatoid factor negative. This is pannus formation in rheumatoid arthritis. What is the prevalence of RA? Around 1%. So in India, at this moment of time, probably there are around 13 million people suffering with rheumatoid arthritis. But how many rheumatologists we have? In India, around 500 to 600 probably, but qualified people like Dr. Vijay Prasanna, probably how many? 50? Less than that. In AP Telangana together, probably around 35 plus. When compared with the West, like US, which is less than 1/3 of our population, the number of rheumatoids around 5,000. So if you take that number, and convert that in Indian population, we need around 15 to 20,000 rheumatologists. Unfortunately, I think there are 7-8 centers for the DM course, and less than that. And DNB, for the entire India, we have only 5 DNB seats. And KIMS is one among those centers, and only 1 center in South India. So I encourage all the youngsters, think about this seriously. If you want to be rich and popular, take rheumatology. It's a very gratifying field. You can share, you can see my patients' feeling when they get better. Very gratifying field because we have latest treatment modalities available. With that, you don't see any deformities if you start treating them early. This is early rheumatoid arthritis. Is it familiar? In monozygotic twins, around 30 to 50%. Dizygotic twins, 2 to 3% risk. If there is HLA B12 cell association, 30% increased risk. The diagnosis of RA is predominantly clinical one. Actually, all rheumatological disorders, clinical diagnosis based on our clinical equipment. So labs are the secondary. First, we have to have proper history and physical examination. Rheumatoid nodules, episcleritis in rheumatoid arthritis. Rarely rheumatoid patients can present with scleritis as a first manifestation, which is equivalent to vasculitis. Early rheumatoid. Chronic rheumatoid with swan neck deformities. The disease usually progresses from the periphery to the more proximal joints, and patients who do not fully respond to treatment result in significant locomotor disability within 10 to 20 years. How do they present? 5 different ways RA can present. Polyarticular presentation, intermittent or migratory, monoarticular, polymyalgic onset. Polymyalgic onset, usually they present with stiffness, severe stiffness in the morning, involving the hips and shoulder girdles, and palindromic rheumatism. Palindromic rheumatism, the onset of RA is episodic in few patients with 1 to several joint areas being affected sequentially for hours to days, and symptom-free periods that may last for days to months. So, usually rheumatoid polyarticular, but if it is palindromic variety, the patient tells us that usually 1 or 2 joints affected at any point of time, and it is self-limiting initially, because in some patients they progress to rheumatoid. So the patient says, doctor, I have involvement of the finger joint, like for example thumb. After 1 or 2 days it goes away. Maybe after 15 days or a month, after 3 months, it comes in other joint. So it's a shifting, migratory type of joint pain and swelling with clear-cut signs of inflammation. So this is called palindromic rheumatism. And monoarthritis, persistent single joint arthritis, very rare, frequently involving the large joints. And over a period of time, it will involve other joints. But until then, that time, we have to treat it as a monoarthritis only. Don't treat it like a rheumatoid. You have to keep the patient under observation. What are the extra-articular manifestations of RA? Anemia, fatigue, rheumatoid nodules, pleuropericarditis, neuropathy, episcleritis, scleritis, splenomegaly, philtes, Sjogren's, vasculitis, and rarely renal amyloidosis. Nowadays, we hardly see amyloid in rheumatoid patients because of the good treatment available. Involvement of the axial joints like atlantoaxial joint, acromioclavicular, sternoclavicular, temporomandibular, shoulders, hips, they're less common in rheumatoid patients. Natural history of RA. 70% of the joint erosions detectable by X-ray, hands and feet occur in the first 2 years of the disease. So first 2 years is very important. That is the reason we have come up with the 2010 ACR criteria to diagnose early rheumatoid so that we can prevent erosions and joint deformities. At 20 years, over 60% of RA patients belong to function class 3 or class 4. Class 4 is bedridden. In these patients, there is increased evidence of infections, cardiovascular morbidity, and lymphomas. Tenosynovitis in rheumatoid. Serial pictures in the same patient, you can see over a period of time how the deformities evolve and the radiological changes. Characteristic joint deformities like Swan neck deformity, Botnius deformity, ulnar drift in rheumatoid hands. What are the investigations we normally ask for? Complete blood picture to see whether the patient has got any anemia and inflammatory markers, rheumatoid factor, CCP, chest X-ray, X-ray of the hands and other affected joints. You can see in this picture severe erosions in poorly controlled rheumatoid arthritis. Rheumatoid vasculitis. Rheumatoid nodules in the lung and pleural effusion also. Whenever you see a case of SLE or rheumatoid with effusions, first think of the primary etiology as a connective tissue disease rather than jumping into things like COX and put them on ATT. Rheumatoid nodules for the elbows. And this patient developed drug rash. The patient was prescribed leflunomide. She developed leflunomide-induced rash. Why I'm showing this picture is some doctors use leflunomide like a painkiller for joint pains. So in this patient, she took leflunomide, developed rash. Never ever give leflunomide for people who are in the reproductive age group because it can be teratogenic. Even if you stop the leflunomide today, it's going to stay in our system for next 3 years. So don't use it in the reproductive age group unless they completed their family. This patient referred to me by Professor Mohandas because the patient has come with joint pains. And he asked me to rule out rheumatoid. Can mimic like inflammatory arthritis. Vasculitis in rheumatoid patient. Vasculitic ulcer in rheumatoid patient. Vasculitic ulcer before treatment. And couple of weeks after started therapy. Sjogren's very neglected disease. Here, if the patient has got Sjogren's, that is Sika symptoms, dry eyes, dry mouth, dry skin, after rheumatoid, we call it as secondary Sjogren's. But if the patient has got Sjogren's symptoms without background autoimmune disease, other autoimmune disease like lupus or RA, it is called primary Sjogren's. Usually, on average, patient comes to us starting the post-lunch session. I think still some of the doctors having their lunch because you're already ready here. First we start with the case presentation, then Dr. Vijay Prasanna will discuss, theoretical part of GOUT. So I request now Dr. D.V. Prasad he's our senior medical officer, sir. Very senior person. He worked in NIMS for many, many years, recently retired, and he wanted to work with us. He joined in our department as a senior medical officer. Earlier he worked in orthopedics, NIMS orthopedics for several years, then rheumatology also. And he's a very good poet. Do you have something on GOUT?
Yeah, of course.
Yeah. Start with your poetry, then the case.
Or whatever. GOUT is the most painful rheumatological condition. So I felt we should write a tribute to the patient who is suffering the pain. Therefore, it appears a little humorous, but and scientific also. So the doubt about GOUT. Why the doubt has arisen is hyperuricemia, whether asymptomatic should be treated or not, till it becomes symptomatic. So like vitamin D deficiency, hypercholesterolemia, similarly should we treat vitamin deficiency, hyperuricemia or not? So the doubt about GOUT, the red hot joint raises a doubt. Is it infection, GOUT or pseudo-GOUT? And whether the hyperuricemic state can itself precipitate crystals of urate. The patient often begins to shout and also begins to wildly toss about and often clutches his foot in vain as his great toe is in great pain. GOUT can be mono or polyarticular, often affecting the first MTP in particular. It isn't due to Viagra or due to pellagra, but it is an episode or a bout of podagra. Hyperuricemic diets, often rich in purine, can precipitate crystals in one's urine, can cause a chronic gouty arthritis for sure, with renal calculi and even a renal failure. Strict diet control with avoidance of alcohol, drugs like analgesics, colchicine or allopurinol, often can be quite soothing and efficacious, unless, of course, the gout becomes tophaceous. Febuxostat is a safer uricosuric agent which can be used even in renal impairment. While renal calculi disappear magically, large tophi need to be excised surgically. The take-home message is gout is like matches ready to set the joints on fire with alcohol providing the fuel. Thank you. Coming to our case, the 51-year-old male patient complaining of intermittent arthritis involving both knees, ankles and first MTP joints is 10 years. Each episode lasting for 10 days with a gap of 1 month. Joint pains increase on consumption of alcohol and non-veg diet, especially red meat. Recently detected to be hypertensive, but she is not a known diabetic. On examination, there are tophi both elbows, right wrist, swelling of the left index PIP joint, tenderness and swelling of both knees and ankles, and tophus with tenderness of the left first MTP joint. His investigations: hemoglobin 14.8, total count 7,400, platelets 2.39, ESR 6, creatinine 1.41, uric acid 10.5, SGPT 35, rheumatoid factor less than 10, negative. So we have X-rays and also clinical photographs of the patient. So otherwise, we can examine the patient. Focus. Chetul చూపట్టండి, చేతులు. Hands. This is also progressive.
There is a mild change in the schedule, as Dr. Divi has covered extensively in his poem regarding the gout. I think I was left with anything to teach you. Only thing I want to show one important case to you. Only slides ఉన్నాయి ఆ పేషెంట్. Please connect to the. We had a typical presentation of gout, and
anything you want to discuss about this?
That I won't tell my students. If you look at this pilot Arachron bursitis, you should think in terms of, see now it's not a typical acute gout where you get MTP joints getting involved, but you see the multiple joints getting involved. So you may confuse maybe to rheumatoid. So in a chronic gout, this is the system. And then you look at this. Now for my BMC students, Bhaskar Medical College, look at this bilateral Arachron bursitis goes in favor of
this colchicine we continue for 3 to 6 months, but this hypouricemic drugs, either an allopurinol or febuxostat, if the patient is not on these drugs previously, these drugs should not be started. If already the patient is on these drugs, we can continue, but if he or she is not on the drugs, we should not start these drugs because they increase the severity of this flare, or they may precipitate a polyarticular if initially the presentation is monoarticular. Once the acute episode settles down, then we'll decrease the dose of NSAID or a steroid, and then we'll add either an allopurinol or a febuxostat depending on the patient's comorbidities.
So you can see this is a polyarticular gout. Because of, the shapes of these nodules, it is gout, but sometimes we do see without this. Like, if you look at this hand, same, symmetrical arthritis. So it is looking like rheumatoid. So polyarticular presentation of the gout. Adi has been suffering for the past 10 years. 10 సంవత్సరాలు బాబు. నీ జబ్బు గురించి నీకేం తెలుసు? ఒక నిమిషంలో చెప్పాలి, స్పీడ్గా, లేట్ అయిపోతుంది.
నాకు 10 సంవత్సరాల కింద నుంచి వచ్చినాయండి ఇది. తర్వాత ఇది చిన్నది వచ్చి పెరుగుతుంది. ఫస్ట్ టైం ఇదండి. ఆ కాడి నుంచి స్టార్టింగ్ అండి ఈ 2 చేతులు. తర్వాత 2015 ఇది మొదలైంది. ఇంకొకటి మళ్ళీ ఇప్పుడు రాజమండ్రి మొత్తం అన్నీ ఉంటాయి, హోమియోకేరీలు ఇవన్నీ వాడానండి. ఆయుర్వేదం కట్టానండి. కీళ్ళ పోతామన్నారు తప్పండి ఏం చెప్పేవారు కదండి. రావులపాలెం వాడానండి, వైజాగ్ వెళ్ళాను, అక్కడికి మా సీట్లు ఉన్నాయి కదండి, అన్నీ వాడానండి. చెప్పలేదండి. మీరు అన్నారు నాకు రాదండి.
So I think this is the second visit to Kim sir. So for the past years he has been suffering without knowing what it is. Taken several treatments including positive homeo. ఏ హోమియో తీసుకున్నా? హోమియో 2 అన్నీ అయిపోయినాయి. So for the young doctors, see, focus here. Actually, among all rheumatological diseases, this has got the best treatment. If you identify early and treat early, you don't see all these problems. Simply tell the patient about the diet and the alcohol and continue the medication. What everybody does is stop the treatment. I think maybe I'm encouraging on to your subject. I think Dr. Prasanna would cover. What's yours?
There are many drugs which increase uric acid.
Yes, yeah. It can be drug induced, but this is not drug induced. I think మీరు cover
regarding the drugs vision. So, pardon?
How long we give this for your allopurinol?
Once you diagnose patient as gout, it is a lifelong treatment. It's a lifelong treatment, but why we have to treat? See, these gouty attacks, they don't persist for years until and unless it is like this polyarticular or a tophaceous gout. So most of these patients, they'll have an episodic type of arthritis. So at that point of time, simple NSAID will cut short the period of arthritis. So from the patient point of view, if you take one NSAID, it's okay. Anyhow, the attack is coming down in 2 days with treatment, or in 2 weeks without treatment. So if the attack is not troublesome, the patient will not take treatment. The second thing is regarding the chronicity of the treatments. So even if there is an indication, like for example other rheumatic diseases, we do insist on a regular follow-up and a good treatment protocol. But these patients, they'll have a poor complex, not all, but a set of patients. So when compared to these patients, these gouty patients are not troubled because of this arthritis over a prolonged period. So they don't want to take the treatment for a prolonged period, because the attacks subside either by treatment, that is by either an NSAID, or without treatment in a prolonged time. So, but we do insist on a lifelong treatment because it is not because for the destruction of the joint, but because of the other systemic effects of this uric acid, which everybody should know. These other systemic effects is either on the cardiac system, is on the renal system, or it is on the vascular system. So because of this extra articular, I can say again, the other system involvement increases the morbidity and the mortality in these patients. Particularly these patients are at risk of developing metabolic syndrome and the associated complications of cardiovascular risk. So because of this, these patients take a lifelong treatment and not because of the arthritis. The second thing is, if the patient doesn't take treatment at the initial manifestations, the other complication could be like this polyarticular and tophaceous gout. When the tophace sets in, it is very difficult to treat these patients. Continuously the tophae act as a nidus, and it will be discharging the uric acid, which crystallizes and again irritate the joint, resulting in arthritis. So this is again like a vicious cycle. So for these two indications, we insist on lifelong treatment. Okay.
There are two issues. One is simple polyarthritis due to the uric acid. Patient improves and prevention. The issue is dysprin.
Dysprin, you say, increases the uric acid levels, and the other things, beta blockers also increases the uric acid levels. So what do you advise, madam? Because nowadays mostly they require beta blockers or the aspirin. What do you advise?
See, most of the times this gout is associated with other comorbidities like diabetes and hypertension. So if the patient has these comorbidities, we select certain types of drugs which has an additional property of increasing the uric acid level in the urine. So these are called uricosuric action. This mechanism is called uricosuric action. So if a patient of gout having hypertension, we prefer to use calcium channel blockers or an ACE inhibitors rather than a Lasix or furosemide group of diuretics. So in the similar way, this again have controlled action on the serum uric acid, and simultaneously the hypertension can be controlled. So in the similar way, if the patient has some comorbidities which warrant the use of some drugs which has an hyperuricemic activity, as far as possible we try to avoid this, but there are many situations where we cannot avoid them. So only serial monitoring of the uric acid and titrating the dose of either an allopurinol or a febuxostat in that condition will follow.
Allopurinol should be given 300 mg per day.
Actually, there are various schools of thoughts regarding the allopurinol dosage. Some say you start with 100 milligrams, gradually escalate to 200, 300, 400. The maximum recommended dose is 800 milligrams.
No, but how do you maintenance for a patient who has no attack?
Maintenance, it's very difficult, sir, because this allopurinol is associated with a hepatotoxicity and severe anaphylactic reaction if the patient doesn't, he had an anaphylactic tendency, genetic tendency for hypersensitivity. So in these patients, you should not hike as rapidly as you can in other patients. And how to suspect this genetic predisposition means, for the initial dose, if the patient has developed a minor itching sensation with allopurinol, that itself indicates that the patient has a risk of developing allopurinol-induced hypersensitivity, because the itching is the initial manifestation where we ignore in the clinical situations. This itching should not be ignored at any cost in these patients.
No, but what dose does it maintain the uric acid level?
Once the uric acid level is attainable, so if the patient has a diabetes or if the patient has other comorbidities and the patient without comorbidities, so the indicated level is the less than 5 milligrams in patient without any comorbidities, and with comorbidities it is less than 3.5.
Is it if the uric acid goes down below 4, if it is 3 or 2, do you stop or not?
No. No, we should not stop.
Because in one of the nephrology meet, the nephrologist said, when there is a CKD and a diabetic and hypertension, and as you said, that it is a only one gouty attack, and he may not get attack again. Do you means he said that after once it goes down, level goes down below 4, better you stop the...
So the situation in CKD patients is different, completely different from the patients who doesn't have CKD. So if a patient with CKD have a hyperuricemia, it doesn't mean that it is equivalent to gout, first thing. The second thing is, in CKD, if the patient's only one attack of arthritis, be it a gout or may not be gout, but you have to prove it. If it is an arthritis, for one attack, we need not treat him. If he having persistently repeated attacks, that too either proven clinically or by laboratory or by imaging, if we prove the diagnosis of gout, he requires treatment despite how low is the uric acid level.
Now, one of my patients, whenever
this is according to the rheumatology guidelines, but I am not sure of the nephrology guidelines.
One of the patients who had whenever he takes some high protein diet, he's a vegetarian. If you give him some milk powder with protein, with the protein powder to increase his protein, he says that I get a pain. Is it a psychological or really it's a possible?
Old schools of thought is like bees, beans, everything like diet which is rich in purine, that is legumes, reasonably legume diet. There has been a lot of research on the legume diet and the precipitation of gouty attack. Initially they thought that the legume intake increased the purine levels and then by uric acid and then precipitation of acute gout. But of late, there is no dietary restriction, for the legumes, only for the legumes. It has been proven that legume intake does not precipitate any gouty flare. It is very clearly proven.
A couple of extension of your remarks. In fact, I have a chapter on gout in the APA textbook of medicine. You can just go through that. The certain practical points are, when a patient is not on allopurinol, that's we call uric lowering therapy, ULT. Nowadays we call ULT. That is uric lowering therapy by allopurinol or febuxostat. We don't combine anyway, both of them. If the patient is not on ULT but develops an attack, do not give the Xyluric or allopurinol or febuxostat during the acute attack. You only precipitate the longevity of the attack. The attack goes long. But if the patient is already on therapy, you continue the same dosage. The mistake most of the doctors do is to add, when a patient gets an acute pain, recurrent pain, add one NSAID, maybe low-dose steroid, and then Xyluric. So if the patient is not having the uric lowering therapy earlier, do not add that time. So when do we add that time? Then once the patient relieves the pain, maybe within a week or so, continue the NSAIDs, maybe lower in dose, then you can add the allopurinol or febuxostat, probably after
9 vertebra and in the left 9th rib, and we have done a CT guided biopsy from this 9th rib. So this biopsy had clearly shown the evidence of gout, that is trophaceous gout. In this you see 2 cases of vasculitis.
Because it comes from the Nalgonda area. The sclerosis is also very common there. That's a very endemic, that area, fluorosis. So have you looked this case in this angle, madam?
Yeah, definitely. We have screened all his bones, forearm bones and all. There is no ligament calcification or any evidence of fluorosis, and the tophi which is there in the tendoachilles, this is that also we have taken an FNAC which is showing a gouty, uric acid crystals.
Sir, about the previous patient, gout, polyarterial gout, he has got a creatinine marginally elevated and GFR was on the lower side. So he is at the verge of developing CKD. But this can be completely reversed by keeping the patient on gout treatment. His creatinine and GFR would be normal again. I missed what Dr. Prasanna has discussed. So in the general practice, what is happening is patients, were told to stop the treatment once they get better after 3 months or so. So never ever stop gout therapy. As per the protocol, either allopurinol or febuxostat, they have to continue. Try to maintain the below 5 uric acid. And we use colchicine as a prophylactic dose. We stopped using it as therapeutic doses because patient is more worried about the dia rather than the joint pain. Because according to the previous textbooks, we use colchicine, titrate the dose till the patient complains of diarrhea. So loose motion is more troublesome than joint pains. So with actually good anti-inflammatory medication, the patient gets good pain relief. So nowadays we are using colchicine as a prophylactic dose for 6 months. Then we stop. But continue either allopurinol or febuxostat lifelong. Never ever stop gout therapy. If you had been on gout treatment from the beginning, you wouldn't have developed all those, deformities and tophaceous gout. So the take-home message from this case is never ever stop gout treatment. And actually, when the patient is on proper gout therapy, we don't worry much about the diet. Especially vegetarian, we don't give much importance to that. But they should, be careful with their drink and also non-veg.
What will we stop?
We tell the patient try to, because there's a very strong link. Thank you, Dr. Datta. We're going to the next session. Which one? Correct.
3 topics. Basically, we got 3 topics.
Yeah, we are covering scleroderma, polymyositis, and Sjogren's and other connective tissue disorders.
Demonstration of the cases that are present. So very quickly we'll go through these 3 things. Each individual topic we can discuss the whole day. That is the big topics. But just for the discussion's sake, we are keeping it very minimal. Like inflammatory myopathies, these are rare disorders, idiopathic inflammatory myopathies. Incidence ranges around from 2.2 to 7.7 cases. These got bimodal distribution, like the first mode is between 10 to 15 years, the other thing happens between 45 to 60 years. Women are more affected in idiopathic type, with the exception of inclusion body myositis, in which men are more affected. And the clinical classification of idiopathic myositis, we can say polymyositis, dermatomyositis, juvenile dermatomyositis, myositis associated with neoplasia, associated with other connective tissue disorder as overlap syndrome, or inclusion body myositis. Quickly, the criteria is basic criteria, as we know, it is the symmetric proximal muscle weakness associated with evidence of muscle biopsy of myositis, elevated with a serum skeletal muscle enzyme CPK or LDH, characteristic electromyographic pattern, and typical rash of dermatomyositis in case of dermatomyositis. So we have got one classification of Bohan and Peter criteria for diagnosis of myositis. They just try to put them in the order, like the same thing, like I said, symmetrical proximal muscle weakness associated with muscle biopsy evidence of myositis, skeletal muscle enzyme increase, characteristics EMG, and typical rash. Depending upon polymyositis, we can say definite if 4 out of all these criteria are classified, if we can find. Probable if any 3 of them are there. Possible, we say when at least 2 criteria are there. In a similar way, dermatomyositis definite is 5 plus any of the 3. So based upon that scoring pattern, we say whether it is a definite, probable, or possible. And the clinical features, like I said, the most important clinical feature that we see is the proximal and symmetrical muscle weakness is a cardinal clinical manifestation of inflammatory myopathies. We got one case which we are going to present where this rule of proximal symmetric muscle weakness may not be there, and that is the reason we wanted to present, because presence of other comorbidities may change this kind of proximal symmetrical muscle weakness. So then also we can the diagnosis will be there. And the pelvic and shoulder girdle musculature are affected most, but weakness of neck muscles, particularly flexors, is also common. Ocular and facial muscles are virtually never involved. Dysphagia may be secondary to esophageal dysfunction or cricopharyngeal obstruction. And the pharyngeal muscle weakness, ultimately it causes dysphonia, difficulty in swallowing. And pulmonary and cardiac manifestations, depending upon the background CTDs, they may precede the onset of muscle weakness, or they may develop at any time during the course of the disease. And the characteristic findings of dermatomyositis, we are going to just go through these Gottron papules. There are 2 features like Gottron papules and Gottron sign, which are nothing but symmetric, lacy, pink or violaceous raised lesions typically found on the dorsal and lateral aspect of the inter-IP joint and MCP joints. We got those features here, like Gottron papules, you can see, and the Gottron sign over the extensor surfaces. Heliotropic rash, which is so typical of the dermatomyositis, demonstrating both erythema, and we must also observe the diffuse periorbital edema that is present associated with that. This is a typical heliotropic rash in a close-up. And V-neck rash in a patient of the point here is that it is a photosensitive nature of the rash that has to be observed. Shawl sign, what do you mean by shawl sign in a patient with dermatomyositis? An erythematous rash across the upper back and extending onto the neck in distribution of where a shawl is worn. Cuticular outgrowth with the periangle erythema and capillary dilatation in patient with dermatomyositis. Mechanic hands, these are the classic features of dermatomyositis that we see. And laboratory findings, we all know the classic classification of we got elevated CPK, but there are certain situations we have to be aware where CPK levels normal CPK levels may be found. Like clinical picture will show us that it is proximal muscle weakness is there, but CPK levels may be normal. In very early in the course of the disease, we may have normal course, or in very advanced cases with severe muscle atrophy, or in myositis associated with malignancy, sometimes proximal muscle weakness will be there, but corresponding CPK levels may not be very much elevated. In dermatomyositis and myositis, sometimes this kind of picture may be there. In inclusion body myositis. Acute phase reactants, CRP, ESR will be elevated, around 50 in 20% of the patients. Certain autoantibodies like these autoantibodies can be present in the idiopathic myositis specific myositis associated autoantibodies like Jo1, SRP, MI2, PMSCL and other antibodies. EMG, what is the role for EMG? Obviously, apart from diagnosis of that, it differentiates between myopathic and neuropathic conditions, and it helps in localizing a neurologic lesion to the central nervous system, spinal anterior, based upon the exact picture. And it also tells the knowledge of distribution and severity of the abnormalities can guide selection of the most appropriate site for biopsy if MRI has not run. So most probably we'll go for an MRI. An MRI will indicate the site of involvement more, and based upon that, specific biopsy will yield a much better result. If that is not there, sometimes EMG may be used. And treatment, very simply, if you have ruled out other comorbid conditions, associated conditions like neoplasia has been ruled out. Ultimately, if it is idiopathic inflammatory myositis, glucocorticoids are the standard first-line therapy. Up to 1 mg per kg we go, either intravenous or divided doses. And then based upon that, there are other medications like glucocorticoid steroid sparing agents like azathioprine, methotrexate, immunoglobulins can be there. These all agents have been used in various studies for the treatment-resistant patients like cyclophosphamide, cyclosporin, tacrolimus, rituximab, underlying conditions, etanercept, infliximab, mycophenolate mofetil, plasmapheresis, or total body irradiation. Thank you. So we got one case of dermatomyositis coming up.
A 39-year-old female patient had complaints of joint pains on and off for past 8 months, rash over the malar region and the periorbital region on and off for 8 months, periorbital puffiness. She had history of fatigue, history of difficulty in getting up from squatting position. At various hospitals, she was given varying doses of steroids for her symptoms. She was a known case of hypothyroidism on regular medication. This was the picture when she had initially come to the department.
Altogether, she is symptomatic. Lights off, please. This lights. She is symptomatic since nearly 7 to 8 months. It's not screen, it's lights. Please switch off the lights and switch on the screen. Initially, she had significant constitutional symptoms. Switch off the lights, please. Stage lights kuda. I want only screen focusing. Rash clear ga kanpishatla. She presented with significant constitutional symptoms. Apart from constitutional symptoms for initial 2 to 3 months, she did not have any other manifestations. Gradually, she had developed photosensitivity in the form. She had developed a reddish rash over the cheeks involving the nasal bridge. This is typically a malar rash description. And gradually, this erythema has extended to both the lower and upper eyelid and onto the forearm. Apart from this, she doesn't have any other clinical history, either in the form of joint pains or difficulty in getting up from squatting or difficulty in getting up from the bed or any history of hair loss or oral ulcers. On examination, she had only this malar rash and next slide, Deepthi, eyes. And this is the initial, if you clearly see, This is a rash which he had, and you can observe some sort of scaling here. This rash is typically called as a heliotrope rash. This is one of the clinical manifestations of dermatomyositis, and this heliotrope rash along with the malar rash, she has been diagnosed as dermatomyositis, but she doesn't have a myositis component of the dermatomyositis. Her proximal muscle power is normal, her CPK, LDH were normal, there is no evidence of muscle involvement in EMG. So she is a case of dermatomyositis, sign myositis, and there is also another variant called as amyopathic dermatomyositis, but as of now I can't label her as amyopathic dermatomyositis because this muscle involvement should not occur for at least 2 years after diagnosing dermatomyositis. So as of now she is a dermatomyositis with sign myositis. Focus to the patient, please. So she was started on 15 milligrams of prednisolone initially elsewhere, and gradually she has been noticing there is gain in weight. Apart from that, there is no other clinical progress of the disease, even after 8 to 9 months of after onset. And she was also off late started with hydroxychloroquine, and she has been with us for the last 1 week, and she had anemia of HB 7.5. The reason for this is iron deficiency anemia, and the cause for this iron deficiency anemia is not related to the clinical picture now. And as of now, you can see that the intensity of the rash, though it is not that severe, but still the erythema is still persisting even after 6 to 8 months after treatment. And now she is receiving only topical steroids with a very low oral dose of prednisolone and hydroxychloroquine. Apart from this, she was also advised regarding the sun protection measures. But this continued and prolonged inflammation that is localized to the malar area, it is at risk of healing with a hyperpigmentation, which may be a permanent hyperpigmentation for her. So she is only a cutaneous, she had only cutaneous features of dermatomyositis without any muscle involvement. To guide him from there is not visible. Next we'll show
focus to the slides.
Narayana. One pediatric case of dermatomyositis. He is Master Narayan. The initial photographs will show you. Deepti.
Ma'am, this is the initial photograph.
You tell the history.
A 10-year-old male patient had had complaints of swelling of the face, predominantly in the periorbital region, pain in the right thigh muscles, and one episode of nasal regurgitation. For 1 month prior to this, he had a history of cold with low-grade fever and photosensitivity. He was treated with various antibiotics. This was a picture of the patient before he had come to KIMS. On clinical examination, the patient was afebrile, vitals were stable, periorbital puffiness was present, erythematous rash over upper eyelids with faint scaling, malar rash, lip excoriation were present. This was the patient when he was referred to the rheumatology department. His palatal movements were normal, and in proximal muscle power, the neck muscles were 3/5, shoulders 2/5, and hips were 2/5. Distal muscle powers were 4+, hand grip and perianal region were normal. Amongst the investigations, his liver enzymes ALT and AST were elevated. CPK was 3,440, and in males, the normal levels are from 52 to 170. LDH levels were elevated, so were serum ferritin levels. MRI of thigh and the abdomen muscles showed multifocal bilateral symmetrical edema of muscles in the lower abdomen, pelvis, and upper thighs. The changes were consistent with myositis.
This patient is with a pediatrician for nearly 3 months before he was referred to a rheumatologist. I have to convince a pediatrician that it is a case of dermatomyositis. That is the reason why I have done a MRI, only to demonstrate the muscle hyperintensities on stir sequences. Apart from this, he is a direct case of juvenile dermatomyositis. The initial pictures which you have seen, he had a classical heliotrope rash, he had a classical periorbital edema and the malar rash along with a proximal muscle weakness. So dermatomyositis is a clinical diagnosis. We need not take any help of the laboratory. But as a workup, we do generally CPK, LDH and ENMG, which all have shown the evidence of myositis, but still the pediatrician is not convinced with a juvenile dermatomyositis, and he was not given steroid for a prolonged period. When we have seen his proximal power is 2/5 with 1 episode of palatal nasal regurgitation, though his palatal reflexes was normal. So 1 episode of nasal regurgitation is very dangerous because there is a chance of choking and sudden deaths in these patients due to aspiration. So these patients, they require an immediate high dose steroid. The dose should be as high as 1 to 2 milligram per kg body weight. So as the pediatrician is not willing and allowing me to start that dose of steroid, I have taken the help of MRI to prove that it is an inflammatory myositis. With only 1 milligram, he had received pulse steroids. Even after first dose of pulse steroid itself, he is able to get up and walk. As the steroid effects, high dose steroid effects lasted for a short time, he was kept on high dose oral steroids for 1 month along with methotrexate, and as of now he is on a tapering dose, I think nearly 5 milligrams of prednisolone and some 15 milligrams of methotrexate, and his proximal power is very well. Narayana, kinda కూర్చొని లేస్తావా? కూర్చొని లేస్తావా? కూర్చో, మొత్తం కూర్చో, మొత్తం కూర్చో, లే. He had initially he had very difficulty in getting even from the bed. So the crux of this case is early intervention. It prevents the irreversible scarring of the muscles, and it also saves the life of the patient.
What is the pediatrician's version?
It's all viral. Pardon? Sir? This, I have seen him in January, sir. Probably next month, I think I'll stop the steroid. Exactly, I didn't remember. 5 milligrams he is on. He's in tapering schedule. In the next 2 months, we'll stop the steroid.
The first case, ANA, DSDNA?
Everything were negative. ANA is negative, so we didn't do a DSDNA.
After that only
So every malar rash is not equal to lupus. That is the other take-home message from this. And ANA is negative. So ANA negative, again, you should think of dermatomyositis. The patient classically presenting with lupus symptoms but persistently ANA negative, you have to think dermatomyositis are you dealing with. Because dermatomyositis and SLE, they have a similar clinical picture most of the times, where there is a clinical diagnostic dilemma. So once ANA is negative, generally we don't do muscle biopsy. The biopsy is indicated only when there is a clinical strong suspicion, but we are not able to prove either in terms of raised muscle enzymes or ENMG or through imaging. In that cases, we do muscle biopsy, but otherwise routine muscle biopsy is not indicated.
Then how you will rule out the previous pediatrician thought that it is a viral fever with myalgias?
So that's what I'm saying. Juvenile dermatomyositis or any dermatomyositis is the diagnosis that is like a spotter. You have to pass the spotter.
Without
lab
rash,
is secondary, sir.
Without rash, without heliotrope rash, only myalgias. It could be still possible.
Yeah, myositis. Myositis can be an initial presentation where you say dermatomyositis, sign dermatitis. That is only myositis can present. Most of the times the presenting feature in nearly, as Dr. Datta has shown in the Bohan-Perita criteria, it is a painless proximal symmetrical weakness. It is a classical presenting feature of this inflammatory myopathies, particularly in dermatomyositis. No, not at all indicated. This ANA profile, myositis profile of late it has become like a fashion to do it, but I personally feel that nothing to do with an ANA profile, because ANA profile we generally don't ask. The profile, the strips, these are very sensitive. That is an operator dependent. If even the technician goes wrong in one step, the whole of the profile picture goes wrong. It will give a false interpretation. So that ANA profile per se, I don't order for any of my patients.
Madam, LFT levels, enzymes,
this SGOT
LDH is also high. So how do you explain all those things?
So these liver enzymes, they also elevate in muscle involvement. So SGOT, SGPT rise in a patient with this clinical setup. Initially, CPK LDH was not done. So when I saw the patient, my suspicion is juvenile myositis, dermatomyositis. And when I am going through the reports, I have found an elevated SGOT, SGPT, again favoring my diagnosis, because these muscle enzymes do elevate, liver enzymes do elevate in the muscle disease, because they have certain types of subtypes, no, SGOT and like CPK only, they are different. This liver enzymes, particularly SGOT, SGPT, they are also elevated in muscle involvement, because muscle also produce this type of enzymes.
Madam, do you observe any quantitative relationship between the very high levels of CPK and clinical?
The only thing is very high levels of CPK indicates the risk. It's not the risk, it's the severity of the disease. Apart from the relation to the severity, apart from this, we don't find any other, like a poor prognostic factor. That's it, sir. Rhabdomyolysis, as of now only I have seen only one patient, but risk is definitely there, but this level of CPK, LDH or SGOT, SGPT will not cause kidney involving rhabdomyolysis. They are very good, sir. Juvenile dermatomyositis, most of the times it goes monocyclic. 60 to 70% monocyclic, even 80% monocyclic. The rest of the 10 to 20%, they'll have a repeatedly episodic flares of the disease, but generally these are monocyclic courses and the prognosis is very good. But the only difficult part in juvenile myositis is the pharyngeal involvement is more severe as compared to the adults. No.
The heart involvement is also sometimes there.
Okay, I'm not sure, sir.
There is. In myositis it is not there.
Okay. Yeah, role of steroids were there, sir. All the three types of idiopathic inflammatory myositis, steroids play a major role. That steroids is very helpful in to tide over this acute crisis. If there are, if there are no questions, we'll move on to the next topic, dermatomyositis. Sorry, sis. Systemic sclerosis is one of the routinely seen connective tissue disease, and this systemic sclerosis, as the name indicates, the skin is very sclerosed. Clinically it is depicted as tight skin. Apart from the skin, there are also other major organ systems involved. That is why it's called as, it's a disorder which involves more than a skin. But there is marked patient to patient variability, either in terms of clinical manifestations or complications associated with this disease. So the hallmarks of systemic sclerosis are inflammation, vasculopathy, autoimmunity, all leading to fibrosis. And ultimately the fibrosis is a major culprit for the worst prognosis in these patients. There are various types of systemic sclerosis. One is diffuse cutaneous, limited cutaneous, and systemic sclerosis, sign scleroderma. This classification is very important, but not in the early stages. Early stages in the sense that if you diagnose a patient with systemic sclerosis on day 1, you cannot categorize this patient as limited or diffuse if the patient has a skin tightness which is restricted proximal to the elbows or distal to the elbows and distal to the knees. Because during, as the time passes, this skin tightness gradually extends. So if you label a patient as limited cutaneous systemic sclerosis on day 1, if the disease onset is less than 2 years, you cannot say the patient will remain limited for next 1 or 2 years, because there is a chance of progression for 3 to 4 years after the disease onset. So again, the broad classification is like a localized systemic sclerosis and a systemic sclerosis. In the localized forms, there are various types of localized scleroderma phenotypes, among which morphea and linear scleroderma, which we see regularly. And among the systemic manifestations, the initial classification is like a limited cutaneous or a diffuse cutaneous with sign scleroderma. So when you call limited cutaneous and when you call diffuse cutaneous, it is very important because there have been a difference in prognosis of these two subsets of patients. See, face is involved in both the types of systemic sclerosis, and for you to say it is a limited, it should be distal to the elbows and distal to the knees. In diffuse, the trunk is involved and the extent of the skin tightening exceeds, it is proximal to the elbows and proximal to the knees. So if a patient have this type of skin involvement with plus minus facial involvement, you can call it as a diffuse cutaneous, and if the patient doesn't have this type, you should call them as a limited cutaneous systemic sclerosis. So the etiology, there are various etiological factors which are thought to play a role in systemic sclerosis, of which genetic susceptibility is considered as a major factor. Apart from that, there are also environmental issues and some infections like Epstein-Barr virus and some chemicals which we use like mercury, arsenic, silica. These are also considered as a culprits in evolution of this disease. So why we have to divide whether the patient is having systemic sclerosis of limited variant or a diffuse variant? Apart from different prognosis which they carry, these two subsets of patients carry, they have some common features, that is Raynaud's, GERD symptoms and skin involvement, along with a significant constitutional symptoms, among which Raynaud's and GERD symptoms, these are the first manifestations to occur. So what is the difference between the limited and diffuse cutaneous form? As I have mentioned, the skin involvement is different, and in limited cutaneous form, the Raynaud's phenomena occurs very early, even 1 decade prior to the onset of skin tightening. And in diffuse form, it's most of the times it is very very early. Immediately after occurrence of Raynaud's, the skin tightness may occur, or they can start simultaneously. And these patients, limited patients, they do not have any tendon friction rubs. These patients have tendon friction rubs. This presence of tendon friction rubs again indicates a poor prognostic factor in these patients. Both these patients test positive for ANA, but the pattern of ANA in limited cutaneous is like an anticentromere pattern, and here you will see a nucleolar type of pattern. And in limited form, renal involvement and the heart involvement is very rare as compared to diffuse involvement, and lung involvement is again less common, and if at all it is involved, it is a very milder form of ILD as compared to diffuse. Limited form, they have an increased incidence of pulmonary arterial hypertension as compared to diffuse cutaneous systemic sclerosis, where ILD is more predominant, and renal crisis is also seen more in these patients. So this, apart from this differences, this limited form, they'll have a very slow progression with a limited skin thickening, which is not so troublesome, with some arthralgias and no significant joint inflammation as compared to diffuse form. And in this diffuse form, as I have mentioned, renal crisis and the involvement of kidney is very high. And these patients test positive for anti-centromere antibody, and these patients test for anti-SCL70 antibody. And among the localized forms, you can see morphia. Morphia is not is a circular or circumscribed or localized area of skin tightening. It can be a generalized morphia or a pansclerotic morphia, and sometimes we can see a linear skin tightening where it is called Encouve de Seber. And these patients, because of the skin tightening and atrophy, they can develop a progressive hemifacial atrophy. And these patients, when they have this progressive hemifacial atrophy, they are also at risk of some neurological complications. There is a variant called as a CREST syndrome, where CREST stands for calcinosis, Raynaud's, esophageal dysfunction in the form of dysmotility, sclerodactyly, and telangiectasia. In this, I want to concentrate on sclerodactyly because sclerodactyly, it means that thickening of the skin over the fingers. But to define it as a sclerodactyly, the extent of skin thickening is very important. If the thickening is distal to MCP, you cannot call it as sclerodactyly. The skin tightening should extend beyond the MCP joints. Only mere presence of skin tightening over the fingers at proximal or DAP joints is not equivalent to systemic sclerodactyly. So among the major, all of the manifestations, Raynaud's is the most common and most troublesome manifestations in these patients. And if not treated, these patients, they go on to develop features of digital ischemia, where there will be a loss of there will be a loss of blood flow to the distal extremities, resulting in pits formation or ulcerations, or it may lead to gangrene and auto amputation of fingers. It can involve any organ of the body, among which skin, musculoskeletal, and GI manifestations are more common. And if you can see a patient of systemic sclerosis, when the patient doesn't have any evidence of skin tightness, you can think of possibility of systemic sclerosis in such patients if you find any shininess of the skin. The typical phenotype looking like a systemic sclerosis, but without any skin tightening. If the patient is having smooth, shiny skin, you can identify, or you can just think of systemic sclerosis in them. Even the skin may be edematous. Tightness, obviously, we cannot miss. And these patients do have some depigmentation, which is called a salt and pepper type of depigmentation, which I'll be showing later. These patients do develop calcinosis, contractures, ulcers, as in other CTDs. And these patients typically have a masked faces, that is, the skin of the face is so tight, nose becomes pinch off, there will be folds in both the frenulum and in the upper lip, the prominence of the front teeth will be there, and the gums may be the same. This is a puckering, we'll call it as a perioral puckering, but most of the times we'll see in the upper lip, resulting in the prominence of the front teeth, which I'll be showing later. And every part of the GIT, starting from the esophagus to the anorectum, is involved. And among the GI manifestations, the most troublesome manifestations is severe GERD. This severe GERD, because of the severe GERD, the patients may do, they do go into a depression. And apart from the proton pump inhibitors, we also have to give them a prokinetic drug. See, you can also see some telangiectasias over the lips. These telangiectasias can occur at any part of the body also. In the cardiac involvement, any layer of the heart can be involved. Most of the times it is clinically silent, or it can present with a conduction disorders, heart failures, or asymptomatic pericardial effusions. In the lung, as you all know, ILD is the most common type of presentations. Apart from ILD, these patients are at risk of development of pneumonias, and these patients do have bronchiectasis, and these patients do have aneurysms of the arteries. And among the renal involvement, most of the times these are asymptomatic, and kidney involvement is very rare in systemic sclerosis. Most of these patients, particularly the patients who were started on steroids, we should have a close watch whether the patient is going for a scleroderma renal crisis or not, because the only indication for steroid usage in these patients is myositis. Apart from myositis, systemic sclerosis patient should not be given any dose of steroid. If the patient has myositis, these patients should be given very high dose of steroids, but with a close monitoring of the renal parameters, blood pressure, etc. And musculoskeletal manifestations are more common, among which arthralgias are very significant, and even arthritis, which is mimicking like a rheumatoid arthritis, is also seen. And because of this arthritis and the skin tightness or sclerodactyly, they will have an impaired hand function. And this skin tightness and arthritis, they also lead to contractures and the associated muscle atrophy. These patients do have puffy fingers at the onset, but puffy fingers again should strike you that whether you are dealing with a mixed connective tissue disease or not. And these patients do have a myositis, which is similar to the myositis in dermatomyositis. These patients have a lot of psychosocial aspects because of the clinical phenotype. They will be very dark in complexion. They'll have a lot of contractures. They'll have skin tightness. They'll have finger deformities. Because of all these issues, they'll have a psychosocial aspects, among which depression is the major cause of suicides in these patients. So this is one patient. In this patient, you can see this is the salt and pepper type of pigmentation which I am seeing. So white areas intermixed with a normal type of skin. This is a salt and pepper pigmentation. Here also in the clavicles you can see. So this is a pinched off faces where there is a prominent and perioral puckering in this patient. You can appreciate the shiny skin of this patient. And this patient have puffy fingers, and one more thing is they'll have a vitiligo-like of depigmentation. You can see sclerodactyly, but I can't say this is a sclerodactyly because the skin is tight only distal to the PIP joints rather than the, proximal to PIP joints. And this patient has significant Raynaud's. Raynaud's in our complexion is very difficult to identify. So if you closely observe, this is a bluish discoloration of all the fingertips in this patient. She is one more patient. At the onset, she had rapidly progressive systemic sclerosis of diffuse cutaneous involvement. After the onset, within three months of disease onset, she had developed as a diffuse cutaneous form. This is again the salt and pepper type of pigmentation in this patient. With this, I'll conclude the clinical aspects of systemic sclerosis. We have only one patient to demonstrate. We'll show all the clinical signs in her. You just demonstrate and
It's a 39-year-old female patient, known case of scleroderma. She had a progressive tightening of the skin for the past 4 months. చేయి చూపించండి. ఎక్కడెక్కడ ఉంది మీకు? చేతులకి ఫేస్. She has skin tightening over the face and over her arms, and she's been also having difficulty in swallowing for the past 4 months with symptoms of GOUT, and she has recurrent episodes of vomiting.
So if you see her from head to toe, this is a frontal regression of the hairline, which we generally see in most of the CTD patients, particularly in systemic sclerosis and in lupus patients. You can also see the hyperpigmentation over the forehead. You can see a pinched off nose. There is a slight perioral puckering of the lower limb, though she doesn't have any prominent front teeth, and you can appreciate the skin tightness. 1 minute, Dipti. See, if I can demonstrate the skin tightness in her, I can just retract the skin up to here. But in this, I cannot even, my finger is just slipping. This is a skin tightness in her. And hands. These patients, they have digital tapering. See, if we observe our fingers, the digits are like a round edge. They'll have a round edge. But these patients do have a pointed digit, like, it's like a pointed digit. If you can see, if finger okat point out cheyagalra, second finger. Itla pedtava poni. See, if you can see, this finger is pointed, unlike the finger of mine, okay? And you can also appreciate the whitish discoloration of the fingertips. Are you able to appreciate? Okay. And here you can see the digital pits. See, these are the digital pits. Dot-like things were there, no? These are the digital pits, this too. Okay, and this is the loss of pulp space. It means that between the nail and the finger, we'll able to feel some place, gap will be there, but that gap will be lost in these patients. She doesn't have any gap. Directly after ending of the nail, her finger tissue has started, so there is no gap in her finger. And this, because of the tightness, these fingers cannot be extended at the PIP joints. And this is a skin tightness. So normally we have to demonstrate skin tightness. If you have to see the skin tightness, you have to see like this. So you can able to pinch a good amount of tissue between the both thumbs. In her, we cannot pinch the skin. So this is a skin tightness which she had. Then she had a very subtle vitiligo-like patches. This one. Okay, sorry. See, very faint vitiligo-like patches in her. This, and this. Okay. The similarly in the legs also she had skin tightness. And you can see this hyperpigmentation over the ear. And very subtle salt and pepper like pigmentation in the ear. Sorry, it's not salt and pepper, it's a ikkadana tella machchalu unnayamma. Okay, she doesn't have any classical salt and pepper like pigmentation here. Here you can see very mild. Okay. And one more clinical thing is, if we ask a patient to retract their neck like this, to completely extend their neck, you cannot find a fold of platysma. Generally, we'll find a fold of platysma here. This will be lost in these patients. Okay? Actually, I'm not aware.
4 years.
4 years.
లేదండి, జాబ్ చేసేదాన్ని. అవునండి.
I think if she had PAH or if she had ILD, and depending on the extent or severity of the ILD, we'll plan her immunosuppression either with a cyclophosphamide or a mycophenolate. For PAH and for this Raynaud's, we can start with the calcium channel blockers and endothelin receptor antagonist or prostaglandin prostacyclin infusion also. But depending on the severity only, we will start prostacyclin infusion. Otherwise, sildenafil or Bosentas. And if she had myositis, definitely she require steroid. And these patients should be counseled for dietary advices. They have to take very less quantity, frequent meals, low fat, low carbohydrate diet. They have to elevate the head end of the bed. They should not lie down for at least 2.5 to 3 hours after food intake. So these are the dietary advices which we have to advise this patient. Apart from this, these patients should also be advised with a cold protection measures. They have to keep their fingers and toes very warm. They have to wear gloves 24 hours. If they have to work in cold water, we insist to do their work in a lukewarm water. There is a role, sir.
Is 36 and CRP is positive. Her Schimmer's test was positive and ANA was 2 plus homogeneous.
We didn't do anti-SSA, SSB in this patient. Cost effectiveness, they couldn't. Lip biopsy was not done because we were thinking secondary Sjogren syndrome, rheumatoid arthritis. She was partially treated, like sometimes steroids, sometimes NSAIDs. We have started on treatment recently, and she's doing fine. 15 days. Yeah, methotrexate we started. No, she didn't have history of parotid swelling so far. It is. But temporomandibular joint involvement is there, inability to move. Swelling typically we didn't have the history so far.
ఫస్ట్ నుంచి నీకున్న ఇబ్బంది అమ్మా
చిగుళ్ళు కిందికి లోపలికి పోయిన కాంతి చిగుళ్ళు
పళ్ళు ఎండిపోవటం
ఆవలిచ్చిన
And typical arthritis in the knees and MCP is there. Yeah, typically parotid extent or extraglandular. Biopsy also, more than the salivary glands of the lip, it will be better to do a parotid biopsy. But only because of the highly invasive nature of that, we generally tend to do it in the inside of the lip, minor salivary glands.
Do you have any role of MRI in parotid gland dryness? Like now we are taking off the muscle biopsy in polymyositis, do MRI and then get away with that. Same way, can we do ultrasonogram or
we
MRI?
are doing ultrasound, sir. Ultrasound parodies we are doing.
So that can give us the without biopsy or without any?
No, it may show, some...
Like atrophy of the acini or blocking of the canal clay?
That is microscopic finding, sir. No, the HRS may show parotid swelling or atrophy, something like that. But we have to have biopsy, I think. But we are going clinically, sir. We don't do biopsy for all patients. The patient has got
I know, yeah. We are going clinically, but here at least you are doing any Schimmer tear test?
Schimmer's test.
We do regularly Schimmer's.
Boston, this patient. 5 millimeters or something like that was there. Severe dryness was there.
We discussed earlier, sir, about Sjogren's. The patient comes to us after 20 years on average. This is the start of symptoms. So if you see any dry eyes, dry mouth, gritty eyes, dry skin, please.
No, in every case of rheumatoid arthritis long-standing, we ask all these features as a routine basis because majority of them are associated with secondary Sjogren's. So elevation of symptoms can be possible only with complete evaluation.
So ANA profile may give us.
ANA profile of late.
Antibodies.
Yeah, yes, sir. But the specificity of majority of the times, what we have recently changed is we are sending ELISA separately, depending upon the ANA pattern. Only those specific antibodies we are sending, sir. Because
what we are doing is we are doing ANA profile where antibodies,
some recent thought like ANA profile itself is not very specific, sensitive.
To stop short of biopsy.
With the extension of the same, quickly I would like to share one of the difficult cases. Again, to tell you that rheumatology is a very dynamic field. This patient, a recent photograph, probably 3-4 months back, but he came to me 7 years back. This is the latest photograph. Case of dermatomyositis. This time, he was on DMARDs, methotrexate, I think he was on 7.5 milligrams and low dose steroid. He had a dental extraction 1 month before he came to me recently. So he stopped steroid and low dose methotrexate and had dental extraction. A month later, he developed a big swelling of the right side of the cheek. So this was not first photograph actually. While he was recovering, we took this photograph. Just observe unilateral swelling of the face. And also an ulcer inside. Mouth ulcer. And the cheek was, the injury was very much. So we didn't know what it was. Okay, initially it was a diagnosed case. I'll show you his earlier pictures. So this was in 2011. He was admitted in general medicine department. He couldn't give a proper history. He came with this kind of swelling of the face. He couldn't open his mouth at all. So initially they thought it was an insect bite and some anaphylactic reaction. When I asked him to open his eyes, this was the maximum he could open his eyes. Beyond that, he couldn't open. So they asked for a rheumatology review. Then we found that he has got high CPK. So this was a case of dermatomyositis. With treatment, he recovered. During the same admission, you can see when I saw him first, then subsequently. Same admission. So just before the discharge. And few months after the discharge. So again, after that he has been coming regularly, but this time again he came with unilateral facial swelling 1 month after dental extraction. So what was the cause? Was it a cellulitis, abscess inside following the dental extraction? Any thoughts on this? Any guess? So we tried several antibiotics because following dental extraction it happened. Hardly he responded. We used to give low dose of steroids because infection might flare up. We did several imaging and nothing helped. So we exhausted with the treatment. So I went back to his previous diagnosis. Just I had put him on a good dose of steroid, methotrexate. He's completely normal now. So dermatomyositis again flared up. Yeah, it is part of the disease because he stopped the medication. Probably it got aggravated following the dental extraction. Also, he stopped the background low dose steroid. Actually, he was not on steroid, if I remember correctly. He was only on 7.5 milligrams of methotrexate because we stopped steroid very long time back. So because he stopped methotrexate, he developed a flare following the dental extraction. So no idea, sir, why. Actually, after admission, he started developing swelling on the other side also, but profoundly on the right side, on the side of dental extraction.
Any addiction he had, good car addiction or something?
Sir? No, sir, no. No, he's a good boy. He's a good boy. He's an engineering graduate. He's an excellent guy. No. No, sir, no. This is all muscles swelling up here. Extensively worked up case. So we couldn't get, we couldn't prove that it was an infection because all the cultures were negative. None of the antibiotics, antifungals helped. Finally, moderate dose of steroids and methotrexate. He's completely back to normal now. Dr. Sarath, next.
For next half an hour, you have to bear with me. I'll start with Sjogren syndrome. That is the end of the session of this CTDs. Next session is novel therapies in rheumatology. Sjogren's, I feel it's a very cool disease because it will not cause much trouble to the patient as compared to other types of connective tissue diseases. Switch on the screen. That's the reason why we couldn't demonstrate any of the clinical signs in these patients, but sometimes we do see patients with some parotid swelling, some arthritis, or a petechial type of skin rash in such patients. I think most of you are aware of this lady. Any guess? Huh? Yes, Venus Williams. She's a person who is suffering with Sjogren's. She also declared that she is suffering from an autoimmune disease. That's the reason why she didn't attend few of the games. So Sjogren's, it's again an It's again an autoimmune disease predominantly affecting exocrine glands, resulting in dry eye and dry mouth. So actually we have two types of Sjogren's. One is primary Sjogren's and one is secondary Sjogren's. The case which we have shown is a secondary Sjogren's. The basic diagnosis in her is rheumatoid arthritis under remission, and later she had developed secondary Sjogren's. So why we call it as a primary and when we call it as a secondary is any Sjogren syndrome associated with another CTD, be it a lupus, be it a rheumatoid, be it a systemic sclerosis, be it a other dermatomyositis or any of the inflammatory myositis, we call it as a secondary Sjogren's. And any Sjogren's which is not associated with other types of CTDs, it is called as a primary Sjogren syndrome. So the major manifestations in these patients are significant fatigue. Sometimes this fatigue is so disabling that they have to quit their work and have to take rest at home. And the next common symptoms are dry eyes and dry mouth. These dry eyes and dry mouth, how the patient tells the history is they feel a sense of grittiness or a foreign body sensation, as Dr. Sarath has said, that isaka in the kallu. So that sort of dry eye feeling, and dry mouth where there is a difficulty in talking continuously, or when there is a difficulty in swallowing dry food like biscuit or bread, there will be difficulty in swallowing. And these patients do present for the first time to the dentist with multiple caries. So when the mouth is dry, there is a risk of bacterial infection to the tooth and decay of the tooth. So because of this clinical symptom, these patients most of the times do present to the dentist. From them we'll get a referral to rule out Sjogren syndrome. So as I have mentioned, the hallmark symptom is dryness of any of the organ which is having this exocrine glands, predominantly in the mouth and in the eyes. Apart from these glandular symptoms, they also have some extra glandular manifestations which are similar to the symptoms present in rheumatoid or in lupus. But the differentiation between the extraglandular manifestations of Sjogren's and the other CTDs is these symptoms are not predominant and not the troublesome symptoms. Like systemic lupus or in rheumatoid, these patients do have all the clinical manifestations apart from xerostomia and xerophthalmia. And predominantly it is a disease of females affected. These females are between the ages of 40 to 60 years, and in children we see this disease very rarely. So what is the cause of Sjogren's? As in other types of autoimmune diseases, we don't have a definite etiology for this Sjogren's. Predominantly it is an autoimmune disorder wherein these lymphocytes, they destroy the exocrine glands, resulting in decreased sensation of these glands, leading to dryness. So what are the exocrine glands we have in our body? Salivary glands, sweat glands, tear glands, and glands within the GI system. So if you see the outlook of Sjogren's, as I have mentioned, this is not a very troublesome disease. Apart from significant fatigue, this disease runs very coolly. The symptoms are very long-standing. These are not very disabling symptoms. Of late, apart from the significant constitutional symptoms, some patients do have a recurrent hypokalemic paralysis, wherein these patients has a sudden onset of quadriparesis. Only with potassium infusion within minutes to hours they regain their power. And rarely we see severe arthritis as a presentation of Sjogren's or as a part of Sjogren's, and major organ involvement is very rare. And other important thing in Sjogren's is these patients are at risk of developing malignancy. So how to diagnose Sjogren's? Because these patients don't have clinical signs, only from the history. But this dry eye and dry mouth are caused by many of the non-rheumatological cases. For example, like drugs. If the patient is on some pregabalin or anything, these drugs do cause dryness, which is as severe as the dryness caused by Sjogren's. So we have to rule out all the non-rheumatological causes causing this dryness to label the patient as Sjogren's. So it is a diagnosis of exclusion, and we can confirm the Sjogren's. If the patient has ocular sicca symptoms predominantly, we can do Schimmer's test. We can also do saliva production test either by a stimulation of the saliva or by salivography. And we do take help of other imaging modalities like high resolution ultrasound and sometimes MRI of the parotids, but we rarely require these high-end diagnostic modalities. Antibodies like ANA, anti-Rho, anti-La antibodies are also seen, but ANA positivity is seen in only 40 to 60% of these patients. So if a patient has a significant clinical symptoms and history suggestive of connective tissue disease, but if a patient has ANA negative, don't consider that this patient might not be having any of the CTT, because a Sjogren's is still a possibility in such patients. So nearly 20 to 40% of these patients can have ANA negativity. Apart from this, anti-Rho SSA or anti-La SSB are also positive, among which anti-La is considered more specific for Sjogren's as compared to other CTDs. So finally, managing this patient is a coordinate approach between rheumatologist, ophthalmologist, and even a dentist, along with a pathologist, because the lip biopsy is very important. Lip biopsy we say, but actually we are doing a minor salivary gland biopsy in the lip. So the word lip biopsy is wrong. It is a minor salivary glands which we take from the lower surface of the inner surface of the lower lip, and this lip biopsy will show the inflammatory infiltrate, predominantly lymphocyte infiltrate. We'll score it as a focus score. That focus score is very significant in diagnosing primary Sjogren syndrome. So this is a case which I saw when I am doing my DM rheumatology in NIMS. So till then I had a good opinion that Sjogren's is very cool disease. It will not cause much harm to the patient. But since then I have seen this patient, my interpretation of Sjogren's is different. So she is a 37-year-old female. She presented initially at 2007 with severe fatigue, sicca symptoms and low-grade fever. She had arthritis of small and large joints of both upper limbs and lower limbs with a prolonged early morning stiffness. And she also had developed erythematous rash all over the face. There is no other positive history associated with these symptoms, and she had a positive rheumatoid factor with ANA showing 4+ core speckle. She had positive anti-Rho anti-La with a negative anticardiolipin antibodies. She had hypokalemia. She had metabolic acidosis. So the clinical suspicion is Sjogren's, and to confirm it, we have done a salivary gland biopsy, and it has evidence of Sjogren syndrome in the form of lymphomononuclear infiltrate in the stroma of the gland. So we have diagnosed as a primary Sjogren's with tubulointerstitial nephritis. Since 2007 till 2011, she is good. Apart from this fatigue, her arthritis has also come down in 3 months after starting therapy. So in 2011, she had developed sudden onset of left foot drop with mononeuritis multiplex as the etiology of this left foot drop. Immediately, she had developed superficial punctate keratitis, which is seen in Sjogren's. In 2012, she has been diagnosed to having pulmonary arterial hypertension. Since then, she used to have occasional URT like cold cough, predominantly which is a dry cough with no fever. So because of increasing the severity of the Sjogren's, we have started her on azathioprine, but she was on this low dose of azathioprine very irregularly. After 1 year, she had developed low-grade fever, sudden onset of shortness of breath, along with cough and hemoptysis for the first time. So during hospital stay, there is no documented fever, but there is a continuation of hemoptysis. There is a decrease in HP. There is a rapid fall in her hemoglobin in the first 3 days of admission with a normal liver and renal functions. Ultrasound is showing a coarse liver echo texture with grade 1 renal parenchymal changes and minimal ascites. Her viral serology was negative. Echo is showing moderate PAH this time with a moderate LVD with a low complements, and cultures were sterile. Her CT chest was showing ground glass opacities in both the lung fields, predominantly in the basal segments. So in the background of hemoptysis, the interpretation of this CT features is diffuse alveolar hemorrhage. So this is a fourth complication which she had nearly 5 years after the onset of the disease. So to confirm this alveolar hemorrhage, we went on for a bronchial wash cytology where we have an evidence of alveolar macrophages laden with hemosiderin, which is considered as a diagnostic feature for alveolar hemorrhage. We have done an AFB screening which was negative, and bronchial wash cultures has grown ESBL E. coli. So we have revised the diagnosis as primary Sjogren's with the tubulointerstitial nephritis, vasculitic manifestations in the form of mononeuritis multiplex presenting as a foot drop, superficial punctate keratitis, moderate PAH, and refractory DAH. We have called it as a refractory DAH because she was given nearly 5 grams of pulse steroids with which her DAH was not controlled and with a lower respiratory tract infection. So we have started her on cyclophosphamide as an immunosuppression along with antibiotics. After control of her DAH, we have discharged her in a stable condition on 1 milligram per kg steroid along with the cotrimoxazole prophylaxis. So on 8th of January, she presented to emergency with a sudden increase in shortness of breath with 1 bout of hemoptysis again and abdominal discomfort with GERD symptoms. This time she had no fever, cough and ongoing hemoptysis presented. And in the background of DAH, we still considered to immunosuppress her with 1 gram of methylprednisolone. Later, she had developed bleeding gums, bleeding PV, ascites, which has progressed from mild to moderate. So there is a serial drop in the hemoglobin with a serial drop in platelets. The lowest platelet count was 50,000. She had transaminitis, she had bilirubin, the highest is 1.6, predominantly direct bilirubin. She had a worsening renal parameters this time. She had an elevated urea and creatinine, progressively worsening renal parameters with an elevated APTT. So we have sent again sepsis is a infection is considered. So cultures were sterile, sputum normal, again high ascitic fluid has shown high SAC, viral serology persistently negative. We have done a splenoportal Doppler which was normal. She persistent to have a low complements. ANCA was done in this case which was negative. She had a persistent positivity of rheumatoid factor with a persistent positivity of anti-Rho. At this point of time, we have suspected cryoglobulinemia and we have taken her sample ourselves and processed it, and we'll take 2 samples. We have to centrifuge it. We have to keep this serum in a refrigerator at minus 8 to 12 degrees centigrade, and we have to keep it for 5 to 7 days before we conclude that the cryoglobulins were negative. So the suspicion for cryoglobulins is because she had a history of MNM in the past, she had a hemoptysis, and all the serology were negative but persistently high titer rheumatoid factor. These are the things which has made us to think a possibility of cryoglobulinemia in this patient. So this patient, this is her serum cryoglobulins. This patient has tested positive for cryoglobulinemia. And upper GI endoscopy, it has shown gastric erosions, and smear for cystocytes which were repeatedly done twice were negative. So the issues which she has is a refractory DAH, transaminitis, renal dysfunction, severe thrombocytopenia, cryoglobulinemia, hypocomplementemia, moderate LVD with a moderate PAH. Unfortunately, we couldn't rescue her. She was on plasmapheresis, but on day 2 of plasmapheresis, she had expired. We have done a post-mortem kidney, liver and spleen biopsy. Her kidney biopsy was showing a thrombotic microangiopathy, though her ACL antibodies and lupus anticoagulant were negative repeatedly in the previous admissions, and evidence of chronic venous congestion in the liver and spleen. So basically the diagnosis is primary Sjogren's, which is complicated by vasculitis, punctate keratitis, PAH, cryoglobulinemia and thrombotic microangiopathy. So this is a very, very rare manifestations of Sjogren syndrome associated with cryoglobulinemia and diffuse alveolar hemorrhage. If you see the respiratory manifestations in Sjogren syndrome, most of the times it is like only a Zika-like symptoms most of the times, but pulmonary hemorrhage is described in Sjogren syndrome. The incidence is less than 1 to 5%. So there are only 4 to 5 reported cases of Sjogren syndrome with diffuse alveolar hemorrhage, but there is no reported case of Sjogren's with cryoglobulinemia with DAH, and ours is a first case with a Sjogren syndrome presenting with cryoglobulinemia and diffuse alveolar hemorrhage, but the only unfortunate thing is we couldn't revive her. Thank you. Pardon, sir? These patients, they have renal tubular acidosis. As a part of this, they'll have this hypokalemia. Pardon, sir? Because initially from 2007 to 2012, we don't have any diagnostic dilemma in her. The symptoms, Zika symptoms with a positive RF, positive ANA, positive Rho, positive La, and
she has current upper respiratory infections, hemoptysis, renal involvement.
Hemoptysis only twice. That is in 2013. That was the first time when she had hemoptysis. Prior to that, everything is fitting in the clinical scenario of Sjogren's. Starting from Zika symptoms to onset of MNM and keratitis, this is all fitting into Sjogren's. But when she had developed this alveolar hemorrhage, that point we are thinking whether we are missing any other disease. Is it a primary or a secondary? That was the reason why we have done an ANCA serology at that point of time. If you are bored of me, I'll just postpone the topic of novel treatments and I'll directly hand over for myths and facts in rheumatology. Sorry, I'll continue. This is a novel treatments in rheumatology. Lights off, please. If you need any break, I can take 2 to 3 questions only and then I'll start the treatment. If not, I'll directly jump into the session. Okay, lights off, please.
We'll give 5 minutes.
I'll complete in 10 minutes, so I don't want to give a break of 5 minutes. Okay, since morning we have been seeing that various kinds of autoimmune diseases, some were being treated by only hydroxychloroquine, some were being treated by methotrexate, low dose, moderate dose to high dose, some receiving a combination therapy. But still there is a subset of patients who are not being completely symptomatically improved even though on this treatment. So there is a scope for a lot of research. What to do in such patients is a major question, major dilemma. So in answering this question, a lot of research have been made targeting the inflammatory cytokines related in the pathogenesis of this individual autoimmune diseases. So how these biologics has evolved, what are the types of novel therapies available in the field of rheumatology, I'll be dealing only under headings. I'm not going to deal with in detail. So these are nothing but a new ways to treat old disease, because these inflammatory cytokines were existent from the time when we started diagnosing these conditions. But the only thing is we have been able to know various other inflammatory, newer inflammatory cytokines, which has led to development of some therapeutics which target these inflammatory cytokines, which are benefiting the patients for their symptomatic improvement, either in the form of symptomatic improvement or by decreasing the associated deformities as in rheumatoid arthritis, or by increasing their survival, mostly in lupus patients or a chronic untreated rheumatoid or a chronic untreated spondyloarthritis group. So where these biologics stands in rheumatology is, most of these biologics were tried in rheumatoid, spondyloarthritis, lupus and juvenile idiopathic arthritis, but of late these biologics also extended their benefit in a major group of diseases called as vasculitis and even autoinflammatory diseases, which are recently coming into the light. There are a lot of autoinflammatory diseases starting from which they have an onset at the age of even when he or she is as a neonate, And in gout also, these biologics like canakinumab is also there is also evidence of these biologic agents in the treatment of gout, though they are not available in India. But before prescribing these biologics, we have to assess the risk-benefit ratio. What is the risk associated with these drugs, and what is the benefit the patient is having if we try these drugs on this patient? And who are the candidates who are supposed to take these drugs is a major dilemma. So when the patient is improving with one DMARD or a combination of two or a combination of three, is there a still indication of addition of the biologics or a replacement of this biologic DMARD with a conventional DMARD is the first dilemma? Or the patient can directly be started with a biologic DMARD, or a patient, after how much time we have to start a biologic DMARD is again a clinical dilemma. Apart from these clinical dilemmas, what are the risks associated with these biologic agents? This is more of a patient-oriented clinical dilemma. Apart from the risk-benefit ratio, cost is another important issue which we have to consider before we start these drugs. But fortunately, most of the companies are coming down with their cost and with the number of offers because as the patient burden is increasing, it is lost to the society and then in turn into our nation also, because these patients, when they are disabled with their arthritis or any form of the severity caused by underlying disease, these patients, they don't attend their occupation, leading to socio-economic burden not only to the family but also to the country. So in such situations, what is the cost-benefit ratio, what is the cost-risk ratio we have to assess before starting this therapy. So as you all know, I cover this biologics in aspects of rheumatoid arthritis because in most of the clinical scenarios we use these biologics for rheumatoid, then spondyloarthritis, and of late we are using for systemic lupus erythematosus or other forms of connective tissue diseases and also vasculitis, but I am retraining this topic only for rheumatoid arthritis. So as you all know, it is a chronic autoimmune disease without a clear etiology, and the pathogenic pathways are multiple. So targeting these pathways is very important in hitting the disease for a benefit to the patient. So if you see the pyramid approach, someone is talking regarding the pyramid approach in the morning. Initially, the treatment is with NSAIDs and steroids. Gradually, these NSAIDs and steroids have changed the treatment pattern to the addition of conventional DMARDs when methotrexate came into the picture. Because with NSAIDs and glucocorticoids, these patients, though they are doing reasonably well symptomatically, but the associated side effects had made the way to create other drugs for treating these patients. So in this way, methotrexate is the first wonder drug which has evolved. After introducing methotrexate, the other congeners like sulfasalazine, leflunomide, hydroxychloroquine came to picture. But as most of the patients, either with a monotherapy or a combination therapy, they are doing well. But there is a set of patients who doesn't do well with this therapy, and hence then came a biologic group of drugs. And even with a biologic group of drugs, there is again a set of patients who are not responding. So recently it has evolved into small molecules. Very recently, one small molecule, which is an oral biologic, came into market. So there have been a growing list of FDA-approved biologics for various rheumatic diseases, but we do give some type of biologics as an off-label indications. For example, like tocilizumab in systemic sclerosis. So why we have to target? What is the pathogenesis? What is the underlying mechanism to target these biologics? To target the cytokine with these biologics. So what happens whenever a cytokine binds with a receptor? It creates an inflammatory response. This is to make a simplification. This is not a book this is not a scientifically given animation. So whenever a cytokine binds to a receptor, it triggers an inflammatory response. This inflammatory response results in tissue damage. So to decrease this tissue response, response, we have to stop the inflammatory response. And how to stop this inflammatory response? We have to hit a cytokine, or we have to hit a receptor, or a receptor cytokine connection. So this is the basis where a biologics has come. So these are, if you see, most of these rheumatic patients, they were being treated with an immunosuppressives, starting from steroids to off-late small molecules. So why we have to immunosuppress them? As you all know, this immune system becomes hyperactive in these patients. They lose discrimination between the self and non-self. So they start destroying their own tissue. So we have to hit this active immune system with some immunosuppression, be it a biologic or be it a conventional DMARD or be it a steroid. So these immunosuppressive drugs play a major role in the treatment of this in the treatment of many of the autoimmune conditions. And these immunosuppressions, they dampen the immune system. That is, they hit both T and B lymphocytes, and they do not permanently correct the fundamental imbalance of immune regulation. That is, they do not have curative potential, because they do not decrease number of T cells, or they do not decrease number of B cells, or they do not have any power to stop the proliferation of autoimmune cells. That is the reason why they do not have any curative potential, and the effect is very short lasting. But these immunosuppressants, when started early in the stage when the disease is active, it is very effective in inducing the remission and also in maintaining remission in these rheumatic diseases. So initially we started with a monotherapy, later a combination of 2 drugs, later a combination of 3 drugs, and later we have gone for biologic DMARDs. So what is the rationale for development of these DMARD therapies? These patients have a favorable clinical outcomes by optimal immunosuppression of synovitis in rheumatoid cases, and they induce remission at a very early stage, and they increase the clinical asymptomatic period and the clinical remission very early, and at the same time they also inhibit the radiographic progression of the diseases. So whom you have to choose? Next question. Which patient is the candidate for either a monotherapy or a combination therapy or a biologic therapy? And if you choose a patient, if you select 10 patients of a similar clinical profile, all these patients do respond in a similar way? No, definitely, because there is a patient-to-patient variability. Because, for example, if you take rheumatoid arthritis, there are a lot of inflammatory markers or inflammatory cytokines which play a role in the pathogenesis. So hitting only one particular inflammatory cytokine, leaving others, is not the efficient way. So this patient variability is because of the predominant inflammatory cytokine that is playing part in particular patient. So all these patients, they do not have a similar response. They have an individual to individual variability. And why this variability is, again, there will be a persistence of immunological memory to our immune system. And this immune system, when it expands enormously, as it's happening in the autoimmune diseases, this persistence of T and B cells, there will be a proliferation of this already stimulated T and B cells in these patients at a higher rate as compared to the patients in whom the T and B cells were not stimulated because of these inflammatory cytokines. So in this regard, the DMARDs which are available here is conventional DMARDs, biologic DMARDs, small molecules, and there are also other new emerging drugs. So among the conventional DMARDs, methotrexate, sulfasalazine, leflunomide, and hydroxychloroquine, among which we prefer methotrexate, and also guidelines prefer methotrexate as the initial drug of treatment in rheumatoid arthritis. Unless and until there is a contraindication for methotrexate, don't go for sulfasalazine and leflunomide. And leflunomide should not be started in a female of childbearing age group. Coming to the biologic DMARDs, we have T cell targeting therapies, B cell targeting therapies, co-stimulatory blockers, and cytokine blockade. T cell targeting therapies, these are again, we have either targeting the T cell or targeting T cell, B cell communicating pathway or the cytokines produced by these cells. So this T cell targeting therapy had not shown any clear benefit in patients as compared to other targeting therapies, and particularly this T cell targeting therapy is mainly in the form of T cell vaccination, which was studied in many of the clinical trials. Coming to the B cell targeted therapy, we have many anti-CD20 antibodies, monoclonal antibodies, among which rituximab is more often used, and other congeners of rituximab is ocrelizumab, ofatumumab, and belimumab. It is the only FDA approved drug for the treatment of lupus, and recently Lymphostat B has also come. And treating the co-stimulatory molecules, see what happens is T cells and B cells talk. They talk through receptors and the ligands. So this CD40 ligand and CD40, T cell receptor with MSC peptide or CD4 or some interleukin receptors. So there is a communication between T cell and B cell. So by targeting these co-stimulatory molecules, we can also inhibit the inflammatory response and thereby inhibit the production of inflammatory cytokines. Then comes targeting the inflammatory cytokines, wherein we have tumor necrosis factor inhibitor, IL-1 inhibitors, and IL-6 inhibitors. So among the TNF inhibitors, we have 5 drugs: infliximab, adalimumab, golimumab, etanercept, and satolizumab, among which the first 4 we routinely use. And targeting the IL-1 inhibitors, we have anakinra, rilonacept, and canakinumab. This anakinra we generally use for systemic onset JA or JA cohorts. Canakinumab is mostly used for gout patients, though we are not using in India. So IL-6 inhibitors, these are the very good drugs with a low side effect profile, among which we have tocilizumab, sarilumab, and secukinumab, clazakizumab, of which we frequently use tocilizumab, which is a human monoclonal antibody. Among the small molecules, of late we have in the market JAK inhibitors, that is tofacitinib. It is the first oral biologic agents. Recently it has come into the market in the month of some August 2016 or August-September 2016. Of late these patients are doing well. The indication for tofacitinib is the patients who have failed to respond on conventional DMARDs with or without biologic DMARDs. These are the candidates for this small molecule therapy. There are also various emerging drugs like granulocyte monocyte colony stimulating factor inhibitors like natalizumab, IL-17, IL-23 inhibitors. Recently we have been treating patients of psoriasis or ankylosing spondylitis patients with this secukinumab. And there are also other drugs like atacicept, and recently in trials we have some molecules which are targeting CD40 and CD40 ligands. And the ultimate goal is to have remission, but clinically the remission is not possible in every case. So in such situations, the goal should be a low disease activity. So once if you are planning to have a remission in a particular patient, particularly in a case of rheumatoid arthritis, you have to hit the target from the onset. If the patient is having very severe disease, you have to use either a combination conventional DMARD with or without a biologic DMARD to attain a goal of remission or low disease activity. So to conclude, pain management in most of the disabling arthritis is very challenging, and targeting the pathogenic mechanism is very important in these patients for good response. And novel therapies are promising in such situations, but they have to be screened for risk-benefit ratio before treating these novel therapies. Thank you.
So if you have energy, I'll make half an hour into 5 minutes. Just myths and facts in rheumatology. Very quickly, I'll try to finish. Tea and samosas are waiting outside, so I don't want to take much of your time. Very important things I'm going to cover. Arthritis, is it hereditary? We have covered this. It is caused by particular types of foods. Except gout, there is no relation between the food and arthritis. People should not exercise with arthritis? No. We encourage all our patients to do regular physical exercise. There is no relation to weather and arthritis. Important point, do not order any laboratory test unless you know why you are ordering it and what you do if it comes back abnormal. We have discussed this in the morning. And ANA, these are the different diseases where you see positive ANA. But be careful, false positive is around 5% in the community. In healthy relatives or lupus patients up to 20%. In elderly false positive it is high up to 20%. And here about ANA, DNA, ANA profile. Some people ask for DNA if they suspect lupus, or some people ask for ANA profile. First, you must ask for ANA immunofluorescence. If it is positive, then only go for further testing of the connective tissue disorders. Like ANA, rheumatoid factor can be false positive. These are the different diseases where you see positive rheumatoid factor. As we grow old, the false positivity is going to be increased. And ASO, all the ASO positive patients have rheumatic fever. It has no relevance in adults. In a child, if you suspect, mostly if it is positive in adult, think of reactive arthritis if the history supports. Otherwise, there's no point in doing ASO titer in adult patients. If in a child ASO positive, don't diagnose unless we fulfill the criteria for modified Jones criteria for acute rheumatic fever. HLA-B27, if it is positive, do we have to call that as angstpon? No, we have to fulfill the criteria for ankylosing spondylitis. So again, rheumatology is all clinical. So if the patient has got inflammatory back pain, sacroiliitis, and they may have peripheral arthritis, then you give weightage to the HLA-B27. And sometimes we get referrals saying that CRP is very high, rule out connective tissue disease. For wrong reasons, we get a referrals. So whenever CRP, ESR is high, CRP can be high also. So they go together. And high ESR, I think everybody knows about this picture. Elderly patient coming with a temporal artery tenderness and this kind of image. High ESR of more than 100 temporal arteritis, which is very rare in Indian subcontinent. And one important point I would like to mention here. Whenever you see high ESR of more than 100, what are the three differential you can think of? Very important. Tell me. Malignancy. Three things: malignancy, COX. These are the first two possibilities, followed by connective tissue disease. The best example is vasculitis. I'll tell you here one example, one live patient who is a very senior doctor now in our hospital. Nearly 1 month history. ESR was 140. started as a ASOM and nostril discharge, pussy nostril discharge, and one episode of post-nostril discharge, bloody in nature. And then he developed other symptoms like fever, bit of weight loss, loss of appetite. In the chest, right lung, some consolidation like picture, bilateral pleural effusions. And PET CT showing uptake in the pancreas, in the spleen, and in the hilum, in the lungs, some tiny nodules in the lung. And he's got neuropathy in both the lower limbs. He is unable to walk properly. He's MON2 negative. And pleural effusion, the Xen expert, AB, everything is negative. What is it? You're right. So ESR very high when you rule out malignancy and infection, give weightage for rheumatic disorders, especially vasculitis. So how do you know somebody's ESR is normal or not? In men, aged by 2, this calculation applies when you don't have a baseline ESR. Because today you see a patient in casualty, his ESR is 50, but we don't have the whole record. So how do you guess whether it's abnormal or normal? So men aged by 2, in women age plus 10 by 2, it gives rough baseline ESR value. High uric acid, is it GOUT? Do not treat asymptomatic hyperuricemia. A normal or low uric acid doesn't rule out GOUT. High uric acid doesn't mean the patient has got GOUT. And GOUT is rare in females because naturally they are protected because of the regular menstruation. Unless the lady is in her menopause, never diagnose GOUT in female patients unless clinically fits into GOUT. Do not blindly order CMRI scans on patients with arthritis unless we got a very clear indication. Steroids, nowadays we don't use too much steroids unless the patient has vasculitis or severe lupus. And you don't see Cushing type of phase in our clinics because we try to use the minimum possible dose and taper and stop later on. Hydroxychloroquine, retinal toxicity, I have never seen hydroxychloroquine-induced retinopathy in my clinic. I must have prescribed thousands by now because the dose we use, around 200 milligrams, very unlikely. So for that we do once in 6 months or once in a year fundal examination. Methotrexate we discussed. Biologics, Dr. Prasanna has discussed. Exercise, I tell all my patients, have good food, good exercise, yoga, and enjoy your life. Finally, SLE and pregnancy, when the patient is in remission, they can plan pregnancy, and we have to monitor them carefully. Thank you very much. So thank you very much for spending your valuable weekend with us. I hope you have learned something new, and also you allowed us to share our experiences with you. And I thank CEO Dr. Bhaskar garu and Chief Guest Dr. Kakal Subbarao garu, Dr. U.R.K. Rao, and all our team, Kim's team, for helping us, including the IT people, cameraman, and all young doctors and senior doctors sitting here. Thank you very much, sir. Thanks a lot. Any suggestions, please give us.
So,
Sir, please have
Very much.
Thank you.
Welcome.